Good morning, everyone. I'm very happy to share my experience with you today about renal denervation. This is not an endovascular case complication, so you can sit back, relax from all the traumatic things we see all day. Enjoy your coffee. And as you've probably heard or seen lately at congresses and in the journal, renal denervation is becoming a hot topic again with a lot of new exciting data regarding the long-term efficacy with the new generation catheter. And I hope I can get you interested today in starting your hypertension and renal denervation program or expanding your own if you already have one. So why should you have a hypertension or renal denervation program? Well, the major reason is the global hypertension control rates are low all over the world. And if we look at this recent study published last summer in The Lancet that looked at the prevalence of hypertension in the world between 1999 and 2019, we can see that all over the world, less than a woman in 4 and a man in 5 are reaching their blood pressure targets. So we still have a lot of work to do. And why are the results so poor? Well, it's not an easy question to answer, but it can come from a lack of interest in the pathology from patients and physicians. Patients usually have few symptoms, and we're dealing with cardiovascular prevention and long-term risk, so it's easy to think that there is time, I will deal with it later. From the physician's point of view, well, let's face it, hypertension is not always as sexy as a valve-in-valve TAVI, and sometimes our attention is taken away by technological innovations. It can also be due to lack of resources and time to screen correctly patients for secondary causes, take the necessary time to educate them, to encourage them to adhere to their medications, and to keep up with innovations and guidelines. Whether we look at patients with uncontrolled hypertension or resistant hypertension, the burden for the physician, especially in private practice, is very heavy. We need to take time to educate them. They often have multiple comorbidities, and it's very hard to keep up with all the innovations, so those patients clearly would benefit from a multidisciplinary approach. And last but not least, as an interventional cardiologist, I want to give my patient the best, and I will get better results if I do the procedure regularly. Whether we look at the characteristics of the patients with resistant hypertension or the causes of secondary hypertension, there's at least 5 different specialties involved in the diagnosis workout. We need the basic lab work for the cardiovascular risk factors and kidney functions, advanced lab work if you're going to screen for pheochromocytoma, hyperaldosteronism, and other secondary causes. We need radiology for the imaging of the kidney, the renal arteries, and the surrenal glands. We need a polygraphy to screen for obstructive sleep apnea, the pneumologist to read the results, the cardiologist to check for left ventricular hypertrophy and heart failure, and last but not least, the rule out of hypertensive retinopathy requires an ophthalmologist. So it takes tremendous work to organize all this, and on top of that, you need to educate your patient about lifestyle changes, diet, medication. It's not easy to do in a 30-minute outpatient consult, and ideally you should be able to repeat it over time to improve adherence. In reality, it is very rarely completed. Therefore, adherence to antihypertensive medication is poor. In a recent paper, multiple trials try and quantify their adherence to antihypertensive drugs using blood and urine samples, and it turned out that almost a patient in 2 are not taking all of their drugs, and 1 in 5 are not taking their drugs at all. So we need to improve that. So instead of having another drug, it would be interesting to have a procedure that could be offered to the patient. And renal denervation, it's not a new concept, it's been running for 30 years, and the purpose is to interrupt the sympathetic neural activity between the brain and the kidneys. Physiologically, the sympathetic nerves connect the brain and the kidneys, and when activated, it increases the release of renin, activates the RAS system, increases sodium retention, and then blood pressure. By shutting down the system, we hope to diminish vascular resistance, cardiac output, and lower blood pressure. With the new generation catheter, we have very good results. This randomized study looked at the efficacy of renal denervation in the presence and absence of meds. So on the left side, you can see here, in the off-med trial, renal denervation was offered to patients that had hypertension but were not taking any drugs yet. And at 3 months, you can see a significant decrease in their systolic blood pressure on the 24-hour blood pressure monitoring and also in the resting office blood pressure. In the on-med trial, they were randomized to a sham procedure or renal denervation on top of their medication, and the results are similar, with a drop of 9 millimeters of mercury on average on the systolic blood pressure. For those of you who do not perform 24-hour blood pressure monitoring, a drop of 10 millimeters of mercury is a big achievement. When you have a hypertensive clinic and you reach such a goal, it's in the outcome studies linked to a reduction in MACE events of close to 30%, and it is rarely achieved with just a drug. So this is very exciting for us at the hypertension clinic because a decrease in 10 millimeters of mercury is a big achievement for our patients. Another way to look at the studies is the results at 3 years. So now we have long-term data that were published 2 months ago, and they're very positive. If we look at the number of patients that are finally reaching their blood pressure targets or that are close to it, we have twice more patients in the renal denervation group versus sham. 83% were finally meeting their blood pressure targets after 3 years. Another interesting aspect of the procedure is the medication burden. On this slide, you see the number of meds that patients take over time. Not only antihypertensive, it's all the drugs they take. It includes their statin, their aspirin, and over time, as cardiovascular events happen, as we're more and more concerned to reach all the goals in cardiovascular prevention, you see an increase in the number of drugs that patients take over time, but it is significantly lower in the renal denervation group. So those results were based on the patients included in the randomized trials, and you may think that, is this really the kind of population I see at my clinic? Well, we also have very similar data in a real-world setting in a very large registry that includes 5,000 consecutive patients that went through renal denervation over the past years. And the results are at 3 years are very similar. They're even better in the office resting blood pressure. You could see a drop, close to 17 millimeters of mercury. And once again, close to 10 on the 24-hour blood pressure monitoring. The safety of the procedure is excellent, whether we look at the short-term vascular complications, bleeding, embolization, no events in any of the groups, no new renal artery stenosis. There is only one reported death 2 years after the procedure in the sham control group, which is kind of expected in this population. And there was one hypertensive crisis and a stroke 400 days after the procedure in the renal denervation group. Regarding renal function, there is no significant difference between the two groups, so we are definitely not jeopardizing the kidney function with the procedure. Given all this data, the European Society of Hypertension posted a position paper last summer, and their statement was that renal denervation expands therapeutic options to address the first objective of hypertension treatment, which is to effectively reduce elevated blood pressure and achieve blood pressure targets. It is evidence-based, it is a safe option for our patient. It is alternative or additive treatment, but definitely not competitive to medication. It should be integrated to a structured pathway for clinical use and individualized treatment strategy through shared decision-making, taking into account our patient's preference. The European Society of Cardiology only stated last year in their recommendation that we should refer resistant hypertensive patients to a specialized center for thorough investigations. So I think now you're pretty much convinced that having a hypertension program is beneficial for everyone. For the patient, they get better information and they can access innovation. It's time saving if they can get all the tests and education done in the same place on the same day, and they get an improved outcome of their pathology. For the physician, it's time saving, and it might cover gaps in resources, especially if you're in private practice and you don't have access to multiple tests easily. As an interventional cardiologist, we improve collaboration with peers and build hypertension expertise, and as well as expand our renal denervation program. Now, before I tell you in detail how we do it at our facility, I have a short video that we show the patients when they come for the hypertension pathway. It summarizes everything, and then I'll guide you through the different steps.
Your physician has diagnosed you with high blood pressure, also called hypertension. High blood pressure or hypertension can damage organs like the retina in your eyes, causing high deficiency, kidney failure, strokes, heart failure, heart attacks, and sexual dysfunctions. This video will introduce the hypertension program you will go through at our hypertension clinic. On your first appointment, you will meet with one of the hypertension specialists from our team. We'll review the history of your problem and schedule further tests. We may have to change your medication. 2 to 6 weeks later, you will be invited to a full hypertension day during which you will go through advanced blood tests, renal artery imaging, heart ultrasound, and other highly specialized investigations. The objective is to rule out diseases that can cause your blood pressure to be hard to control despite several medications. The investigation will start early in the morning and you will be discharged around 4 in the afternoon. It's important that you respect the change in regimen of medication before you come to the outpatient clinic and refrain from eating since midnight the day before. During this day, you will have the opportunity to enroll with the person of your choice in 2 different workshops. One will be a lecture regarding high blood pressure drugs and lifestyle given by certified nurses. It will help you understand your disease better and how the drugs act. The second is a dietary workshop run by dietitians. It will help you reduce the amount of salt you eat daily, since an excess of salt can cause blood pressure to be harder to control. Approximately 2 weeks later, a multidisciplinary meeting involving heart, kidney, and internal medicine specialists will review your case in details. Once we have a good understanding of your situation, we can make concrete propositions to improve your treatment. Options will include an increase or change in drugs, lifestyle modifications, cardiovascular rehabilitation, and renal denervation. During the second and last appointment with our hypertension specialist, you will discuss the results of your tests, ask any leftover questions that you may have. A full report will be sent to your referring physician, who will carry on with your usual follow-up. Renal denervation is a safe and effective way to improve blood pressure control on top of your medication. The intervention is ambulatory, meaning you come early in the morning and leave home in the evening. The procedure will be explained in detail during a pre-interventional consult, and you will be scheduled for a CT scan of your kidney arteries to confirm your anatomical eligibility for the intervention. The procedure requires a local anesthesia in the groin and painkiller or sedative through the veins. An anesthesiologist will be present during the whole intervention to make sure that you do not suffer from discomfort or pain. A general anesthesia is usually unnecessary, and the procedure can be done in an ambulatory fashion, meaning you come early in the morning and go back home in the evening. We use the femoral artery to go up to the kidney arteries. Once a small catheter has been inserted, we inject an iodine-based contrast medium to visualize the anatomy of your arteries. Then we will insert a little electrical wire in the renal arteries to deliver electricity and destroy the nerves around the arteries of the kidney that participate in the rise of your blood pressure. The catheter and the electrical wires are connected to a generator that will deliver electricity, which will rise the temperature on the different 4 electrodes up to 70 degrees Celsius during 1 minute. Step by step, The catheter will be withdrawn in order to treat every segment of the arteries of both kidneys larger than 3 mm in diameter. The duration of the intervention is 1 to 1.5 hours. At the end of the procedure, the small hole in the artery in your groin will be closed by a resorbable collagen device, and a compressive belt will be put around your waist during 4 hours minimum. You will then be transferred to the cardiology unit for surveillance of a minimum of 6 hours. Before you go home, we'll review with you your regimen of drugs. It's important you remember you cannot drive the day of your discharge. The benefits of renal denervation should start about a month after the procedure. We are at your disposal at any time to answer any questions you may have, and wish you already a prompt recovery.
So in a nutshell, this is the program, a quick overview, and now I will show with you in a little bit in detail all the tests we run and how we do it. Our team, as you've seen, is multidisciplinary. It involves all specialties related to hypertension, cardiologists, nephrologists, pneumologists for sleep apnea, internal medicine specialists, dietitians, and trained nurses in education. We are working in collaboration with the University Hospital here, especially with the catecholamine lab specialist and interventional radiologist for the catheterism of cerebral veins when hyperaldosteronism is suspected. Who sends us patients? Mostly general physicians, cardiologists in private practice, and nephrologists. Occasionally, we have a patient sent from the neurologist and the vascular surgeons, and we have made it very easy for them. All they need to do is email us their last consult with the patient, a 24-hour blood pressure monitoring for baseline evaluation, and we schedule all the further workout. They have no paperwork to do. If the patient has normal renal function, he is seen by a cardiologist. If he has even mild renal failure, he is seen by a nephrologist. Most patients referred to us are suffering from resistant or pseudo-resistant hypertension and are taking at least 3 drugs, including a diuretic. We get quite a lot of young patients referred for screening for secondary causes, and more rarely, but more and more, we have patients with labile hypertension, difficulties in adjusting the therapies, and the physicians request our help for educating and trying to adjust the therapies of those patients. Our program, as you've seen, has 4 steps, 2 appointments and a full workout day. The patient has to come 3 times, but in one day he gets all the tests. During the first appointment, we meet the patient and we plan the diagnostic workout. I will go through that in details. Then he comes for the diagnostic test in education. We run the multidisciplinary meeting, and we see him one final time to explain what we have found and what our propositions are before he's referred to his usual physician for the follow-up. The first consult is the biggest one. It takes a lot of time because we fully review the hypertension history, prior treatments, intolerances, comorbidities, complications of hypertension. We scan for obstructive sleep apnea, the take of alcohol, drugs, anti-inflammatory drugs, etc. Physical examination focuses on the screen for aortic coarctation that may have missed before. And if we don't have one, we schedule a baseline 24-hour ABPM. As much as possible, we try and put the patient on neutral treatment for the scan, the rule out of hyperaldosteronism, which means they need a 7-day washout for ACE and ARBs and beta blockers. Only calcium channels blockers, alpha blockers, and moxonidine are tolerated. If the patient is highly unstable with persistent grade 2 or 3 under 4 meds, obviously it is not an option. I will pass this slide. You've seen in the video, it's all the different steps. They do the lab work, radiology, education, and cardiology investigations all in the same day. And in the evening, they go home with their sleep recorder and their bottle for the 24-hour urine sample. The biological tests we run are all the baseline, the usual plasma, sodium, potassium, creatinine, and so on. And we do resting renin and aldosterone, free and total plasma catecholamine in standard measurements, which mean that we put the catheter that's wide enough for the blood draw so they have no pain by the time we draw the blood again, and they rest for 30 minutes, then they walk for 30 minutes, and we do the second round of tests. You've seen patient education in the video, so not much to add. The nurses do a private class of 40 minutes with 3 patients, and they have a take-home brochure, and the dietitians run a workshop where they actually have bags of salt that they have to put on different meals to really get to learn how much salt is in which food. At the multidisciplinary meeting, we really focus on putting a diagnosis, whether it's true resistant hypertension, an excessive salt intake. We really focus on finding a cause of the hypertension and make therapeutic propositions that are concrete. Is it going to be topping the treatment with aldactone? Is it going to be renal denervation, cardiovascular rehabilitation, and so on? And we see the patient a final time to explain it all. And during this consult, it's important that we try and get the feedback on the patient's preference regarding his future. Would he rather have an increase in his drug regimen or go through renal denervation if he has true resistant hypertension? Things that are missing, but that we're hoping to implement within the few next years, is to have the retina scan available on that same day and a regular adherence and e-learning platform to repeat education over time. Now, which patients are best suited for renal denervation? The traditional indications haven't changed. It is truly resistant hypertension with negative screening for secondary causes. And these patients are 90% of the patients that go through renal denervation at our institution. They need to have an eGFR over 30 millimeters per minute, so no severe kidney failure. Now we also have a bunch of newer indications, patients' preference versus an increase of drugs, and patients that have very level HTN. We've had excellent results stabilizing the blood pressure, and when you don't have peaks and huge blood drops, they're much easier to control once they went through renal denervation. For those of you interested in learning more about the procedural aspects, we'll be running a workshop today at 11 a.m. in the auditorium César Roux. I'll still give you a quick hint of how it works if you don't have time to join us this morning for the workshop. It can be done ambulatory. Of course, the patient can stay overnight. It really depends on what kind of sedation you offer. We always do pre-interventional 3D reconstructed aortic CT for 2 reasons. You need to check for polar arteries, as they are surrounded by a lot of sympathetic nerve, and they are a big target for renal denervations, and your results are much better if you denerve those arteries as well. And you need to know in advance the tortuosity so you can choose your guide wire appropriately. Unfortunately, RDN is painful and it requires a deep sedation with high flow cannule. This is the protocol that we use. We mainly use remifentanil and propofol, and on rare occasions, general anesthesia if the patient is at high risk of hypoventilation because of respiratory pathology, obesity, or has addictions that might make him resistant to the painkillers. Renal denervation can only be done through femoral approach. We recommend using an ultrasound guiding femoral artery puncture to reduce access complications. A 6 French Francs is necessary, so it's still a pretty small hole. Standard dose of heparin. There are 2 dedicated catheters. One is a traditional IMA shape, the other one is RDC. The only difference is they are shorter and they're very easy to torque. Since we're going femoral, they are 75 centimeters instead of 1 meter. You use a regular coronary intervention wire. I like to use an extra support wire, especially in high tortuous vessel. And the spiral catheter is extremely trackable. It tracks better than most of the stents we have today, so it's very easy to get to distal branches, including in tortuous vessels. And what you do is you start distally, and then step by step, you're gonna treat the vessel more and more proximately. So it's like in a PCA, you put the guide wire in, you advance the spiral catheter. The difference is you have to retract the wire before you apply electricity. And it runs through the 4 electrodes simultaneously. So it's much quicker than with the old catheter where you had to do it point by point. It's 4 points for each 60-second cycle. After the procedure, the patient lies in bed for 4 hours because of the femoral puncture. We keep them on the intermediate care watch for 6 hours due to the drugs and the risk of vagal reaction and blood pressure drops, and they can be discharged home the same day. We do not do long-term follow-up because that is how we work with the referring physicians. They carry on with the usual follow-up. Of course, we're available for any help they may need. And we perform ABPM 3 months later for the first round of drug adjustments. Our program started in 2016. Unfortunately, you remember COVID, it's there. The hypertension clinic was closed, and I also had maternity leave, which didn't help probably, but now we are good and picking up again. And what's very interesting is initially, peers would essentially refer young patients to screen for secondary causes at the hypertension clinic, probably thinking that anybody can deal with hypertension. And then as they see the good results, they are encouraged to bring more and more patients because they can really see the benefit of such a program to anyone. And we're not just interventional cardiologists with the catheter between our teeth ready to denerve anybody. We're really here to help and improve the outcome of all those patients. How to get started? Well, it depends where you work. I can only talk about my experience. It took roughly 6 months, but I was coming from Paris. I am not originally from here, and I had to get to know the facility, the institutions, how it works. It's important that you set your goals and priorities. Do you only want to deal with resistant hypertension or all kinds of hypertension? And as much as possible, I suggest the latter, because if you want hypertension expertise, you should deal with all kinds of hypertension and get to know how the nephrologist works as well, and we have learned a lot working together for the past 6 years. There's probably are some things that you can already use at your facility. For example, there was already educational SOLT program for heart failure patients, so all we had to do is ask the dietitians to schedule more spots for our patients. You probably don't have to start everything from zero, but more get people to work together, which is probably the hardest part. Once you get an idea of what you need, well, step by step, you organize it. And the most important thing is to set a recurrent multidisciplinary meeting. Otherwise, it never happens. We are all super busy, and if it's not a recurrent meeting, we do it every second Thursday of the month, because that's the morning we don't have TAVIs, for example, and we bring breakfast, so everybody has a nice little moment, and we make it convivial, and people are more willing to come if it's going to be a nice session as well. During the first sessions, I was present at every step. You have to make sure it runs smoothly, and then they can do it without you. And of course, you need to advertise. Regarding visibility, how we do it is we suggest bringing the patient to the hypertensive clinic in all kinds of support. You see STEMI patients all the time. They come in for heart failure and they have uncontrolled high blood pressure. Why don't you suggest that the patient is referred to the hypertension clinic for a thorough investigation? And of course, we inform the medical residents at rotation because they see a lot more patients than we do, and they might be able to pick the ones that are good candidates for the clinic. And you have to educate about renal denervation. There's been a lot of improvement in the technique, in the long-term outcomes, and not everybody knows about it yet. So if you want to recruit patients, call them. Call the physicians and say and explain why you think renal denervation might be a good option for their patient, because of the recent strong evidence on the long-term efficacy, because it's safe, it is not very invasive, and sometimes it's what the patients would rather have than another drug. Thank you very much for your attention. If you have interest in the procedural aspects, I'll see you at the workshop at 11 today. Any questions? Yes.
I think we have some clear understanding of the renal artery denervation, innervation now, sympathetic innervation, Previously, it was considered only the proximal part of the renal artery was innervated with sympathetic nerves. Now we know that all the renal and the polar arteries also are innervated. So are we going to denervate all the renal arteries?
So this is something we can talk about the workshop, but the anatomy has been, our knowledge of anatomy has improved, and it turns out that the sympathetic nerves are much closer to the arterial wall in the distal parts. So if you look at the shadow of the kidney and the parenchyma, you want to hit all segments outside of the parenchyma that are 3 millimeters and bigger, and it turns out the 1.5 centimeter close to the ostial artery. At that point, the nerves are quite far away from the arterial wall, and you're not very efficient. But you want to do all the others, which is why it takes about an hour. It takes 30 minutes per side, even with the 4 electrodes. If you're going to do all segments, you have to be patient if you want to get good long-term results. So, yes.
Sometimes we see patients with renal artery stenosis, mild, not very severe. In those patients, are we can we do this procedure, renal denervation? I mean, patients who have mild to moderate renal artery stenosis.
It's a very good question, and it depends. If it's mild, it is not a problem. We just don't hit the ostium, because anyway, there's not many nerves at that point. For as long as we have, we know that the renal stenosis is not the reason of the hypertension. If it's just 30–40%, especially on one side, it is not the cause of the resistant hypertension, then this is not a contraindication for the procedure. We just don't hit this zone with the catheter. And it's very, very common, especially if you do a 3D aortic CT, you see all the small plaques, and a mild stenosis in patients that have multiple comorbidities is very often found.
Are there any follow-up CT angiograms on these patients? Because we are denervating, does it produce any renal artery problems in the long run?
It was a concern in the first studies, but after 5,000 patients, it never happened, so it is not recommended. It's like you do not perform a coronary angiogram systematically after a PCA. There's no reason why. So far, no recommendations, and we haven't seen any. Our data at the institution is very similar to the one in all the publications, so there's no reason why they should go a systematic angiogram or US Doppler. Anybody from the back?
If it's so effective, like reducing blood pressure by 10 millimeter mercury, why you select patients only with resistant hypertension? Why not take all patients with hypertension? And particularly young patients who would probably would not want to take a lifetime of medications.
Well, we want to do things correctly and make sure it's not a secondary cause, because if you perform renal denervation on a young patient that may have hypoaldosteronism, and you're not treating the...
Not secondary hypertension, essential hypertension.
But we need to prove that it's essential.
Yeah, after proving this essential hypertension, young patients would not be relegated a lifetime of medications. Why not do it in the first instance?
We offer it, but then it's also patient's preference. You've seen now it's about 35 to 40% of our patients who would be keen on the intervention. But some people still rather take a drug, or not take it actually, but to go through an invasive procedure. So it's a patient's preference, and we had a lot of resistance also in the referring physicians, especially at the beginning. They didn't see the benefit of the procedure, and this long-term data at 3 years was just published 2 months ago. So I think that it's going to develop quickly now that we have this solid base with a good hypertension clinic. We have the technique, we are experienced. We're very sure of what we can offer our patients. It might pick up over time. Thank you very much, and have a beautiful day.
So good morning and welcome to this third and last day of this ECC edition 2022, 15th edition, so that means 15 editions. That's a lot. Huh? First of all, I would like to thank on behalf of the whole CHUV team, all the feedback I got from you yesterday. There was a social gathering and many of you spoke to me, but also to the team. And I cannot express how much heartwarming this feedback we get from you on what we do. And what I said to you, this is not our meeting, this is your meeting, or this is our meeting basically. We do it all together. I said to many of you, we just put the frame in place, we just built the structure, but then you have to fill up the house, and the house is filled up with fantastic people that come from all around the world to this little town, but nice town in Switzerland. As you know, the lectures at this meeting are a bit different. And well, we had a great lecture by Bernard de Bruin yesterday, but he immediately said, I'm not going to talk about the thing that you asked me to talk about, Eric, but I get to give you a nice overview of coronary physiology over all these years. Malcolm spoke in 2015 about a subject that I found of utmost importance. And you don't mind, I hope you don't mind, I used your slides at some occasions when I traveled around and showed them to people. And it impacted people, took the message very clear. So you're going to speak about mental and physical health of physicians, but in particular us interventional cardiologists. And you will going to give a kind of updated version this year on the subject. You said that you changed some slides, so we're looking forward to it. We have half an hour for that, so you can take all the time. And I think it's very important also for you to ask questions and to interact. You will probably think that it's only about radiation, but that's much more, and that's what we'll hear from Malcolm right now. I give you this microphone, Malcolm, and the button.
Thank you very much, Eric. Good morning, everyone. Eric, I really don't mind if you've borrowed some of my slides. I think it's such an important message that the more widely this is discussed and distributed, the better. Because I think these are topics that are really, I think we don't pay enough attention to them. So I'm going to start just talking about some of the physical issues of health, and you mentioned radiation. But then Eric had asked me to maybe update the issue about mental health, and particularly during this phase of the pandemic. So just ask yourself, what's the one concern you have when you work in the cath lab in terms of your health? Are you worried about radiation? Are you worried about any orthopedic issues? Or are these the same? And this is an old slide, as you can see. This is from my colleague Rajiv Galati in our cath lab, and he sent this little Twitter survey, and there's a small number of respondents, but you can see there that more than half the people, they're just concerned about their risk of radiation. And I think that we should be concerned. We should be concerned for the effects of radiation on ourselves and on our patients. But with modern equipment, and particularly taking advantage of all of the dosing controls, decreasing frame rates, decreasing the number of times that you're going to be recording data, we should be able to reduce the amount of radiation significantly. And so these are just data from our lab at the Mayo Clinic. You're just showing for the mean patient dose and the physician effective dose, how this decreased over a number of years. And actually, I haven't actually updated this slide, but it's actually got even lower in terms of the effective dose. And I think that we're all aware, we should be aware of how to reduce the amount of radiation to which we're exposed. Standing further behind, you work with a very big fellow and stand behind the big fellow, let them do all of the hard work. And so there are obviously many bells and whistles that if you're not familiar with how to use those, you should be. And so today, the amount of radiation exposure should be significantly less. So this is where all the risk data comes from. It would be disingenuous to say that this is an experiment. This is the only experiment that we really have. These are the data. And you can see here, these are from the Japanese A-bomb survivors. And you look at, and I just particularly want you to take note of the lifetime equivalent doses there in millisieverts. And so we may be up to 100 millisieverts over many years, but the additional fatal cancer risk is less than 1%. I mean, when we think about where we are at, you've got to be over 1,000 before it really becomes significant. And obviously, many of these people did not survive. But where are we? We should be nowhere near that last line there. So that's just something to keep in mind. And don't forget that your lifetime cancer risk is about 20%. That's the baseline before you even step into the cath lab. Now, I'm just going to debunk this study. In fact, it's to me, it's shocking that this was really published as a paper. I think, maybe a letter to the editor or something. But you'll be aware of this about reports of increased number of left-sided brain tumors amongst interventional cardiologists. But as I said, I think we really need to question the validity of this study and the data in it. This was all self-reported, so extremely selective and biased, and there was no control group of non-radiation workers. So let's just think about brain tumors, because we have our protective aprons on, but we don't really have much protection for our head. So sure, radiation therapy can cause brain tumors, but it's meningiomas and it's 2 sieverts. 2 sieverts to be at risk of a meningioma. And fortunately, particularly for interventional cardiologists, we've all got very thick skulls. Maybe thicker among interventional cardiologists than some others, but the weighting factor for the skull, or for the brain, is extremely low in terms of dose attenuation. It's like 10 times, maybe almost 20 times higher for example, for breast tissue. So there's not much gets through the skull. Whoops. And interventional cardiologists, you'll receive about 20 to 30 millisieverts per year with the use of a ceiling screen, so standing behind the screen. So your lifetime exposure, as long as you're paying attention to radiation protection, might approach 1 sievert. So you're a long way off from even having a meningioma. And we've actually studied this. I don't have time to show the studies that we did in terms, we had a anthropomorphic phantom, but the estimate here is that about 120 millisieverts per lifetime to the brain. So it's way below what we would be considering dangerous. And among 10,000 interventional cardiologists, and these are data from our medical physicist who works very closely with us and is very, very interested in this topic, the fatal brain tumors will occur at about 25 just from natural exposure and 4 from occupational exposure. So it's a very, very small number. And in another study, it's estimated that you're going to get about this tiny number of microsieverts per case. You'd have to do over 2 to 3 million cases in your career to be at risk. So I think this is something that has been overplayed. Again, nothing should be ignored, but I think it's really important to understand what the real risk is, compared to what you perceive the risk might be. And protection from radiation literally comes with a heavy health burden. So that's what I'm going to move on to now. So we've talked about perhaps the very, very small risk of cancer. It's extremely small. And then the methods that we go to protect ourselves from that risk, or that perceived risk. And so the old-fashioned lead aprons, some of which are still in use, are extremely heavy. We have lighter protection now. We tend to call them lead aprons, but it's not lead. It's a composite there. So we say lead apron, but it's not lead. But it's still heavy. And you all know that when you take your apron off at the end of a case, it's not something you just swing over your shoulder like a jacket. It is heavy. And so many years ago, as you can see, 1997, Alan Ross was very interested in this. And this was from a survey among orthopedic surgeons, rheumatologists, interventional radiologists, cardiologists. And first coined the term of an interventional disc disease, that it was a real entity. But take notice of the date, 1997. it wasn't until 2015, almost 20 years later, there was any real study of this, any further study. This was a survey conducted through Sky, and you can see there among interventional cardiologists that 25–30% of them were complaining of neck or lower back discomfort that they thought may or may not be related to their occupation. But only 40% actually had no complaints. And in fact, what I've really wanted to do is to get a photograph of all of the people who've worked in the cath lab at Mayo Clinic since I've been there, and just as a cartoon, and just put a little cross or wipe out all the ones who've actually had neck or back problems, who've lost time from work, who've had to have interventions. And it's really significant. And I've been one of the lucky ones, and I think it's just pure luck that I actually haven't had a serious problem. I've had other orthopedic problems, but they're all out on the football field, sorry. We also then did a study about the same time. This is from one of our fellows, published in Jacques back in 2015, a survey of 1,500 workers and employees at Mayo. And we did have a control group versus radiation workers. So you can see that there was an increase of reporting of musculoskeletal pain among radiation workers. So these were some orthopedic surgeons, radiologists, and cardiologists. But it's really difficult, because to really separate out, because low back pain is quite prevalent in our society. In fact, 30% of people will complain of some chronic low back pain. And 80% will have experienced this in their lifetime, even if it's just transient. Chronic low back pain, present in 10%, so that's a pretty high prevalence, and particularly in sort of your middle and later years. In 2012, in the Global Burden of Disease study, it was still in the top 10 of diseases that was a huge burden globally. This was just updated about a year ago, and it was still in that top 10. So it continues to be a problem. So why is this? Well, we talked about the protective apron and the weight that goes on it, but our procedures are increasingly long. There's prolonged standing, and I'll show you some photographs here in a moment, but I often have fellows who are standing there at the front, you've got a hand on the catheter, and then leaning over here to pan, and I say, stop. Why do you have to do that? Why can't you take a few steps back and stand up straight? Or they're looking like this at the screen. At the same time, they've got these heavy aprons on. We have to move our foot to do the recording and panning. The monitor is not always in a direct line of sight. You're sort of having to look around corners there. And of course, muscle tension. So many of us are stressed. And I think I'm one of those. Sometimes I realize that I'm clenching my fists, and I thought I was relaxed, but I'm not. So here are some examples here. So this is one of my colleagues in the cath lab. I took a photograph of her there. And the calculations here that 2,000 kilopascal force on the vertebral discs. I mean, that's when you add the protective apron. And then look at our fellow. I mean, he's actually now a very successful interventional cardiologist down in Texas. But, he's straining his neck like this. This is Sperling's test to diagnose cervical neuropathy. And he's doing this test on himself during the case. What about this structural heart disease, your fellow, very talented, very big, strong Indian gentleman. But look at this, he's looking up at the monitor here. And I did some research on this, just in the literature, and found this article that the force by the head to your cervical disc, number 2, increases with flexion and rapidly increases with extension. So already, just that movement up and down, that you're putting extra force on those discs. So there are things that we should be thinking about, just being relaxed, standing up straight, not bending, twisting, moving ahead in awkward positions. Here are some other examples. This, again, one of our very talented fellows from a number of years ago, even just with the way he's using his hands there and bending over. Again, one of my colleagues, twisting and turning around like this rather than moving around. Who has ever been instructed on this in the cath lab? I certainly wasn't. It's just something I began to observe and was concerned. But I just did this Google search a number of years ago and looking for, safe, workplace safety. And if you go into a factory or even a department store, there are posters up on the wall showing you how you should pick up objects, how you shouldn't bend over, and all these things. When did you last see something like this in the cath lab? So industry is all over this, but we're not. We're way behind this. So the point I want to make here is that we're making all these, adjustments, and we're putting all this, heavy equipment on, but we're not really taking care of our physical health. And it's because of this perceived risk of radiation. And I would argue that we are overemphasizing the risk from radiation and underappreciating the risk to our physical health. A couple of examples here, because yes, it's really good to protect yourself as much as possible, but sometimes there are unintended consequences. This is a painting depicting the Battle of Agincourt. And, okay, this is an Australian, American talking to you about European history, but this was probably the greatest English victory, certainly against France, 1415 in Agincourt. The French force was vastly superior in numbers. They had incredible equipment, but they were weighted down with very heavy armor, extremely heavy armor. But this ended up not being very helpful to them at all, because the English, because this is where the longbow was very effective, but this is a battle that the French should have won. And so there have been some studies here saying that, well, the armor was so heavy, and actually the field was very muddy, that the French were probably already exhausted before the battle even began. So they got sort of stuck down with all this heavy armor and ended up getting destroyed. And as I said, this was one of the greatest victories of England. Now, people have actually then gone and studied this in an exercise lab and actually put armor on their fellows and get them to walk on a treadmill. And it just showed that, again, it would prove that these people would be absolutely exhausted. And of course, these people weren't terribly fit. I mean, they didn't go through exercise training. These were conscripted people from the villages that had to come and fight the English. And they suddenly put all this armor on, and they were just been stuck there, and then they were sitting ducks and were killed. Similar thing in American football. So historically, American football, they did not wear helmets. And the problem there was they had very severe head injuries, particularly fractured skulls. And that's how helmets came into use in American football at the beginning of the 20th century. And it's become very sophisticated in terms of how these helmets are fitted. But I think you all know that, again, an unintended consequence, yes, skull fractures have disappeared, but unfortunately, this risk of chronic traumatic encephalopathy is a real thing. And of course, now people are worried about that with football and rugby and other contact sports. So again, this protection comes at a cost. And just think about the analogy here that I'm describing with what we do in the cath lab. So just to finish here, I'd say that there's a need to look into this. And I think there's just not enough work done here and not enough discussion of this. It comes down to you as the individual, but also your hospital, professional societies, and we need help from industry. There are a number of things that you're probably aware of that that people are trying to sell so you don't have to wear protective aprons and things. And I don't have time to discuss that, but they're not used widely. And again, as I said, we've got to balance this perceived versus real risk with how much you're going to enjoy work and be comfortable at work and take care of your patients. Because if you are sidelined because you've got a bad back and have to go lie flat in your office, or you're going to have to take a few weeks off because you had to have surgery, then the people who suffer, apart from you, are going to be your patients. And so we need to avoid that risk, and we should be able to continue sort of long careers and make them more comfortable. So let's move to mental health issues. And arguably, this is more important. And it's something, again, that I think you've heard a lot about in the last few years. But from a number of surveys, and we were lucky enough that we've got 3 or 4 nationally and internationally recognized researchers in this at Mayo Clinic. And certainly Dr. Schannefeld's name you'll see here crops up over and over again. But it was recognized about 7 or 8 years ago that about half of US physicians suffered burnout. Now, what is burnout? It's not sort of just you're exhausted and tired at the end of the day and, and all you want to do is go home and have a beer and go to bed. But it's a triad of symptoms of emotional exhaustion, a feeling of depersonalization that's then accompanied by a diminished sense of accomplishment. And this leads, as you can see here, to cynicism, inefficiency, demoralization. Unfortunately, this is accompanied probably in about 5 to 6% by suicidal ideation and depression. And this is not reflected in other professional working groups, that physicians are probably at a higher risk of this among professional work groups. I think military personnel also suffer this, but that's probably about the only other group that would have these high numbers here. So this is really very concerning, and it has repercussions. It has repercussions from a personal side of things, as you look on the slide on the left-hand side, whether it's relationships, depression. It's estimated that those who have burnout, about 40% of them may actually meet the definition of clinical depression. And as I said, a small number are at risk of suicide. Your healthcare organization, your hospital, they should have a vested interest in this. They truly should. And the reason is because those who have burnouts are more likely to deliver poorer level of care to their patients. Medical errors are increased. Decreased patient satisfaction, for sure. I mean, it's, an unhappy doctor is going to then end up, and if that's projected into the patient, that the patient's not going to be happy either. Physician turnover is extreme. So again, the healthcare organization, they should have a vested interest in this. Now, this is really sad. So this was from a few years ago, and there was this article that caught my attention in The Guardian. And there was a story of a young doctor who was just so overwhelmed with her work and demoralized that she strongly considered suicide. She didn't. She survived that. But unfortunately, her colleague didn't. And her colleague died from suicide. And the reason I bring this up is because about this time, there were a number of incidents of suicide among some medical students and residents up in Minneapolis at the University of Minnesota, over in Florida at one of our Mayo facilities. And I'm the vice chair of our department, and that week, I had personal knowledge of this because my youngest daughter was a medical student at the University of Minnesota, and the chair of cardiology, his daughter was a medical student in New York, and someone had tragically thrown themselves off a building and had died, all in the period of about a week. So it's estimated that about 400 physicians a year in the United States die by suicide. 400. Now, the population in the United States is very large, but 400 is a big number. And when we think about that fact that as physicians, we think that these are really satisfying and meaningful careers, but we know that we can be stressed. And if you have 400 who die a year, it would take about 2 to 3 average size graduating medical school classes to replace them every year. Think about that. And that's not what graduation of medical students should be when we're looking at numbers. We certainly shouldn't be thinking about how many we're going to then replace of those who've died by suicide. So, interventional cardiologists, you want to see what the data are for interventional cardiologists? There are none. No one studied this in our group. But we are not immune from this. But the potential stresses are all listed here. And you can read these yourself. You know, our job can be stressful at many times. Don't underestimate the stress of being on STEMI call over and over again with the sleep deprivation that comes with. And I've talked to a number of you just in the last day or so about your experiences and being up all night and then having a full list the next day. It can be very stressful. And I think that, you know, we still have to be available to our patients, but I do think we need to make this more civilized. On the other hand, I think interventional cardiology is a fantastic profession. You know, it's gratifying, it's meaningful. Most of the burnout actually is among frontline workers in the emergency department, primary care, family care, ICUs. But they're there, you know, particularly in the office, you know, particularly with electronic health records, but they're sort of interacting with these patients and talking to them and dealing with all their problems and all the documentation. And meanwhile, we're having fun in the cath lab trying to avoid complications and open up arteries and put in new valves. So there are some you know, benefits there. It's fast-paced, and when we talk about STEMI and someone comes in and we know that we've saved many lives. You know, not just you, but it's your team as well. And it's a very satisfying, as I said, meaningful job. So that was the slides that Eric has probably used before, it sounds. COVID-19 upended the healthcare system, there's no question. Here in Europe, in Asia, the United States, many other countries. And the first thing we need to understand is there's no going back to 2019. Time only moves forward. So let's think about the phase that we're in at the moment. So there was an updated survey. This is, I've forgotten how many respondents are here, but this is just published just a few weeks or so ago. And you can see here that emergency medicine, critical care, 60% of these physicians reporting that they're burnt out. Now, whether that's validated or not is unclear. I mean, this is self-reported. But nevertheless, these numbers are alarming. And cardiologists are actually sort of in the middle here. But 42%, that's nothing to be proud of, is it? I mean, it should be single digits. And it hasn't been for a long time. What are the contributors? It's the usual suspects. It's the bureaucratic work, all the paperwork that we have to do, electronic health records, too many hours at work, so many other things here. What about burnout compared to the pandemic quarantine period, you know, in 2020, 2021? And you can see here that roughly half patients say, well, half respondents here say it's worse. What's been the impact on our healthcare workers? Well, as you know, and I'm sure that some of you, unfortunately, have had association with this, and it's been incredibly tragic, but a number of physicians and other healthcare workers, particularly nurses, suffered severe COVID pneumonia and other symptoms, and many died. And actually, this is a number. This was published in The Guardian last year, looking at U.S. healthcare workers who died. Over, well, you can see there, 3,600 odd deaths. 17% of these were physicians. So I think it's just take a moment to reflect on that, because these are tragedies that we never saw coming. As I said, some of you may actually have had personal experience there. Burnout and overwork. This has increased, unfortunately. And I just want to make a point here that the impact on women is much greater than it has been in men. And that's been consistent with all of the recent studies here. And you think about it, it's not just the work that you're struggling with, but it's your family and your other responsibilities. So suddenly everything was upended. If you had children in particular, that was a problem, because childcare is closed. Nannies were not available. And suddenly you had to sort of deal with this. Or if they did have childcare, those were frequently closed because of infections. And so and I heard all about this as one of the leaders in my leadership role in our department, because we would get emails every day saying who was going to be off, and it was a struggle for so many people. And then the concern about well, how much at risk were your kids, particularly really young kids, who maybe just a few weeks old? Or I mean, these were just stresses which we never saw coming. And then all the debate about putting masks on and the kids to go to school. And remember, for a long time, most schools were closed. I mean, there were literally hundreds and hundreds of millions of children across the world who weren't in school. Think about that. I mean, that is probably irreparable. You're never going to come back from that. And these are the people who will be taking all of the professional jobs in the future, and just think how their education has been affected by this. And it has to be in a negative way. It also, particularly in the United States, really exposed the healthcare inequities that we have in our country in terms of access and delivery, and what the mortality was in those patient groups as well as the healthcare workers in those areas. Unfortunately, I don't think Europe was immune to this, but we certainly had a problem in the United States that initially it seemed as though we were in a war together against the virus, but very quickly we became divided. And the polarizing politics, which I do not want to go start the day off talking about politics here, but it really became extreme and very uncomfortable at work. And so suddenly there were people that you thought you could talk to very reasonably, and now that changed. We actually had a number of people who were terminated at Mayo Clinic because they refused to get vaccinated. And that created a lot of issues. Fortunately, it was a very small number. The patients then seemed to be sicker. And as you've seen, the volumes were down, and then they're up, and then they're down, and the concern about delaying health care. But currently, they're really high. I mean, we are extremely busy in our hospital. We're always on triage and surge, and the hospitals around us don't have any beds, and very, very sick patients, the cardiology patients sitting in emergency departments for 24 hours or so waiting for care. Patients and families and visitors, they've been confused by things, but there's no question that they're now, this is a challenge for us. And every day there are issues with visitors, and again, trying to mandate mask wearing. And at our hospital, everyone still has to wear a mask, whether you're a doctor, a nurse, patient, or a visitor. Patients and their families are angry. There are a number of violent issues, even here, even in what we consider to be a safe place at Mayo Clinic, we had workplace violence and had to have security come in. We're now having to secure all of the ICUs, the emergency department, and you have to badge in. So even as a physician, if I don't have my badge, I can't get in there. So I'll just finish here with a couple of things. The Great Resignation. What else is happening here during this, what we call the stabilization phase of the pandemic? So even before COVID came in, there was a projected physician shortfall in the United States, which was just, these numbers are just outrageous. These are conservative. And I thought that over the next 10 years or so, that we would be short of almost 50,000 primary care physicians. A very similar number of specialists. And currently, in the United States, about 1 in 5 physicians is planning on early retirement or resigning this year. 1 in 5. We've never had those numbers before. And we've seen it at Mayo Clinic as well. 16% are looking for another employer because they consider they're overworked, and 12% are looking for another career. And this is so sad when you think about everything that we've all put into to be where we are today, to think that you're going to now retire early or quit your job and look for a job in another career. And we've got an aging workforce. Every day in the United States, there are 10,000 new people signing up for Medicare over the age of 65. 10,000 a day. 2 out of 5 physicians in the United States are over the age of 65. And you combine that with early retirement, you can see where this is going to lead us. It's not just restricted to physicians, nursing staff. We have nursing homes that had to close or severely reduce the number of beds available. And then, of course, that creates a bottleneck in the hospital. You can't dismiss your patients from the hospital. So many nurses are now they've decided they can do travel nursing. The compensation is high, but economically, you can't continue with that model indefinitely. So the so-called gig economy, where you decide, okay, you can quit and you can just go and work wherever you want for a better job. And that has resulted in 3 million open nursing positions as of the beginning of last month in the United States. The daily workplace today, as I said, there's no going back. We're in a phase now of where we should be thinking about where we're going to go in the future. So we had a 2030 plan. There were some positive things came out of the pandemic in terms of virtual health, so, some research, educational issues. But these are things that came upon us more quickly. Working from home, particularly our allied health staff or our administrative staff. Daily staff shortages, I mean, we're faced with this all the time, just this week. We've talked about early retirement, but then there are other things, financial uncertainty, and now you've got this period of inflation and the economy looking very shaky. Supply chain issues, I'm sure you're dealing with that. We can't get this catheter today, we can't get this stent, we can't have contrast. Patient volumes, the severity of the disease, they bring a lot of social baggage in with them here. Hospital security that I've already talked about, and I'm sure you heard the case recently of someone just walking into a hospital in Oklahoma and shooting 2 doctors and an administrative assistant there. So my final slide here, this actually comes from Dr. Jeffrey Staub. He's the chair of psychiatry and psychology at Mayo. And he talks about this as the transition back. And he's given me permission to share this with you. And we can look at 3 groups of people, the worn out but healthy and burned out. And these are the people who are just, they're overworked and they're struggling a bit. The psychiatrically ill, these are the people who are distressed, impaired. They're the ones that are really not coping. For the worn out but healthy, interventions here are various wellness activities, and the goal here is to maintain their morale, and these are the people who have been resilient. The burned out, this is where leadership is needed to really help there, to improve morale and bolster their resilience. The psychiatrically ill, unfortunately, this is a very, very small number at the moment. Obviously, the goal here is to restore their health. So I think, as I said, that the goal here is to understand that we're in a mode of survival. This is not victory, this is survival. And we need to think about now what we're going to be doing in the future. And again, I think leadership is so important here, but just an understanding that, we're not alone, it's other professions as well, but it really hit the healthcare industry very badly. And I think that we need to also recognize that there are impediments. So we have a lot of demoralized healthcare workers. And they're demoralized because they feel as though there's lack of support, that they have lost control, that they're irrelevant. And they're the ones that really, really need our help. So I'm just going to end there. I maybe raise more issues and questions than solutions, but I think that we as physicians and again sort of leaders in our areas, we need to be aware of this and be empathetic to the people around us. I think people are looking for more control over their work and flexibility. Those are probably the key things, and also a recognition that they are valued workers. And those are the 3 points I really want to make to you that I think could be helpful. So thank you very much for your attention and the opportunity to present this again.
Thank you so much, Malcolm. Indeed, this was a very important lecture, and you had to give it. I'm happy that the people can, I'm sure, Oli, I give you the microphone first.
Thank you very much for your brilliant presentation. I just want to go back for how we can support the healthcare worker, like the physician or the nurses. And we have to convince the administration that we have to put a budget for that. And it's very difficult to, ask them for budget to protect the health worker. They need budget for patient because they see directly the gain. But for the physician or the nurse, very difficult. For instance, we try with Eric to implement the robotics, which might be something that protects everybody at the end. And but it's very difficult to, ask the administration that the gain for it's a big budget. It's 1 million to get a robotic, and the gain is not for the patient; it's for the physician first. Even though there is a small gain for the patient. So, how in the Mayo Clinic do you talk with the administration for that kind of budget?
So it's a really good question. And I can tell you that Mayo Clinic, unlike many other healthcare organizations, is physician-led. So our CEO is a physician. And the administrative part is very, very important, but they're to support us. Nevertheless, we still have these challenges. I mean, we still have to prove that we're financially viable. I mean, we're a not-for-profit organization. We put a lot of money into research and education, but it's a real challenge. By the way, we were using robotic, the Corindus system. We don't anymore because we didn't find it terribly helpful. And we still have to have people standing next to the patient. The only person who was able to sit down is the physician. And I have a photograph, but I didn't have time today. Still sitting there wearing the lead apron as he's using the controls. But I think that it's important, and I think that that's the biggest challenge. And so I think that the physicians have got to have a stronger voice. And if they don't, I think these numbers that I'm going to show you will eventually evolve and probably get worse. So that's in terms of the health of our, let's talk about the mental health and all of the demoralization that I was talking about now. We in cardiology, we're having frequent town halls, with Zoom, and so we can have 100, 200, 300 people. They need to understand that we care. And so we would hope that most physicians are going to be very resilient, but there are still people there, as you can see, who are struggling. But anyway, that's how we're trying to tackle it. I'm not saying that we haven't solved the problem, but there's a lot of work to go into it. And unless we address it, it's just going to unravel, and it's just going to be, I think we're going to end up in a very, very poor state of affairs.
Can maybe a comment, Malcolm? At the end of your talk, am I rather more depressed than before, or is there a light at the end of the tunnel? Globally, when I see the figures for the US, and I'm definitely, the nurses here in the room also know that, the nurse in the cath lab, every day there is a shortage. I'm looking at the nursing team over there. Every day somebody of you has an issue, a health issue, and you're struggling with the on-calls, with the same as us. They're on call, they work, do the on-calls, they go on the next day. So at the end, what kind of positive message can we give beside them being empathic, beside them trying to build a team on our lone microcosmos? I'm not sure we can do more.
I think one of the things is that we need to be sure that it's very clear that we're trying to connect with everyone. Yes, there's the empathy, but I think that it's also got to be transparent that we as physicians and leaders, with our administrative staff, that we're trying to do something to get us out of this. And I would be the first to admit that we're a long way, from getting there. But we have to take an active role in this. But we also recognize that some of our peers are also in need of our help. But it's something that, in simple terms, Eric, the supply chain issues, for example. What we don't want to do is be angry and shouting that, we don't have this, why don't we have this, and blaming everyone else around. And I think that we've got to transfer that into some more positive energy, and we've got to come up with solutions. And we just can't sit back and feel depressed and think, just someone else is going to fix it, because no one else is going to fix it at the moment. We have to play an active role in it. But as I said, I don't have easy answers, and I think it's going to be really difficult. I mean, we've got a war here in Europe. We've got a global economy that's a problem, and so much uncertainty. And I guess the other thing too is just recognizing we've had so many people who just feel isolated for so many different reasons. And that's why I think it's really important that we try to connect.
I think we can take one or two questions because there's an important. Yeah, you first. And
I'm hoping more comments than questions.
Thank you very much. It's a wonderful presentation. Just my comment or question is, do you think the financial or the monetary status of the physicians and the paramedics in terms of not only absolute measure, rather relative measures, once we compare ourselves with our colleagues from the college era with average performance and then flourishing into telecom, engineering, and other sectors, and doctors and the paramedics completing trainings in early 40s or late 40s rather now. And by the end of the day, the monetary and the financial status with much increased burden of the work, on-calls, everything, neglecting the family. And would you think increasing the monetary status, especially for the middle grade and the paramedics, is it expected in future, or will it impact or not? A little bit.
I think it's a great observation and question. And it's interesting, so during the pandemic, I think the divide between various employment groups in terms of how much they were making versus people who had higher paying jobs became more and more apparent, and again created friction. But I think that certainly I can tell you at Mayo Clinic there were groups of people that it was very apparent that they're probably not paid as much as they should be, and whether they're paramedics or technicians, in particular technicians. So this really sort of boiled to the top at times. And in fact, we took a pay cut. The physicians at Mayo took a pay cut. So, but anyway, I think that throwing money at this is not going to solve the problem. And certainly we don't need more money. And I would hope that none of us went into this just because of the money. I mean, it helps, as Dr. Kern said yesterday. But I think a lot of our frontline workers, that's why so many of the nurses now, I mean, they're getting paid massive sign-on bonuses to go to work at various places. And as I said, these travel nurses, they'll earn significantly more than their colleagues in the hospitals that they've left.
we probably need to move on very quickly, but yeah, a short question.
Yeah. I enjoyed your talk. A lot of problems which you address, can we have some solutions? I have a lot of my colleagues who have low backache wearing the heavy lead aprons. And recently I was in a live meeting where the physician ingeniously designed an apron which was hanging from the floor.
Yeah, that's the zero gravity.
Yeah, zero gravity. And can the industry take up more of this so that physicians can be spared of the burden of wearing heavy aprons?
Yeah, but the short answer is we need more solutions. I've looked at that zero gravity. I mean, it's a bit awkward and cumbersome. But I think that, and there are many other solutions out there, but they're all a bit clumsy. But as I had in my slide, we need the help from industry as well. So there's a lot more work required, there, and we just haven't had enough of it when we talked about, robotics as well. Thank you so much for your attention this morning.
Thank you, Malcolm. Go for it. So can we ask Michalis, Hamilos, Brahim, and Tito to come down and start the structural session? We're a little bit over time, but we should be fine.
Good morning, everybody. An excellent talk, I think we'll all agree, very important. So we would like to introduce our first presenter. It's Marion Dupré from here at the CHUV in Lausanne. Thank you.
Good morning, everyone. It's my pleasure to present you our clinical case of structural complication from here in Lausanne. So our patient is a 80-year-old gentleman. He called 911 for chest pain. He's known for acute coronary syndrome with stent in distal RCA and for many cardiovascular risk factors and some comorbidities as chronic kidney disease and previous ischemic stroke. He had chest pain at rest since a week, but intermittent, and now permanent since the morning. His ECG show an inferior ST segment elevation, so he was transferred to our center for primary PCI. His coronary angiogram revealed a tight lesion of LAD and an intermediate lesion of circumflex, and an acute occlusion of right coronary artery just up to the previous stent. So we decided to pursue the procedure with RCA PCI with 2 stents and to program the PCI of the LAD and an evaluation of the circumflex by FFR in another procedure during the same hospitalization. Here's the results. He was transferred in cardiac intensive care unit and he reported chest pain resolution. He was stable, but he remains dependent of oxygen 2 liters a minute. ECG after reperfusion revealed sinus rhythm with large first-degree AV block and large Q wave in derivation 3. His echocardiography in CICU revealed preserved ejection fraction, but with septobasal akinesia and inferobasal akinesia. And as you can see, a large ventricular septal defect with left to right shunt with restrictive flow at approximately 4 meters per second. So we had a patient, 80 years old, with comorbidities, with subacute inferior STEMI and a large basal ventricular septal defect. The last European guidelines of STEMI suggest a delayed surgery because the risk of this surgery is very high. And for the percutaneous closure, the role of the percutaneous closure is not very clear, but as mentioned, it might change soon. So for our patient, he was stable, so we decided to not perform any surgery or percutaneous repair at the acute setting. He was monitored and we programmed a cardiac MRI as soon as possible to assess anatomy and flow ratio. Unfortunately, 48 hours after his admission, he arrested. The initial rhythm was ventricular tachycardia and an immediate CPR was started. After 20 minutes of CPR, 3 shocks and 5 milligrams of epinephrine, he had a ROSC and he was transferred to ICU for invasive ventilation. In ICU, he had no recurrence of ventricular arrhythmia, and the TEE confirmed a large septal ventricular basal defect. To improve his hemodynamics, we insert an intra-aortic balloon pump as a bridge to definitive therapy. And with that balloon, we decreased the vasopressor, but weaning was impossible. The sedation was stopped after 20 hours, and the patient woke up with good contact and responses to orders. So now we had the same patient, but with vasopressor and intra-aortic balloon. So we had a second heart team discussion, and we felt that the VASD needed closure as soon as possible. Considering age, comorbidities, and the nature of the intervention, after discussion with the family, we decided to do a percutaneous closure of the VASD with general anesthesia and under TEE guidance. For this procedure, we got 2 peripheral vascular access, one in the right jugular vein and one in the left femoral artery. We chose an Amplatzer septal occluder, and the left atrial disc becomes the left ventricular disc, and the right atrial disc becomes the left ventricular disc. The idea was to insert the septal occluder in the jugular vein. And to get more support, a better support, we decided to do an arteriovenous loop from the left femoral artery to the right jugular vein by the septal defect. With this approach, we need to deploy first the LV disc. So here you can see the ventriculogram at the beginning and the large basal septal ventricular defect. First, we put the advantage guide wire through the VASD, and we did a snaring of the guide wire in the pulmonary artery for its externalization by the right jugular vein access. During the procedure, the Swan's-Ganz catheter was trapped, so we removed it. And during all the procedure, a IR mode catheter preserves the aortic valve. And everything was going well. So now you can see the 12 French introducer through the ventricular septal defect. For the first attempt, after TEE measurement, we choose a septal occluder of 28 millimeters, but we didn't succeed to put the left disc in the right position. So we thought that the system was too small, and we decided to choose a bigger one, but also to do a femoral conversion to maybe have a better angle. So for the second attempt, we did a new arteriovenous loop with a puncture of the right femoral vein, and we choose 34 millimeter septal occluder. And now we had a good result for the left ventricular disc. But unfortunately, it was impossible to deploy the RV disc. So what is going on? Any idea? Maybe too big, or no idea?
I think the chairman need to make some proposals.
Do you have an idea for this?
We can tell you this case was done together, Marion and me. Marion is presenting the case. We also didn't have any idea. So
Is there some mechanical issue with the delivery system or the device? Could there be the release mechanism is not functioning correctly?
Let's see. So the right ventricular disc was trapped in the tricuspid apparatus. So we need to remove the system to make again a new loop out of the tricuspid apparatus, but the occluder doesn't move. Really doesn't move. So we pulled it a lot, and finally we achieved to remove it. But unfortunately, the patient developed a sudden hemodynamic instability, with rapid clinical worsening and significant increase of amine. Here, the TEE control. And what do you see? There is a massive tricuspid regurgitation by laceration of the tricuspid valve. And just after, the patient developed a pericardial effusion with rapid worsening, probably secondary to RV perforation. So he needed pericardial drainage. And the pericardial drainage allowed us to remove large amounts of blood, but he was in refractory cardiogenic shock, and the only option was to do an open cardiac surgery in the table. So we felt that the prognosis of this patient was very poor, so we stopped here resuscitation, and unfortunately, patient passed away in the cath lab. So some take-home messages. Percutaneous closure of ventricular septal defect is an alternative to surgery, but it's a very high-risk procedure in very fragile patients. Here it was maybe a special case because of the location of the septal defect. It was septobasal defect and not apical one. The femoral conversion was probably the wrong choice because the standard approach is the jugular access, and it seemed better to avoid the tricuspid valve apparatus. And after all, there was one solution here. It was to push the entire system into the left ventricular, the left ventricle, to recapture the right and then the left disc in the sheaths, and then take the entire device out. Thank you for your listening.
Thank you, Marion, for this horrible case. Very serious complication. Do you have any remarks or comments?
I think it will be a very good option to do this high-risk procedure under ECMO. You will stabilize the patient, you will have time to bridge to therapy, and you will do this intervention without any stress, without ECMO support.
How to say? I'm not sure. This patient was passing away. It's like the patient we showed yesterday. We have, I would say, not every year, but almost every year, 1 or 2 VSDs. Very rarely they will survive. The tissue is so fragile, and even, you know, mostly we succeed to close them, but then they have multi-organ failure and they have many other issues. It's only those VSDs that don't go into shock, that don't get their lactates up, and that you can remain stable over a few weeks, and then you take them. These are the patients that are good candidates. But we try. You know, it's our mission to try and help patients. This is the first time I personally encountered this complication, and we made a big mistake to convert to femoral, because if you come from jugular, you're much better aligned and you avoid the tricuspid valve. But on the other hand, as you could see, the disc was not aligned at all, because this is a very atypical position of the VSD. They're mostly apical, and they're more easy to tackle. But we wanted to share that with you because we learned from this case. Yeah.
I mean, to gain time under ECMO for 3 weeks, then you do the procedure. Bridge to therapy.
Okay, yeah, I got it wrong. Yeah, maybe, yeah, maybe. Yeah.
So very nice presentation. First case of the day, and a fatality. But I mean, I've never tried this. I'm not a structural interventionalist, but I think just to share the perspective, and I don't know if do we have any cardiac surgeons in the audience, because You showed earlier, I mean, what the mortality is with early surgery. And these basal VSDs are the highest risk. So the surgeons don't like doing it. So even if this patient were 60 years of age, there's a mortality that's still extremely high. And that's why the surgeons are reluctant to do this early on. And if the patient's, in heart failure and in shock, for surgery, I mean, most surgeons, will say, I'm not taking the patient to the operating, it's going to be prohibitive risk. So I think it's just important to put a perspective there. We know that the mortality here is going to be at least 20, 50%.
Surgical mortality is even almost 100%. There was a colleague yesterday who had I don't know if he's here, who had a VSD. It's you? Who was it? Yesterday was a colleague at the cocktail who had a patient. It's you? Oh yeah, it's you. Yeah, sorry. You can tell us your story.
Actually, it's more sad actually because it was a younger patient, like 49 years old, and actually was playing golf, and he presented to the emergency department. I got a call from the colleagues. They treated him like they interpreted like supraventricular tachycardia, because he doesn't have any history before. His heart rate was like 170, something like that. They gave him full dose of adenosine, and they shocked him, and they gave amiodarone, and they called me complaining because they cannot control this fast rate. And actually, when I arrived, it was like sinus tachycardia, 140. So I have to stop everything. There was murmur. We found this same shape of VSD. I can forgive them about overlooking this diagnosis of inferior infarction, because actually it was very rapid and the QRS complex was very small, and there is very subtle ST elevation, and the Q was very small also. The patient was really in cardiogenic shock. First ABG like 7 point, and the VH is like 7.19. And the lactate creeping high, like suddenly. Unfortunately, I mean, we don't have on-site surgeon, so I have to move him quickly to a tertiary center. So they put the intra-aortic balloon, and also they shooted his coronaries. He had 3 vessel disease, and they stented the RCA, but the surgeon for sure was reluctant to take the patient. And still reluctant. The ECMO team also, they were reluctant to put him in ECMO. He was on high dose of noradrenaline. It's getting worse, and sadly he died at the end.
So this is just a testimony of a young patient that has an ASD in the UK, and that the surgeon refused to operate.
I don't understand. I mean, I'm not a surgeon, but we know if we don't do anything for this patient, he will die. Definitely he will die. So wasn't worthy to take the patient even with 80% risk of this? It's better than like 0%. I don't know.
Thank you. I mean, it's a very interesting case. I think it shows that we're all trying our best to treat patients in potentially impossible situations. I think there were some learning points which you've all emphasized. Shall we move to the next case you want to introduce?
Okay, thank you.
Thank you very much. It was a great case. So the next, we thank the organizing committee for being here and giving us the opportunity to present our case from Heraklion. Thank you, Eric and Olivier. And this is a complication we did together with Dr. Petousis, but I'm not brave enough to present it. So I asked him to do for me.
Is it working? Yes. Dear colleagues, good morning to all. I want to thank the organized committee for this honor. So we're going to present a 45-year-old female patient with a BMI of 29.5. He had a medical history of cryptogenic stroke, and brain MRI showed chronic ischemic injuries at the frontoparietal region and a more recent lesion at the left occipital region. So after a series of exams and tests, we found an aneurysmatic atrial septum, and a large tunnel-shaped PFO of about 17 millimeters, and a positive bubble test. So we decided to proceed to occlusion. We had our T images, echo images. And we chose the 25 millimeter cardioform Gore septal occluder. I think the videos are not. Maybe you can give him some help with the videos, please. Does not play.
Does anybody have any comments about the choice of the 25 millimeter occluder for this aneurysmatic and long tunnel PFO?
To go back.
Are you able to help play the videos, please?
The videos is difficult.
Thank you.
So the tunnel was 16?
17.
17.
You can see it here. But unfortunately, the videos are not playing in the next steps.
I have a comment. The fact is the tunnel is really long and you have a large aneurysm. So to choose the right size, you have to take into account the fact that the tunnel is very long and the Asia is very large. So I would say that 25 is the inferior limit, I would say.
We can take you to our department as a consultant.
And also the distance to the aortic annulus. It's very important.
Yes, you're right. You're right. We control it with T images, but we cannot see here, unfortunately.
Yeah.
Perhaps you can do the video.
You give it to. It's an important step for the presentation, I think.
And what was the length of the septum, of the atrial septum?
17. Of the septum.
tunnel, okay, but of the septum.
Take some time to give the videos, but what we wanted to show here is the placement of the
Can please use the microphone, Michalis?
Is the placement of the PFO device and the TE echo that shows that there is a capture of the two parts of the ASD. But it's moving. It was moving a lot.
Yes.
So that's the idea of showing those two images.
No, we need. Don't worry. We have time. We'll have to see the pictures otherwise. Okay. But in the meantime, we can discuss because PFO closure is considered a very simple procedure. You agree, Malcolm? But it's delicate. I always say that to the patient because, of course, while you work on this, can we just look at the video while we are waiting you for just the video of the
run off the presentation so they can put the...
Can we see the first video, please?
Just while waiting, yeah.
So can I...
here they are.
Ah. I think you just need to wait and be patient.
So we have this fluoroscopic image and the video of the T is not playing.
I think if you just click it with the mouse there, like that.
It should work.
It should work. You have to do it from the computer up there. Can you hit play?
So can I, while we're waiting for the videos to run, can I ask what sort of tips and techniques do you use to help choose your device and the size of device? And do you plan that beforehand or do you do it ad hoc as you're carrying out the procedure? Because it seems to be this is possibly key to this
yes, indeed.
Presentation.
Usually in these cases we use the 25 occluder as a default device and we control it simultaneously with a TE echo to see if the margins fit if we don't reach the aortic. And this is the default strategy that we make. In this case, we thought that we're just fine. The left disc had resistance when we pulled back the catheter, and we started to open the right disc. Hi, is okay?
I think it will play now.
Okay.
The thing is that, as you already commented, this is considered to be a simple procedure.
Here we are.
And sometimes the thought and the planning behind this procedure is not so meticulous. So this can cause some problems,
yes,
as you are going to see now.
The devil is in the details often. So after these images, we're ready to release the device. If we have to make some technical consideration at this point, if you notice something that would be preoccupied for you.
Olivier, is it okay for you?
I'm not sure to get the right picture here. It's a bit cloudy for me.
Not so, but that was the picture we had.
Yeah. So I'm looking forward to see the.
So we blame the echo guy.
I think Jacques wants to make a comment. He's the next presenter.
Yeah, well, I have the same problem with you.
So
the next presentation is the same.
Yeah.
So I think maybe the left disc doesn't look really well opposed, and maybe it's in the right atrium from this image on the echo.
Okay.
You see the left disc? Maybe it doesn't look like above the septum.
So you said it's below.
It's below
the right,
for me.
Yes, yes.
Like this.
So we're good. We thought that we're good.
Can I use the laser? So I'm going to explain for the people who are not used. This is the septum secundum somewhere over there. Septum primum is over there. This is the left disc. And basically what we see is that the superior right is already pointing leftwards. So something will happen.
It's a complication course, so something will happen.
I have also to add that it was our first implantation with this cardioform. We used to implant the Auslender, so we were more concentrated to the system.
To the release.
And probably not to the images.
So we thought that we're okay. We made a confirmed position with T images. We made the test of the resistance of fully banked the catheter, and then we release it. And oops. It's, as you can see, it's migrated. It's passed through the valves. And it fell right away. And finally, it was stuck in the abdominal aorta. So what is the thing to do next? Would you call a vascular surgeon to save the day? Would you call an interventional radiologist to help you? Would you try it to yourself to remove it?
In the audience, any idea?
You took all my questions. It's not fair. I would go for percutaneous retrieval for sure, because it's in the aorta and not in the heart.
So that was the idea. We also called back an interventional radiologist for backup as a consultant. So we put a large sheath in the right femoral artery, and then we used a snare. After 2 or 3 attempts, we understood that the thing to do is to catch the device from this or from this eyelet in order to deform and enter the sheath. In another way, it would be or traumatize in a very hard way the artery, or it would be impossible to get out. So after 2 or 3 attempts, we we realized that we have to catch it from here or here, one or over the two islets. The videos are not played again, okay.
Okay, and what was your feeling at this time?
The first feeling was we have some palpitations, maybe more and more, but and we have also more palpitations when we could not retrieve the device into the sheath. But after the third or fourth attempt, where kiwed, we put the device into the sheath. We had no vascular complications.
I think in these cases, it's important that we were lucky enough that the device passed through the cardiac valves.
Yes, indeed.
And was in the abdominal aorta. Since it is in the abdominal aorta, then you have some solutions to provide.
A little of luck helps every time. So we proceed, we put a bigger device that was implanted successfully.
So I think it's very important for the audience that you show maybe with the laser that this time the device is nicely setting on both sides of the septum.
Yes, we see.
You see towards the aorta, it's open.
We see here the left
so
disc,
this is a perfect
the right disc
position.
You can see if the videos. Yes. We see also the big excursion because of the tunnel. The discs are not very close enough. We control it with a new contrast injection. And we have to say 2 words that this kind of complication is not very, very often, 0.5% to 0.7%. The major causes is aneurysmatic PFO with a large tunnel. We had both. And often, in these cases, you undersize the device. And the last thing to say that many times, even if a procedure is very simple, it appears very simple. And if you made it many times in the past, the details, the devil is in the details. Probably during the release, just before the release, the disc prolapsed into the left atrium, and then it flied away. Fortunately, we had a very happy end.
Thank you very much. Any burning question in the audience?
There is another method to retrieve this device. You can wire this device with a coronary wire, then you push a balloon, you inflate your balloon, and you can retrieve this device.
It is an interesting option, but with this method, probably would not enter into the sheath. The key point, in order to take it atraumatically, is to catch the device from the eyelets in order to deform and enter homogeneously into the sheath. But thank you for your...
It's a good proposal, but it's impossible. No, not with the gore. Did you do it with the gore? Not with gore, it's not possible. I can tell you, it's too solid. It's it's gore, it's Gore-Tex. And Gore-Tex is impermeable. What's that?
Polytetrafluoroethylene, expanded polytetrafluoroethylene.
You cannot penetrate it, yeah.
But you cannot, it's like a sponge with little holes. Indeed, you cannot penetrate it.
Okay, perfect. So let's move to...
Thank you all.
Presentation. Thank you. So now this is Jacques Auslender from Belgium with another PFO case.
Okay, good morning, everybody. It's a pleasure for me to be here, and thank you for the invitation. My name is Jacques Auslender. I'm an interventional cardiologist at Jolimont Hospital La Louvière in Belgium. And without any further delay, I will start with my case, which is not surprising that it's a PFO embolization. So it's a 47-year-old female who has only hypertension as risk factor. She's on aspirin and ACE inhibitor. Here the difference with the other case is that she had a central retinal artery occlusion, and therefore she had a systemic evaluation for searching embolic etiology. The 24 hours and 1 week Holter ECG monitoring didn't detect any atrial fibrillation. The TEE highlighted a PFO with a large atrial septal aneurysm and a bidirectional shunt. The cerebral MRI didn't show any ischemic lesion. The transcranial Doppler, sorry, it's like the X factor, yeah. The MRI, the cerebral MRI didn't show ischemic lesion. The transcranial Doppler revealed 50 hits during the Valsalva maneuver. The carotid Doppler didn't show any atherosclerosis, and no coagulopathy were found in the blood tests. So the case was submitted to the heart team, and we decided to go for a PFO closure. At that moment, in your daily practice, this is my first question to the audience, someone close PFO for this indication? Because there's no randomized controlled trials for this indication? Who did? Yes? Two in the audience? Okay. And you, in Switzerland, for example, do you have the reimbursement? Because in Belgium it's quite difficult also to have, because for stroke it's easy, for that you need special agreement.
No, it's not a problem.
It's no problem, okay. So, I show you here the images of the TE before the procedure. The atrial septum, you see, it's very aneurysmal, and there is a significant shunt on the bubble test. So we went for a PFO closure with an Emplatzer occluded 25 by 25 millimeter under general anesthesia and TE guidance. The tuck test was good, no complication occurred during the procedure. The TTE before discharge at day 1 was correct. The device was in place, no pericardial effusion, no residual shunt, but the entire aneurysm was not covered. These are the TEE images during the procedure where we measured the distance between the defect and the aortic root, which is 14.5, and the distance between the defect and the superior vena cava, that was 24, so that we can maybe have an idea which size to choose. And you have also the image downstairs that shows the aortic rim was quite good, 9 millimeter. So we went for this 25 on 25, but there was a discussion, maybe we should take bigger size, because we know that it's an aneurysmal septum. But we, like you, the 25 is the most common device we use, and maybe it would be okay. So we decided to go with the 25 by 25.
But sorry to interrupt you. You used the 25-25, not
not the 18.
Yeah, not the 18.
Yeah. So you see that device grasped well the septum secundum. The shape is good, and below you see here that's the tuck test. That's the device seems stable, and so everybody here in the audience is comfortable to release the device at that moment? No. Why?
The distal part to aorta, to aortic ridge.
The distal part?
It's not enough engaged.
Okay. So we released the device. But the patient was okay, and the control the day after was okay. But 1 month and a half after, she came to our follow-up. She complains only about palpitation. The ECG didn't show any arrhythmia. I performed my echo, and I was really embarrassed to tell the patient that I don't see the device in the heart. And I
I had to tell her, sorry, we need more exams. We're going to do a TEE. It's not pleasant, I know, sorry. So she went, and my colleague also said, I don't see your device, sorry. So we went immediately to the scan, the body scan, and finally they found the device in the descending aorta. You can see it here, it's stuck at the level of the first lumbar vertebra. So we are in front of an incidental finding during follow-up of an embolized Amplatzer 25/25 in the descending aorta, 1.5 months after implantation. The patient has few symptoms, and she's hemodynamically stable. So same question, what would be your strategy? You go for percutaneous, right? Okay. So that's what we did. We planned our strategy because it was my first time. So I wanted to try the device I will use, and we decided to go for arterial femoral access with echo-guided puncture, put 2 proglides, and use the eye-sleeve sheet, which is the sheet that we use for the TAVI. It has the advantage that it is a long and large sheet, long 32 millimeter and large 14 French sheets, but it's also expandable. So it will be easier for us to do. And we use here, different to you, the double snare technique, which, because when we tried with 1 snare, it was not sufficient to grasp. It was always slipping the snare. So we thought it was a good idea. And we also call the surgeon vascular for backup, just in case of failure attempt or complication. This is the double snare technique that was published in the Journal of Interventional Cardiology in 2018 by Kisoha and colleagues. It's a quite simple technique. You have to put the second snare through the first snare outside the sheet, like you're threading a needle, and then you push both catheters through the sheet. And outside the sheet, you have to be parallel on the opposite way when you pull back the 2 snares, so that you can reorientate your snare and goes exactly aligned and straight to the sheet, and it won't damage your sheet, the tip. It's an elegant technique. And that's what we did. So the sheet, you see, is very close to the device. We managed already to grasp with the first snare the screw, and then after a few attempts, the second snare will grasp the screw. Here we go. So here, like he said, my colleague said, it's very important that everything gets inside, and this is the first disc, and then the second disc, so that there is no vascular injury. It's the perfect way to retrieve it. If you try with small sheets and try whatever, biotoma, it could complicate your procedure. This is simple and it's easy to perform. So, embolization of the PFO device results in this case from an underside occluder who did not cover the entire aneurysm. The device was successfully removed using the double snare technique and a long and large sheet. The advantages of using the double snare technique and the long and large sheets that it provides more grasp, reduce the risk of re-embolization, and facilitate recapture through the sheet. Thank you for your attention. Yes?
Shall we keep it to one question just to keep things moving, please? Thank you.
Wonderful presentation. Just short question or comment for my own understanding. I mean, once it was embolized and we were unable to see the device, was CT scan justified, or rather taking the patient to the cath lab and just scanning 1 or 2 minutes?
A posteriori, yes, but maybe it has So first, I have no idea about she has no symptoms of palpitation, so it doesn't guide me where maybe it could be. So second, it could also go, I don't know, stuck in the subclavian or whatever. So first of all, yeah, maybe the cath lab will, yeah, maybe the cath lab.
There have been much lesser radiation and quicker detection.
You know, a quick dedicated scan is not a lot of radiation. For, you know, medical legal reasons, it's better to document the case than going in the lab directly. So don't forget this is a complication and you have to secure yourself. Congratulations, because this technique was elegant, a brilliant, brilliant job.
Thank you very much.
Great case. So can we ask Michael Naguib from Bahrain, our next speaker?
Yeah, I'll be doing it online. Can you guys hear me and see me?
Yes, we can.
All right, I'll just start sharing my screen. Right, can you see the PowerPoint?
No, we can.
You can?
Yes, we can.
Brilliant. So good morning, everyone. My name is Dr. Michael Naguib, and it's an honor and a pleasure to participate in this year's ECC Congress. Unfortunately, I'm unable to be in Lausanne. I would have loved to be there, but you know, thankfully we have Zoom, which allows me to present the case remotely. So today it's quite an interesting case, and it's about a percutaneous closure of a post-infarct left ventricular pseudoaneurysm. So we have an 84-year-old female patient, and she had a significant past medical history of cabbage. She came and was admitted with symptoms of chest pain. She underwent cardiac catheterization and was found to have a subtotal occlusion of the diagonal branch. The interventionalist at the time attempted to angioplasty, however was unsuccessful due to the difficulty of crossing the lesion with balloons. This resulted in total occlusion of the diagonal branch, which we found out later. So 3 months later, the patient was readmitted with acute congestive heart failure exacerbation. A transthoracic echo was performed, and it revealed an anterolateral pseudoaneurysm with bidirectional flow. This was further confirmed by a transesophageal echo, and that showed a narrow neck of the pseudoaneurysm, as you can see in image 2. The neck of the pseudoaneurysm measured 6 to 7 millimeters, and the ejection fraction of the left ventricle was 35%, and there was abnormal wall motion. And this sort of makes sense because of the left ventricular pseudoaneurysm. Now notice the position of the pseudoaneurysm was in the anterolateral apical position of the heart, and this makes sense because of the total occlusion of the diagonal branch, which supplies that region of the heart. So in light of the patient's advanced age, her chronic steroid use, history of hepatitis, her previous bypass surgery, she was felt to be at prohibitive risk for surgical excision, and the cardiothoracic surgeon declined to operate on the patient. And the patient was transferred to the interventional cardiology team for a possible transcatheter repair of the left ventricular pseudoaneurysm. Now, as we can see in image 3, a CT angio of the chest was obtained. And as you can see over here, this is the left ventricular pseudoaneurysm in the lateral apical position. And it measured 4.5 centimeters by 2.5 centimeters. And you could see it also has a very narrow neck. So at this point, before we jump onto the procedure, let's just discuss a little bit about what a left ventricular pseudoaneurysm is. So it's basically an outpouching through the defect in the wall of the heart, and it's lined by adventitia and either pericardium or scar tissue. Versus a true aneurysm, which has all 3 layers, the endocardium, myocardium, and pericardium. It's a potentially fatal complication, and it can present in numerous ways. Like our patient, left ventricular pseudoaneurysm can present with a congestive heart failure exacerbation. It can present with chest pain, dyspnea, arrhythmia, cardiac tamponade, potentially syncope, and most fatally, sudden cardiac arrest. And the main etiologies for the left ventricular pseudoaneurysm are either post-infarct or iatrogenic, maybe more commonly post a mitral valve replacement. So how did we go about and manage our patient? So the procedure was performed in the cardiac cath lab under conscious sedation, and it was done via femoral retrograde approach. Part of the diagnostic workup as well in the cath lab was a left ventriculography, and it confirmed both the location and the size of the left ventricular pseudoaneurysm. As you can see in image 4, it's highlighted by the dotted circle. That's the left ventricular pseudoaneurysm. And a 6 French shuttle select sheath was parked in the mid left ventricular cavity, as you can see in image 5. There was some difficulty, however, the neck was negotiated with a 5 French Bernstein catheter and the glide wire, and we were able to get in the left ventricular pseudoaneurysm, and angiography was obtained inside the left ventricular pseudoaneurysm. Ultimately, a 6 millimeter Amplatzer septal occluder was deployed across the neck of the left ventricular pseudoaneurysm, as you can see highlighted by the red circle. And final angiography revealed excellent positioning of the device with mild trivial leakage into the pseudoaneurysm. Now, at this point, it was decided to go for a 6 millimeter Amplatzer septal occluder. However, we could have went for a fenestrated PFO device. However, an ASD septal occluder was chosen, so the waist of the device can seal the mouth of the pseudoaneurysm and achieve or to achieve minimal flow into the pseudoaneurysmal sac. The following day, a transthoracic echo demonstrated a well-seated device. There was some trivial leakage into the left ventricular pseudoaneurysm, both by color flow Doppler and echo contrast administration, as you can see in image 7. The patient was discharged on the second post-operative day, and 4 months later, the patient continued to feel very well with no heart failure symptoms, continued to enjoy daily walking with no limitations. Now, image 8 shows a repeat transthoracic echo, and it shows complete seal of the left ventricular pseudoaneurysm with absolutely no flow through the device. At 2 years, the patient is still alive without any cardiac symptoms nor any hospitalization, and repeat echo at 2 years verified the complete seal and exclusion of the aneurysm. It's actually quite interesting that the patient is scheduled in a month's time for a TAVR, and it would be quite interesting to see both devices post-procedure. So when we came to choose our device, this is a question for the audience. What would dictate the choice of device? I'm sorry, guys, I cannot hear you.
Okay. So
yeah.
A is the size of the neck and the width of the PA. B the size of the neck length and the PA. C the device availability. D the shape of the PA cavity. E the location of the PA orifice.
This is basically a very difficult question, and this is totally offline. We saw off-label, sorry. But we saw, of course, yesterday a case, Michael from colleagues here, and from South Africa. They also used an ASD device, which we also intuitively would use because it's a softer device. Because of course you can have erosion and then have trouble, and I have seen patients fatal outcomes with this technique. Don't think it always works. But I'm not going to answer the question. It depends on the size, basically of the device, and then you stent it with the ASD device adapted to that. Yeah. not too much oversizing. Any opinion in the... The room is silent, so...
Okay, so I'll continue. Basically, the device was chosen based on the size of the neck length of the pseudoaneurysm. Obviously, all answers are and have to be taken into consideration when choosing the device, and it should be really an individualized approach. What we found was that the size of the neck length of the pseudoaneurysm really dictated what device, as there are many device choices in the literature that have been used, such as a VSD device, an ASD device, as this patient had, a PFO, a fenestrated PFO device. However, since this patient had a very short neck, it was better to use an ASD device versus a longer neck, which would be better to have a VSD device. Pseudoaneurysms and left ventricular pseudoaneurysms are becoming very prevalent due to the incidence is actually on the rise because there is increased structural cases, a lot of TAVIs, a lot of mitral valve replacements. So this is actually very interesting, and the literature doesn't have many reported cases. Actually, there are only roughly 47 to 50 cases. So what has been found is that PCI is actually much more favorable than the traditional surgical approach due to three main reasons. The first one being the mortality rates. So in the literature, out of the 47 cases that were published, there was 100% survival rate versus a 9% surgical mortality rate as published in the literature in the most comprehensive review by Francis et al. And post-operatively, out of the 47 cases, there were 33 cases that were followed up for an average of 264 days. And their survival rate was 98% compared to a 23% post-operative mortality. Conservative medical management has been an option. However, there was 48% mortality rate. The patient's morbidity was much more favorable after a PCI rather than surgery. The economically, it was much cheaper for the patient and the hospital to undergo PCI versus surgery because the hospital stay for a PCI was 1 to 2 days on average versus surgical stay, which was 1 to 3 days in the ICU and roughly up to a week
Thank you very much.
in hospital stay.
Okay, thank you very much for your nice case. No question, I think, in the audience. So we're going to move with the next presenter, Grégoire Giraud from Lausanne and Sion. Thank you very much.
Thank you.
Okay, dear colleagues, thank you very much for the invitation. Thanks, Eric. Thank you to give me the opportunity to share a local case from Lausanne, a PFO case. So it was the history of a 40-year-old man with a stroke in March this year. He had no cardiovascular risk factor, no thrombophilia, no atherosclerosis, and only a moderate PFO without atrial septal aneurysm. The ROP score was 8, so the cardiologic consensus was to close the PFO. The material we used were the 9 French on the left side for the access with the, on the right side for the access with the delivery sheath. On the left side, we control the procedure with the ICE catheter. And to cross the PFO, we used the guidewire 0.35 with the MB launcher, and then change to an Applancer super stiff with a delivering sheath to put in a occluder device of 23-25 figular flex device. Just to remind, we see two PFO complications this morning, and the anatomy and physiology of the septum is quite important in this situation. In the embryonic evolution, it's first of all the septum primum, who grows from the top to the bottom, with the formation of in the upper part of the septum, formation of a hole. After that, we have the septum secundum, who grows from the top and to the bottom, and it's a formation of a second hole, and the two holes are not just in phase, so it's only a virtual channel between the left and the right atrium. Here you can see a video from a patient with ICE procedure with the atrial septal aneurysm and a large PFO. This was not the case in our case. In our case, it was a small PFO and no septal aneurysm, so we choose a small device. Here you can see the technique. Everybody know this technique. We cross the PFO, expand the left part of the device and lying against the septal and release the system. So, as we know, large or small device is a real question, and normally we choose a small device for short PFO channel, a small PFO on the microbubble test when patient had no septal aneurysm or when the septum secundum is quite thin. And we will choose larger device when the channel is more than 10 millimeters, large PFO or ventriculography on the microbubble test, or aneurysm of the septum, or thick or lipomatous septum secundum. Here, so we come back to our patient, and on the left side we can see we are quite happy with this situation on the left, and we leave the septum. On the right side we can see the releasing of the system, but if you see here, you can see at the end that the device tilts a little bit. This was our final result. And now I have a question for you. So first question, I'm happy with the fourth answer, I'm happy with the result. Second, something is wrong, but I don't know exactly what. 3, I'll call my best friend a cardiac surgeon, or the device should be removed, or embolization of the device is imminent.
I'm blinded of this case, so even though I'm local. What I see is that you had like Pac-Man sign, where the septum secundum usually enlarge a little bit the device, and it seems that the last picture that we saw is we don't have anymore this Pac-Man size.
Exactly.
That we can see it at least on this.
So just before it was a real Pac-Man sign, so we were confident, but indeed after that the Pac-Man sign disappeared. So our opinion of the team was that the device should be removed, and we take place for the removal of the system, because our hypothesis was the following. The left side of the umbrella is on the right place, but the right side of the umbrella slipped into the PFO channel. Therefore, there is no this Pacman sign. So next question. I'm confident the device will not migrate, and we end the procedure, or I call my best friend, or the device is too small and should be replaced by the bigger one, or for I will try only to reposition the device because size is adequate. Any opinion in the audience?
We should ask Jacques maybe, huh? Or
replace. Okay. Okay. In the team, there were several opinions, but we prepared to retrieve the system. So we changed to 11 French introducer on the right femoral vein and used a end snare for 8 millimeter to remove the system. Here you can see the several attempts to catch the system. So here we attempt to catch the system. Here we catch it, and then we pull back very hardly, but it's not so easy to retrieve a system from the left side in a PFO. In a atrial septal defect, it's not a problem, but in a PFO, it's not so easy. And what happens? Suddenly, the system slipped and recovered a new position. And this was the final position. So, what is your opinion? Well, I'm happy. End of the story. The device is still too small, and a new removal attempt in order to implant a bigger one. Percutaneous way is very risky. I'll call the surgeon, or the risk of embolization persists.
Am I right in thinking that there's a Pacman sign present now?
Yeah.
Did you have any insight from the eyes echo images that's telling you that the device was on both sides?
Yes, at that time, unfortunately, we didn't save the pictures, but at that time, we have the Pacman sign on the echo. Yeah.
But it seems now you have a very nice position.
Yeah.
Your attempts to pull it was not very successful.
No.
So if you have good eyes images, I think you could leave it like this.
Yeah, sure. So summary of the situation, as you've seen, before the two umbrellas were not in the good position, and after the second attempt and the replaced of the system, we have this Pacman sign. That means it's in a good place. So each PFO is unique, and a simple case can always reserve surprises. And it's very necessary to choose the good size for each PFO, according to the anatomic and functional criteria. And it's also important to maintain traction on the septum when you release the right part of the right umbrella, especially in vertical atrial septal, because it can jump in the channel. And it's obviously necessary to watch the Pacman sign on fluoroscopy or under control, eyes control. Thank you for your attention.
Thank you very much, Grégoire, for this Pacman signs. So now let's have a break, a little break. We have a workshop on renal denervation in César Roux, and we also have a workshop with Medtronic. I think in César Roux also.
That's correct. Yeah.
Yes.
We'll give you some more time for a break. So we give a gong sign when we come back in about 20-25 minutes. Okay.
Welcome back. I'm Iulian Matei from Romania, and alongside Michalis, we'd like to invite you to join us for two great presentations of two great interventional cardiologists who will show us a little bit how it's like to be in their shoes and what we have to do to reach success. So we invite Annari, who's from South Africa.
Right, so good morning. Now, it's quite an interesting topic Prof. Eric asked me to cover, and perhaps the reason why he asked me specifically to do so has to do with demographics. Now, disclaimer, I'm from Cape Town, South Africa, and while you can't quite call it deep, dark Africa, I do believe we do things a little bit differently over there. Now, I believe our teaching hospitals have a setup that's reasonably similar to the setup you have in Europe, with the one exception that there's almost no posts available to stay on in the academic sector. So once you are freshly qualified, you get kicked out of the nest and you join the private sector. So now you've just completed your training. You can wire a LAD in under 3 seconds. And the first thing that you do with this newly acquired cath lab skills is set off to find a hospital with a cath lab in need of a cardiologist. That is then followed by finding premises to rent, setting up infrastructure, telephone lines, purchasing equipment, hiring staff, and essentially becoming a small business owner of a cardiology practice of one. Now, patients can either pick up the phone and just make an appointment with you, or they can be referred with by any doctor. And the way that it works is patients either pay cash for the appointment, or they get one appointment per year with a cardiologist that's covered by their medical aid. So you better be able to sort out whichever problem they choose to come and see you with. And that means it's not unusual to see a complex congenital heart disease patient, followed by a patient with chest pain, followed by a patient with heart failure. And this then translates into quite interesting theatre lists. So it's not unusual for me to start my day with a TOE and a cardioversion. And of course, it's Africa, so we do the sedation for the cardioversion ourselves. Then it's get followed by PFO closure, followed by complex PCI, and you end off the day by placing a CRT. Now, if you're lucky, when you choose your hospital, you already find at least one cardiologist there. When I set out, I had the choice between 3 hospitals, and all 3 hospitals had one cardiologist already there. And that means you're on call only 50% of the time, so 1 and 2. But of course, your practice is run completely separately, so you're on call for your own practice and your own patients all the time. So that means that apart from the odd weekend where you get your colleague to cover for you, you essentially need to be available all of the time. And then being a practice of one also means that if there's a hemodynamically unstable STEMI or a complex PCI or a PCI that you caused a complication in, you are it. You can call for an anaesthetist to assist you, but there's a good chance they might be at home already and have to come in, and in the hour it takes them to get there, the case will already be decided one way or another. Now, this might not be applicable to the majority of the audience here, but I wanted to be an interventional cardiologist, and I also wanted a family. And that means that 5 out of the last 6 years that I've spent in private practice, I've been either pregnant or breastfeeding. And that is while maintaining the status quo without missing a beat. So now that I've convinced all of you never to come to South Africa, let's just take a step back and look at the definition of multitasking. Now, the first type of multitasking that you get is called concurrent multitasking, and that is literally doing 2 things at the same time. Now, we all believe we are masters at multitasking, but unfortunately, the truth is that our brains simply wasn't designed for any heavy-duty multitasking. So the closest you get to concurrent multitasking is digesting your lunch while doing PCI. So the majority of multitasking that you actually do is called interleaved multitasking, or rapidly switching between tasks. Now, every time that you rapidly switch between tasks, your brain takes a little bit extra, or use up a little bit extra glucose, and you also have a brief mental block, and that's called the PRP, or the psychological refractory period, and it's much like your computer just hanging for a moment before switching to the next program. Now, every time that you switch, you end up losing this few milliseconds to seconds, which doesn't sound like much, but the quicker you switch, the longer the PRP is. And that ends up creating quite a stubborn bottleneck. And you actually end up losing up to 40% of your productive time this way. And that is at the cost of increasing the stress and the energy used, as well as increasing your error rate. Now, of course, this is only applicable to the men in the audience, because we all know that women are masters at multitasking. But unfortunately, a recent article in the PLOS ONE journal, and I assure you I went through it with a fine-tooth comb, shows that women are no better at multitasking than men. We have no genetic advantage to it. The only reason why women multitask more than men is because we have to. Now, unfortunately, we as healthcare workers, and especially interventional cardiologists, will never be able to avoid multitasking altogether. So are there any positives to multitasking? And interestingly, they gave a group of doctor tasks to do, and they told them you had to do A and B and C and D together. And what happened is it took them more time to do it, and they had increased errors. And then they gave doctors the same tasks to do, and they told them they had to multitask, but they could choose which of the tasks they wanted to do together. And they actually ended up using less time and had less errors. So the reason for that is that they could then choose the cognitive load that they wanted to impose on themselves, and their brain could select the least complex sequence of tasks to complete. So the first thing about multitasking is you need to choose your battles. Now, secondly, we as interventional cardiologists, I truly believe we enjoy what we're doing. And if you enjoy what you're doing, you're going to be much more resilient at handling the additional stress and workload that comes with multitasking. So if you enjoy what you do, you will do it better. And then there was an interesting study where they took 162 participants and they gave them an educational video to watch. They told them they had to make notes, and then they had to do a comprehension test afterwards to recall what they learned. And one half of the group got told it's a complex task that they expected to do, and they expected to multitask. They had to listen, they had to write, and they had to recall. And the other half was given the exact same task, but they told, listen, it's a simple task. Just listen, make some notes, and to do a comprehension tests afterwards. And interestingly, the group that was asked to multitask fared better. And the reason for that, they could see in their pupil reactions, is that they were much more engaged at the task, and they actually transcribed more words per second. They were more accurate in what they transcribed, and they fared better in the comprehension test. Now, if you think of PCI, you can think of it as a simple task. You're opening up the vessel, or you can think about it as multitasking. You are keeping an eye on the contrast load. You're keeping an eye on the hemodynamics. You're doing the PCI. You're talking to the patient. So sometimes, if you see it as a more complex task, the better engagement that comes from it can actually end up improving your performance. And then, while this is perhaps doing multiple tasks rather than truly multitasking, but in the South African context where we do a little bit of everything, you can use skills from the one skill set in doing something else. So, for example, I've often used my coronary wiring skills to wire the coronary sinus, and I've even balloon tracked catheters around the coronary sinus, increasing my success rate there. So sometimes if you can actually transfer the one skill set to benefit another task. Now, in the true spirit of ECC, I want to finish off this discussion with a brief clinical case. The patient is an 81-year-old lady. She essentially came to me with significant shortness of breath, and she had recurrent heart failure admissions in the last few months. Her echo showed a typical cardiomyopathy picture with an ejection fraction of 11% from the referring doctor. By now it's increased to about 20% with medical treatment, and I repeated it on that day. It really did look like a typical cardiomyopathy picture. But despite her significant medical issues, she is still running her shop in a nearby coastal village. And it was the last case of the day. It was after 5 o'clock already, and we learned that that is how problems start. And then I expected it to be normal coronaries, and I proceeded to do the case, and this was the first picture that I took. And you can appreciate that she actually has severe triple vessel coronary artery disease, not much backup coming from the right, and everything is essentially hanging by critically stenosed proximal LAD. Now, the way that it works in South Africa, and I discussed that earlier that day with her and the family, is if we see that they require PCI, we simply proceed to do the PCI during the same setting. So I proceeded to wire the LAD, and I wanted to pre-dilate just with a 2015 balloon. And then two things happened. So the balloon wouldn't go down, and it just transiently blocked pressures, and I lost invasive pressures, which gave me a fright. And then secondly, the occlusion of flow caused chest pain to the patient. Now, at that stage, the patient was quite calm for the procedure. When I told her I actually had to intervene, she became very anxious. And I think it is because up until that stage, she truly didn't believe that there was anything wrong with her. And when I transiently occluded flow for a second and she had some chest pain, she went from being a nervous flyer to a complete panic attack, and she was actively trying to get off the theatre table. Now, at that stage, I've wired the LAD, I've tried to get down with a balloon, and I'm terrified I caused just a minute amount of plaque shift, and if I stop the procedure at this stage, the vessel will occlude, and there's no backup coming from everywhere. She will not make the night. So, rightly or wrongly, I feel that I'm committed to proceed. My options for sedating her is limited because she just had a supper, and options in terms of sedation without airway management is very limited. I called for an anaesthetist, but my anaesthetist that was on call was busy with another theatre case, and I had to call in somebody from home, and they thought it will take them about an hour to get through peak traffic to get back to the hospital. So, like it or not, I've now become the multitasking interventional cardiologist, trying to get my patient through this. And I'm the one that knows her best, even though I've only met her that day, so now I'm actively trying to play psychologist and counsellor, talking to her, trying to get her to calm down, while trying to open up that vessel as quickly as possible and get the hell out of there. And just as I was getting ready to set up for rote ablation, the head theatre sister walked in. Now, she knows nothing about coronaries in the cath lab, but she heard we needed some assistance, and she was the only one that was available at that stage. And she went and she sat down at the patient's head, started talking to the patient, managed to calm down the patient, and more importantly, allow me to stop focusing on the patient and focusing on the coronaries. And at that stage, I could get a 1 by 5 millimeter balloon down there, and then it was a relatively straightforward PCI from then onwards. So for me, and that was the final result, for me the take-home message of this case was that whether it is in the cath lab or in your practice or at home, you can never avoid multitasking, but to have support, whether it's coming from a colleague or whether it's coming from a team member or whether it's coming from your family, will be your best chance at success in multitasking. So the take-home messages of this for me is that multitasking in a healthcare practitioner and interventional cardiology setting is not always optional. At least if you're used to doing two things at the same time, it does help. If you are better engaged, and I'm not suggesting that you multitask all of the time, but the better engagement that comes with multitasking can sometimes actually translate into improved outcomes. And if you focus on the task at hand and you rather do the task sequentially in the least complex sequence of tasks, it's going to save you time, it's going to reduce your errors. And then remember to pick your battles. And finally, support, support, support. Thank you for the opportunity.
Thank you, Annari, for this beautiful presentation. If there are any comments in the room, please, Malcolm.
First of all, that was brilliant. Just a fantastic talk. And so as I listened to you talking there, I'm not sure I believe that there aren't gender differences here. But so I have a question. And that is, well, two questions. Is there any evidence that we're thinking more about multitasking in this era than maybe 20 years ago, 50 years ago? Has there always been multitasking? And secondly, when you read and certainly observe what people are doing with social media, and you're very distracted by looking at their cell phones, and recognizing that people learn differently now, and that the brain is very plastic. And so just the way we learn, can be modified by, what we're doing, particularly as we're in the younger years. And so my
question then is, as I said, is there a difference in, do we see more multitasking, or people think that there's more multitasking now? But the second part of that question then is attention span. I mean, so for example, just looking at TikTok videos, I mean, it's short, so people don't read books anymore as much, and so they can be very distracted by these small videos, and so they don't want to watch a 2-hour movie, but they would really like to watch your multiple little TikTok videos. Does that play into multitasking as well? And maybe, again, it's perhaps a bit of an obtuse question, but as I was listening to you there, I keep thinking that these things can be rolled into that as well.
No, true. In terms of the social media and media available, there's good evidence to show it's distracting, and you actually function more poorly if you're distracted by media, or keep checking emails, etc. the whole time. In terms of whether it's different now than it was 50 years ago, I don't have any evidence of studies to actually show or prove that, but just from a personal perspective, I imagine it must be very different. And I just think the options and what we do and what is available at short notice, there's just so much more now. I think you used to just do one thing with very limited options 50 years ago, whereas at the moment the options are limitless. And I think also, just from a personal perspective, with women moving into the workplace, there's always going to be more multitasking. I really enjoyed your talk, but I was thinking, when you said you've got to be home for dinner, you've got to remember I've got to be home to cook the dinner.
I can't, there are on the cath lab group from the hospital CHUV here, Catalina Trana, who is also a lady interventionalist, is impressed by your talk, and I think it was really essential to have your talk here at the meeting. Maybe, do you see, you're still young, how do you see your perspective? Cape Town, South Africa, it's a beautiful city, so those who have never, you have to go once in your life to Cape Town. But how do you see the perspective of cardiology, the private practice, the fact that they have to look for patients? How do you see the perspective for your generation of cardiologists in your country?
I think we've got a very interesting setup. So we've got problems and we've also got solutions, and that's always the situation in Africa. So I think training is becoming more and more of a problem in the majority of the institutions, and people leaving training hospitals are becoming less and less equipped. But that also creates a lot of opportunity for education in the private sector. And even though I'm essentially on my own, and I've been on my own from the start, there's lots of opportunities either before COVID from industry, getting experienced people in to do cases, or even asking, phone a friend, asking a local person or somebody from a different province to actually come in terms of training. So I think for the people who, or even in the case yesterday, where you call and somebody will come, it will take them 2 hours to get there, but we will all support each other. So I think there's lots of opportunities, and there's lots, if you want to do something in the South African setting, there's, especially with, globally, you can get so much help from anywhere in the world as well. There's lots of opportunities there. But sometimes I do wonder if we had more of an academic setup a little bit longer, with more exposure to multiple cases, rather than learning one case at a time. It might also be beneficial.
So thank you for your beautiful talk. It was really interesting, something that make us thought differently out of the box. And I think we have to move to the next talk. I have to invite Tito Kabir from Royal Brompton, a very experienced interventional cardiology, and we are really waiting for his talk about his long and winding road to interventional journey.
Thank you, everybody. Thank you, Eric, and the organizing committee for giving me the privilege of talking today. So I'm a cardiologist at the Royal Brompton Harefield in the United Kingdom, and I was a fellow here in 2008 with Eric, and well, sort of a fellow. in some sort of way. So when Eric gave me this title, my initial reactions were, well, oh my God, me? Am I really at that end of my career that I'm giving a long and winding sort of, is it over? And then I thought, well, maybe I'm somewhere in the middle, and there may be some nuggets of information that might be useful to somebody along the way. I have to say this is a zero evidence-based talk, and there are no references. Lots of internet images. And I thought, okay, I'll play. I suspect we've all got long and winding stories, and each and every one of us could probably give this talk in some way, shape, or form. So I'm just going to ramble for a bit and maybe draw some things on reflection that have occurred to me. So to try and understand this winding journey, I thought it might be useful for you to understand where I am. So I'm currently a interventional cardiologist, as I guess the vast majority of you are, or somewhere along that journey of becoming or been for some time. And I've been at the Royal Brompton Airfield, which is now recently joined with Guy's and St Thomas's, which is another big teaching hospital in London. And I've been an interventional cardiologist there for, well, 12 years. It's even scary to say that. And I do approximately 350 to 400 PCI a year, of which about anywhere from 150 to 200 are PCI STEMIs. And I try and spend the majority of my elective time doing complex type of PCIs and all the sort of impossible cases from the surrounding hospitals, along with approximately 100 TAVIs, mostly Edwards now. I have to say one of the benefits and reflecting is I thought, well, what are the actual things that I do? A lot of my time is spent training colleagues who are junior colleagues who are now fellow consultants, and that's actually, I'm sure Eric and Malcolm will, and a lot of you will reflect, that's actually one of the pleasures, is that you come along to work with colleagues who were once your trainees. And somewhere along the line, I've managed to maintain, as you can see, my hair and my sanity. Just to give you an idea about Harefield and Brompton, it's basically 4 big hospitals, but Harefield itself is a sort of I guess, a very old building. And interestingly, it's in the shape of RAF pilots' wings. It initially started off as a TB hospital, I guess, as a lot of hospitals started off, and then it morphed into an Anzac hospital during the war, and then a heart and lung center. So basically, there are lots of very old bits. There are some brand spanking new bits, but really it's the people that make the place. So, to the journey. You can see that there are 2 very sort of similar looking images, one at the top and one at the bottom. The top one was essentially my aspiration, and the bottom one is more or less what I ended up with. Of course, this is a much more glamorous looking model. So I distinctly remember my interview at medical school, and I was probably a bit more confident than I am now. And I remember saying to the interviewer, mark my words, I will be a neurosurgeon. So that worked out well. So in order to do that, I pursued an intercalated BSc in, what I thought would get me into neurosurgery. And there was lots and lots of Western blotting involved, and immunofluorescence. However, along the way, cardiology seemed to make a lot of sense to me, and I guess by selection, we all must have, in some way, shape, or form, made that conclusion. It seemed to be pretty binary. You find somebody with a problem, you do some interesting tests and examinations and clinical acumen, find the cause, and then you fix the cause, and then everybody's happy. Of course, nearly everybody I met said, you'll never get into cardiology. And these people were supposedly my supporters. But actually, the thing that I realize is, as I'm sure all of you do and must be by the fact that you're here, is that if you need to set yourself some clear goals, focus on achieving those goals and be determined. So, some more of the winding road. Junior doctor training, I guess, is pretty much the same throughout the world. It's intense, long hours. Basically, it feels like an episode of MASH. But you learn the practical aspects and skills and knowledges to apply the knowledge that you learned in medical school. You learn to be organized and focused and reflecting on some of the things that were mentioned in the talks by our senior peers yesterday. Time management and people skills are important things that you learn or are forced to learn. And also to learn also that the focus of everything we do is really the patient. I also, along the way, as I'm sure we all have, made a lot of lifelong friends and colleagues. There is also the other aspect, which I think we all need to, I guess, pay attention to, is career planning, next steps, juggling, multitasking, having the ability to undertake higher exams. And I think something that really stands out is having a mentor along the way. And I think it's fair to say that Eric is a mentor to me and probably to a lot of people in the room. So I then thought, what should I do to further my career in cardiology? So I did a PhD in cardiovascular biology. And as luck would have it, more basic science and Western blotting and Northern blotting. I also learned that, I don't know whether it's the same throughout the world, but I'm guessing so, that scientists, basic scientists and medics quite often have a very curious and challenging relationship, a bit like oil and water. But you have to develop a synergistic relationship and get along with people. That's all I'm going to say. Right. That also involved hard work, long hours. And I think it's fair to say for the scientists in the room, you delay your gratification, you put a lot of hard work in, you work towards a goal and you don't get an immediate reward. Your reward is quite often something different, a publication a year or 2 years down the line, or even further. And also there are no guarantees, and quite often you find yourself repeating the whole week for some minor infraction. And also that led me to conclude, is basic science for me? I went into basic science thinking I will be one of these super duper academic cardiologists that will juggle many balls. But actually the main thing I learned was time management skills, and that basic science wasn't actually for me. But I did learn critical thinking, and I think that's really stayed with me along the way, and the ability to assess a situation, assimilate the problem, generate a hypothesis, and then focus on developing ways of solving the problem. The other thing I really importantly learned was write your thesis up before you leave and go back to clinical medicine. I don't know how many people are in the middle of doing basic science or some sort of research. My strong advice, as Eric will probably start to remember, is that you really need to write your thesis up before you get back to clinical medicine, because life will overtake you and you're busy saving lives and meeting other deadlines. And it took me 10 years. And in fact, I think they changed the rules probably because of me. I remember during that 10-year period, I remember certain key moments. My wife took me on a surprise birthday party for a big birthday, which I'm embarrassed to even mention the year of. And all I could think about was writing up my PhD while everybody else was partying. I managed to distract myself by watching the whole of the royal wedding, because that seemed to be a major important thing that I had to do rather than actually write. And I also remember attending a lecture at the Royal College of Physicians in the UK by one of my other mentors, John Martin, and he was more or less where I am now, but in a massive room full of trainees, and he spotted me right at the back and stopped the lecture and said, "Tito, have you written up your thesis yet?" I really wanted the ground to open up and swallow me at that point in time, because I had like 200 people focusing their attention on this loser. Right, okay. So then I went on to specialist training in cardiology. Thankfully, there was no Western blotting. This effectively underlined a lot of the things which clearly are becoming important traits and maybe the nuggets of this talk, that you really need to be organized and efficient, or at least have a way of believing that you are and focusing your efforts and attentions. I also learned the basics of managing cardiology, patience and technical skills. And that you basically got to get through the hard slog in an efficient way to get to the good stuff, which is essentially learning how to do and create complications. I also met my wife along the way, and I also realized that my interaction was, patient interaction was my strength. Another high point in the winding road was fellowship. Don't I go on a fellowship? And there are lots of considerations when you have to make that decision. You're going to lose another year of your potential career when you're cooked. What's going to happen to my family? Is there really a benefit? Shall I just breeze through the system and come out the other end as a card-carrying cardiologist? And actually, it has to be a very individual decision. For me, it was definitely the right choice. I came to the CHUV in Lausanne, and I learned a lot of different things. Obviously, there was a technical aspect, but I learned to broaden my mind, live in a different country, different techniques. I had my first exposure to the ECC, and also I made a lot of lifelong friends who I do still keep very much in touch with. Reflections, hopefully not at the end just yet. The road may be long and winding, but I think for most people, if you work hard and enjoy what you're doing, manage your time and your people's skills, that it usually does work out. I think that's my advice to anybody who's maybe somewhere at the beginning of the journey. It may need some planning and thoughts. It is also, I guess, important to focus on your core values and interests, but at the same time, adapting those to suit your goals. And also working to your strengths and to challenge yourself. I'm clearly not a basic scientist, but I learned some things during the time that I was. And also you need to ask yourself why you are doing something and what's your motivation for pursuing a goal. The other thing I would say is mentorship is very important, and sometimes if you're struggling with some of these decisions and concepts, having a senior mentor who has maybe seen other people go through this sort of process is much more important than you may appreciate at the time. And once again, Eric. The other thing to say is it all goes by very quickly. 1 minute you're a trainee, and the next you're giving this talk. You really need to find some way to enjoy yourself along the way. As has been said many times over the last few days, you really need to look after your mental health and well-being, because it's super important and nobody else will do that for you if you don't do it yourself. You really need to devote some time to your family and your loved ones, because you will never get that time back again. And some of the things that Malcolm said yesterday were really pertinent. The other thing that also struck me is that it's very rewarding to become a mentor in some small shape or way, and fostering the next generation of cardiologists is super important. That's it.
Thank you very much for this fantastic talk, and for giving us the opportunity to see how multitasking interventional cardiology tried to get through all these difficulties and combine basic research with today's interventions. Do you have any comments, Eric, Malcolm?
Yeah, Tito, that was wonderful and so personable. quick question though, do you have any regrets of what you did or did not do? And the second thing, just really a comment, you talked about, the trainees and how they've then become your colleagues. And it's something that I think took me a long time to really appreciate. And that is how important it is to make sure that the people who you are training really get up to a very high level. And so when you see a trainee struggling, I sometimes hear people being critical of them and say, well, they're not working hard enough, or they're not going to make it. On the other hand, you should look at that and say, well, that's our failure as teachers. That's someone that that they've come to train. These are people who've invested a lot of time and their education. And I think now I appreciate that one of the most satisfying things is to see trainees who now can do a whole case by themselves, complex case. I don't have to touch anything. And that's really, as I said, super satisfying. When these people get then hired, as fellows or residents, we should be thinking about these are the people who, we're not just training them to go off and be cardiologists somewhere. These are the people who should be our colleagues. Right from the beginning, you want to train them to be as good as you, or better, and your other colleagues. And I think that just puts a very different flavor and emphasis on their training. But as I said, one of the most satisfying things, and many of the things that you talked about there really resonated with me. But any regrets?
I try not to have regrets. Clearly, all of us could have done some things in a better or a worse way. I think that we all have a journey, and it's important not to too much regret. Obviously, driving a car into a shop front might be something you'd regret. But career-wise, I don't think so. I think you just learn something from each step. Once you've made that decision, I tend not to look back too much. Coming to the trainees side of things, I genuinely found that more rewarding than I thought I would. And actually, when now I have telephone conversations with now consultant colleagues who were my trainees at one stage, it genuinely warms me, makes you feel that you've achieved something more than just, doing an angioplasty on one patient. And the other thing I would say is I quite often, when I'm working with a trainee, I often ask myself, would I want this person doing an angioplasty on my nearest or dearest? And that has to be the benchmark, because they need to be competent. And when they leave, your training sort of period, they need to come away with that skill. Otherwise, you're doing them a disservice if they're not fully trained, and you're basically doing patients a disservice.
There is a very delicate point in terms of training and transmitting skills and knowledge, both. But we don't always succeed. And is it always because of us? You see what I mean? Or is there something else?
I think that's a very important point you raised, because there are some times you have to recognize that there are failings at multiple points. We obviously have to do everything we can to make sure the training that we do and the mentorship is the best it can be to bring the best out of somebody. But sometimes there are some trainees who just, for whatever reason, are not going to make the grade. And you have to realize that that's going to be the case. And there's a few people that thankfully not too many, that I remember, and irrespective of the fact that they may be very nice people, they just were never going to be interventional cardiologists. And I think recognizing that early and communicating that to them in a non-derogatory way is important, because they need to make a very difficult decision themselves, I think.
Yeah, I wonder if somebody in the room, because it's a delicate subject, I think we all have to transmit knowledge and skills, but not always easy. And I wonder if somebody dares in the audience to make any comments on that. You don't have to, huh? I see Brahim laughing. How is it in France? So how is the... give the microphone to...
Oh, in France, it is not easy also, but for the thesis, it doesn't take 10 years, just perhaps 3 to 5 years. Sometimes it's very difficult to get what you want. And when you want, for example, to do interventional cardiologist, everybody says to you that it is not possible because there is no place and it's very difficult. And you just have to follow your dreams. I think so.
Maybe I have one last question for you, Tito. Do you think there is an interventional generation gap? Or is it just fake? Because, you know, people get older and then they pass away, and then there are those that are young, 20 years later, they're in the middle like you, and then they get older too, and just life goes on. Or is there a change in mentality, and there's a change in skills? Is there, do people subspecialize in you know, valvular and whatever? Of course, Annari is multitasking. She does everything in Cape Town, but not everybody can do that. So what is your vision on that?
I mean, I think that interventional cardiology has changed even in the time that I've been observing. I'm sure that you will all reflect on that. And the specialty itself has grown and developed many different heads along the lines you've just clarified. And even those specialties are becoming more and more subspecialized. And therefore, there is little choice but for people to be very good at one or two areas. There are a few people, but actually I think the majority of people need or do focus on the areas that they're interested in. For example, I was taught to do a CRT when I was in training, but I would never dream of purposefully going near the coronary sinus. It's something that I would hand over to one of my colleagues. And I think that part of that is because the training has also developed. I think it tends to divide much earlier as well. When I was doing my training, we all learned a bit of each of these specialties. And the trainees that are coming through these days, the training is much shorter because of various reasons, and therefore trainees are required to make a decision a year or two earlier than we were, for example.
Just one other question, because we keep talking about trainees. Could you just reflect on what your experience was when you finished your training and then became a consultant? Because that's an important step, and people sometimes struggle with that. So I'm just wondering, what advice you can give to people who are at that stage in their careers now.
Yeah, well, what I would say is that I think that you're right. That's a very, very delicate juncture, and the first thing I would say is I wouldn't rush to be a consultant. You need to be confident in yourself within reason that you're fully trained. And that's one of the reasons I did a fellowship. And one of the things that I found in the fellowship is that Eric and the team at Lausanne gave me the wings to develop. And I was doing on-calls with support from home. And that I found very useful, and that enabled me to develop my own problem solving, shall we say. The other thing I'll say is to any new consultant, sure, everybody wants to be, Superman, but or woman, sorry, super person. You should really maybe take a step back and think before you get into some of these complicated situations, because it's very difficult to come back from the reputation of being a maverick, although it may not be your intention, and therefore just pacing yourself before you take on the super complex cases, or at least think carefully about how you're going to do them. Maybe have a buddy or a mentor or somebody that you can work with, and really think through particularly elective cases before you rush into them, because you can quite often get yourself into a lot of trouble very quickly. And then when you know, A, it knocks your confidence if things don't go well. B, we're all learning all the time, and you can always learn something from somebody next to you who may have been in the situation before. That's I would say, the most important thing. Thank you.
Okay. So thank you, Tito, for this reassuring and also encouraging talk. It's great for a young interventionist. And just to finish, if Eric allows me, maybe one quick question. I also wanted to ask you about your regrets, but just to turn on the funny side, it was about choosing the royal wedding versus the Ibiza party.
Yeah, I really should have been writing my thesis at that time. I mean, honestly, I watched it from the beginning to the end because it somehow seemed super important at the time. And I literally had my laptop computer open with a blank page. Yeah, so please don't do that.
Thank you very much. Thank you, Annari. And see you everybody later.
So good afternoon, everyone, to the final afternoon of what has turned out to be a wonderful congress thus far. We're going to move to our first case. It's Alexis Simeon from Romania.
Hello, my name is Simeon Paul Alexandru. I'm an interventional cardiologist at St. Spiridon Emergency Hospital in Romania. I would like to start by thanking Professor Eric Eickhout for the invitation. It's truly an honor and a privilege to be at such a wonderful congress. I would like to start with a case entitled, "And Yet to Every Bad There is a Worse." This case I had after a very long night shift. I was a bit tired, but it was a successful night shift, so I was in good spirit. So it's about a 60-year-old male patient admitted with chest angina for 10 hours. The ECG revealed ST depression, anterolateral leads, positive troponin, severely depressed left ventricular ejection fraction, 30%, and diffuse hypokinesia with akinesia, anterolateral wall and apex, good renal function. So the patient was known with chest angina for 1 year. He was diabetic, hypertensive, and was under this current treatment. So in the cath lab, we can see in the first picture, we have a normal RCA. Oh. Okay, but this works. And we have a lesion in the mid-LAD, like 90%. It's a very tortuous vessel, the proximal LAD, as you can see from the caudal view. And at this point, the patient had NSTEMI, chest pain, 3 out of 10. And I would like to ask, how would you approach this case? I would like to ask the audience if you would proceed with intracoronary imaging or just standard balloon predilatation, or would you plan for cutting rota or IVL? It's a little bit of calcifications there, as I can put that. Anybody would use IVUS for this lesion from the start? No, okay. So we placed the BMW wire, right radial, 6 French, AL2 for support because of the tortuosity, if I needed to deep seat the guide catheter, just in case. So we proceeded with the 2.015 NC balloon predilatation. No hourglass shape, so the lesion expanded quite well. We found an incidence where we can see the lesion quite well to approach with other things. And the 2.7 didn't pass, so we placed a body wire and extra support. We predilated it without the hourglass shape. Unfortunately, the 3.0 balloon didn't pass. We changed the BMW to the diagonal. We tried some anchoring, didn't work. At this point, I asked for a 6 French guide extension. They told me that I've used the last one last night, so only 7 French is available. So I placed the guide wire again in the main branch, and this time I moved the 3.0 balloon on the BMW and not on the extra support. So it's very good expansion of the balloon, so it's not an unexpandable lesion, but due to tortuosity, it was very difficult to advance from the proximal part of the LAD, which is very tortuous, actually quite like a corkscrew. So very, very difficult. We advanced the stent, the first stent, 3.018 Resolute. We implanted it. Good expansion, one might say. But in order to facilitate the advancement of the stent, we had to pull back one of the guide wires because just on simple body wire, it didn't pass. So from time to time, we tend to do this, like advance the stent and retrieve slowly the other guide wire while advancing the stent, and it worked. We positioned it where we wanted. And at this point, we post-dilated with the same balloon in the proximal part of the stent, just to ensure that we will place another 3.0 stent. But when we tried to place the second stent, the tortuosity didn't allow us, and our guide wire moved just a little bit up and down, and after that, I lost everything. So I said, okay, the patient had the big radial. We changed to 7 French radial sheath, ABU4. We didn't know about the dissection at this point. So we wanted to advance the normal BMW, and while I was passing through the stent, I said, okay, let's just check just to be safe. And when I saw this, I was like, oh, this is new. So it was a very long dissection, like just to the apical part of the LAD, and I was in big trouble. the patient was stable, but had increasing angina. And I reviewed the last movie, and I saw that there is a small part distal to the stent, because I thought, why this happened? So I had like a small narrowing distal to the stent. I thought it was spasm that will relieve with nitroglycerin, but actually our guide wire, when we lost the approach and the guide wire, it pushed into that micro dissection and desiccated the whole vessel with a very, very ugly dissection. So we have no problem. We have a proximal dissection in a corkscrew LAD. We have a stent that we need to pass through. We have a distal dissection through the apex. We weren't able to advance the second DES the first time. Now it's even harder because we have zero support at this point. If you try to push, the guide wire will just come back and you risk acute vessel closure. So you have to be way more careful than before. But the patient was stable and increasing angina. So I would like to ask a question. Would you prefer a BMW in this situation to go intraluminally, or you will choose another guide wire at this point? Would you choose a floppy?
Shall we take a vote? Who would want to use a standard workhorse wire? And floppy wire?
Okay.
Majority.
And if you pass intraluminally, at this point, what do you do? Do you take the 7 French guide extension, or do you try with the multiple extra support wires, maybe in different vessel, maybe different anchoring? How many would choose the 7 French guide extension from the start, at this point, after you navigate the dissection? Okay, so multiple extra support wires in different vessels. So here we have the floppy. I chose the floppy wire because I prefer it in case of dissections. And on the right part, we can see that there is a stump, there is a contrast persistency, and I checked like a micro vessel just to see that I'm in true lumen. And I navigated just distally in that small right part of the apical LAD just to ensure that I have good intraluminal passage of the guide wire. So I've changed this through the microcatheter. The microcatheter actually had some resistance to that proximal LAD. The thing is, the second extra support wire, I didn't want to cross the dissection with an extra support wire because of the risk of acute vessel occlusion. So I placed it in the septal, just have like a partial body wire, and the BMW, I've left it in the circumflex. Maybe it changed something, and it did a little bit. We managed to place a 3.015 balloon, which is well expanded. So it wasn't an expandable lesion, but that tortuosity tended to recoil after each expansion of the balloon. So I said, okay, I'll get the 7 French guide liner. I have no support. I don't want to risk the position of my distal guide wire, so I will take the 7 French guide liner. But the problem is that the LAD is quite diffusely diseased, so I might expect hemodynamic destabilization of the patient, especially because it crosses over the circumflex. So I had to make a little bit of planning before putting the guide wire, the guide liner in the proximal LAD. So I said, okay, I will treat the dissection with 2.25, 26 DES, and I will leave the apical part dissected to heal. So that was my plan, to have these 2 stents available, ready. When I place my guide liner, I'll just put the stents and then retrieve my guide liner to have some flow in the left coronary system. So this is what I did. I navigated with assisted tracking, as you can see, pretty deeply. But at this point, the 225 didn't want to advance through that proximal tortuosity of the LAD. So what I did was, I took a balloon, a 2.5, I placed it just proximal to the stent, 2.516, almost reached this point of the guidezilla. So in order to not risk anything, I anchored, I pulled a little bit to straighten the vessel. Then, when I reached with the guide liner my balloon, I deflated the balloon and I came across with the guide liner across the deflated balloon. So, to me, it seemed like the least traumatic way to navigate that tortuosity, and it worked. And I managed to place a 225, 26 stent in that region. I said, okay, the distal dissection, I'll leave it here. So I placed it. I think it's a good dimension. I inflated to nominal pressure. I retrieved the balloon, inflated again. Everything went fine. So this was like the end of the procedure, as it seemed. 225, 26 millimeter stent. Between those two stents, just retrieve the balloon, inflate again, nominal pressure. I was planning to get to finish everything. But as I was pulling the balloon of the stent through the guide catheter to exit it, I said, okay, just to be safe, a little bit of test. And I saw this staining, and I said, okay, okay. And I made the movie, and I saw this, and I was like, oh, this is not planned. I had to finish the procedure. So what I did, in fact, actually I removed the 225, and I asked for a 2.5, because I can see that the vessel grow larger due to this ugly rupture. But this rupture was like through the myocardium and going around the pericardium. This might explain why it happened. So this is my 2.5 balloon hemostasis. I tested it. I don't like injecting when I'm that deep-seated with the guide extension, but in this situation I had to, because I had to check for the sealing of the perforation. So it wasn't enough. So I had to take a 3. So between those two, as you can see from the timelines, it's approximately 1 minute.
Can I interrupt you? Sorry, it's fantastic, Alexis. But there is something new here, because of course the point you make is it seems to be intramural into the myocardium, but here I see something new.
From upper part of the...
Yes.
Yes. I saw it and I said, you will see.
But this is very important, you know.
Yeah, it's very important, because downstairs where there is the tamponade balloon, we have 2 perforations. So one on the right, one on the left, which I needed to cover. But from the proximal part, I didn't know if it's due to the guideliner injection, maybe, mostly probably, because it wasn't there before. But after a hemostasis, I said, okay, let me treat the worst one first, and then I'll see for the other one. So I called the ICU, asked for echo. I had the pericardiocentesis kit available. I had the hemostasis done. I did the echo. It was like 8 millimeter circumferential pericardial effusion. The patient was quite stable at this point. And I had a 3.5 18 millimeter B graft available, which needed to be implanted in a place of a 2.25. And this quite helped me. This rupture helped me because the vessel expanded. And it's the only size that I have. So I have to put it like nominal size. And I want to talk a little bit about single polymer covered stents. The best one, I don't know if I can say the best ones, but big graft and papyrus should be available worldwide because they are single covered stents and they have good profile crossing. And big graft is available on 5 French old dimensions. So that's why we order it and that's why we prefer it. So we implanted the 3.5 80 millimeter big graft. At this point, we can see that it's very good. We did some post-dilatation with the same balloon in the proximal part, and this is where I waited like 2 minutes to see if it closes, the other one. So I waited with this balloon a couple of minutes to see if the other perforation, which was in the upper part of the big perforation, would close spontaneously. Afterwards, I continued to resolve the proximal dissection, and as you can see here, even though I had 3.0 non-compliant balloons which were very well expanded, at nominal pressure the stent has a hourglass shape. So it was due to the tortuosity which recoiled. The calcium that was broken recoiled back into the lumen. So I had good expansion at 16 atmospheres, which was quite okay. And this is the final result of the patient. So everything is sealed as it appears. Afterwards, he had 14, 16, 18, and 20 millimeters pericardial fluid. Maximum at 6 hours post-procedural. We didn't do protamine. We just monitorized with echo at 30 minutes, 1 hour, depending on the situation. We took an APTT. We don't have ACT in the cath lab. We took an APTT post-procedural. It was in good anticoagulation time, so it wasn't an overdose of heparin that required protamine for that reason. And after the 2 hours was normal. So we did just double support. The patient was asymptomatic. We checked for the signs of compression. If we had some, we would have performed pericardiocentesis, but it wasn't. So the patient was discharged after 10 days with just 3 millimeter pericardial fluid. He was asymptomatic, stable. actually we got some improvement in the basal region of the anterolateral wall. The mid and apex remain the same. And there is discussion of double antiplatelet therapy. It's in this situation, there is one study that investigated big grafts on 60 patients, monitored for 279 days. They said there is no stent thrombosis, but I think it's kind of bold because a lot of patients, like 10% of patients in this trial had myocardial infarction at 30 days. And after implanting a covered stent to have a myocardial infarction, it's quite difficult to exclude stent thrombosis, but they declared 0 stent thrombosis. But most importantly is that the PTFE covered stent, which is big graft, has a delayed endothelialization, which is known. And they, in the trial, used prolonged DAPT. So I decided to keep the same as they did during the trial. So we suggested to prolong the DAPT. At 1 month, the patient comes back. He has apical akinesia again, same left ventricular ejection fraction, is completely asymptomatic, improved his walking distance. And we decided to talk to our colleagues in the cardiovascular rehabilitation and to include him in a program to have cardiovascular revascularization, rehabilitation. Thank you very much.
Thank you, Alexis, for that wonderful case. Are there any questions or comments from the audience?
I didn't understand the first perforation. The second, the last one, I get it. I got it, but the upper one, I didn't. This perforation go to the epicardial there or not?
So after the second stent implantation at nominal pressure, you have this coronary rupture, I might say. I wanted to add at this point that it has some myocardial trajectory, maybe, I'm not sure. I haven't done imaging in this case, because I thought to myself why this happened. And I was thinking maybe it was some intramyocardial passage of the artery. I reviewed the films, I didn't see it, but I know it's associated with vascular fragility. And this perforation happened after stent implantation. And this one, I think, the proximal one, as you can see, at that septal, proximal to the perforation, which is quite severe, there is a bit of staining. That might happen due to a guide catheter injection.
So what is important here, that the point we made before, the problem is you don't always see the contrast leaking in the pericardium. But because you have a guide extension, I don't know if you agree with me, just my hypothesis, you have a selective injection and that enables you to see the pericardium filling up, which you probably wouldn't see when you are injecting from the guiding. So the guide extension enabled you to see that it was communicating with the pericardium.
Yes.
Yeah,
Thank you for sharing this fantastic case. Did you ever think, like after this distal edge stent dissection with spider dissection, going back down to the apex, just to conservative management?
I did, of course, but the patient had increasing angina. And so the question was to treat it conservatively, the dissection? Or I misunderstood?
No. I mean, if you go back after you have the dissection, okay, you have flow down in the false lumen, and you didn't, after you put the 2 stents, the extension, you have the same, like you didn't reach the apex, you understand what I mean? And also there is no septals. So I don't know from where this angina, because I have a similar case, actually, it went well with just conservative management, yeah.
We just, when we have a dissection, we routinely ask the patient if everything is okay, and he said, I have chest pain, which is worse than before. And yes, of course, it's in the anterior lead. Yeah.
Yeah. I think
that's why I continued.
I think it's distal edge dissection from the first stent and then extending down,
yes,
and popping the second stent and leaving a segment in between. If I would have been, I would have gone for overlapping with the first stent and extending it, isn't it?
So
because in overlapping, the
yes,
first stent,
yes, both are. The stent is overlapping between those. So I checked.
would you go for IVUS the second time before popping the stent?
That was I thought about it to go with IVUS, but at this point, I didn't know why the perforation happened at nominal pressure of a normal stent. So I thought maybe it's some adventitial calcium that was pushed through the adventitia, and I didn't want to risk another perforation, especially because I didn't had another stent graft. I had one, but it was 4, so I didn't want to risk my result, my...
Can we see the very first image before you do anything?
The diagnostic angiography?
Yeah. The point I make is that perforations often happen at sites where there is intramyocardial passage in kind of small bridges. You may have that. I may have.
Yes,
yeah.
yes.
Maybe there was a bridge, but I'm not sure.
No, I haven't seen one. So I reviewed these images a lot of times because I tend to... There is another lesion on the diagonal, and I will treat it afterwards. But I reviewed them a lot of time. I didn't see any narrowing of the LAD.
There's no bridge, no.
So my presumption, because it's not something that I know for a fact, my presumption of intramural trajectory maybe is that how the perforation behaved, like going through the myocardium and then to the... Maybe, but I think calcium is more probably.
It's an excellent save. I mean, this is a very complicated case you made more difficult by your struggles to actually advance anything, and then you really have to be congratulated on an excellent result. One quick comment. You anguished about the guideline or your guide extension. You had to go to 7 French. Don't forget, if and you had some concerns about, whether that might compromise the flow elsewhere. Occasionally, you might even think about just putting a 5 French guideliner.
It wasn't available.
Not available.
Only.
Yeah, and in fact, in this case, it wouldn't have helped you because then you had the covered stents to put in. I just want to go back to your one of your first questions about whether you would do any intravascular imaging before you started the case. Yeah. So you've obviously had a lot of time to think about this, and we won't have time to discuss it in any great detail, but any thoughts there that if you had done intravascular imaging, whether you would have potentially predicted this problem or not?
Maybe I have known for a fact if it's something intramuscular and in the proximal LAD, but no, I don't think so. The key to the solution to this case was the 6 French guide extension. I think that wasn't available at the moment, so I had to force a little bit of stuff. I got the dissection. I ended up in a place where I had no push force. I couldn't advance anything through that. I had to change everything. I changed the radial sheath on the angioplasty wire, so it was quite... and I had to make the tough decision to go with the 7 French guide extension through that corkscrew LAD, which can be quite traumatic. It can rupture the vessel. So that's why I use the balloon like a little bit, anchoring, deflate, advance, anchoring, deflate, advance to protect the LAD.
So well done on an excellent case.
Thank
Shall we move on to the next, just in the interest of time?
Thank you very much.
Thank you. So next up, we've got Robertas Pranavishesh. Welcome.
Hello, everyone. Do you hear me? Yeah, I guess.
We can hear you.
Yeah, great. So, hello, everyone. It's a pleasure to be here remotely, but still, it's a great honor to be here. So my name is Robert, and I'm an interventional cardiologist, initially from Lithuania, but now I'm working in Austria, in Graz. So first of all, I would like to really thank Alex from Romania on the previous case. It was really amazing, like how you managed the whole thing. Really congratulations. So my case is, I would say similar, but I'll try, overall, I would like to just raise some consciousness on those procedures which we, I guess every one of us does every day, and sometimes as taking in mind that as every procedure is more or less a casual one, we take some procedural steps not so seriously, and sometimes these things happen. So a very fast case, but I guess I will remember it for all of my life. My career isn't long, but still. So we have a 47-year-old female, which was already know that she was hypertension. She was dyslipidemic. She was a smoker. She admitted herself, and she came to our hospital with complaints of typical angina. Afterwards, when everything happened, when we really talked with her, like it was discussable about those typical symptoms, but at that moment, she had a lot of stress 2 days ago. So maybe Takotsubo was also discussed by that cardiologist who saw her, because I was already in the cath lab and other cardiologists saw her in the emergency room. So overall, we didn't have any significant changes in the ECG. The serum biochemistry were like more or less in the normal limits, with just slight raises of cardiac enzymes. Echo at the bedside in the emergency room was totally okay. But here the pitfalls of this case comes that more or less we were finished in the cath lab. More or less it was the last case when that cardiologist called us, and she more or less convinced me to take her into the cath lab, as you know, Robert, she's young, she's feeling some chest pain, maybe the first troponins are negative, but maybe something will happen, since she had the positive family history of cabbage. So as it was the last case in the cath lab, so those more or less discussable indication for the procedures, but still she came to the board and she was still feeling some chest pain, so we took her to the cath lab. And initially this was the first angio of the right one was totally fine, as this case was like happened quite 2 years ago, and now I'm working in the other cath lab, so I don't have all of the images. So the first image was okay, some slighter lower, let's say, slower flow in the LED. But with this first image, which was like totally done in a normal pattern, in a normal way, and initially from when the patient came to the cath lab, she was totally free of symptoms, and everyone was like discussable why we overall took her to the cath lab, because she was totally fine, she was laughing and so on. And after this first image, we more or less, I was convinced that we won't find anything in the left system, but it was just the first angio, so casual diagnostic guide. And then the second image appears with this angiographic view. So the patient instantly, on the moment, she crashes with no pressure, with huge chest pain in her over her chest, a lot of emotions, a lot of understandable moments, what happened and so on. But like initially, the first moment when you see this, you understand what happened. So we have a dissection. I guess it happened from the guide, and we can discuss it later. So here we can discuss about what could be possible to do. So of course, surgery, we're a center which has cardiosurgeons nearby, so it could be a discussable option. So continue with the PCI with mechanical support. At that moment, we didn't have Michalis, so it was also, but there was a possibility to discuss. But at that moment, as everything is very instantly, the ICU was already called, and like everything was very, very fastly. So I guess I made my fastest exchange ever in my life. So we decided to go for the PCI, of course, that like we didn't have a lot of options, I guess. So this was the last, the second, let's say, injection with the EBU guide. For us, a workhorse wire is a Sion blue. So just initially hoping that we will get to the true lumen, and I was somehow lucky. So trying to use as less as possible of contrast, because as we all know, we need to try not to inject. So just initially somehow we were lucky, and the wire went into the true lumen, just a small puff of contrast just to understand what happened. Are we really in the true lumen, and so on. So of course, initially I took the first stent which we had on the shelf, more or less revising the first angio which we had. So just without a predilatation as the patient was getting worse and worse and worse. ICU was working and helping us, but still we didn't have like any stability. The patient was raising her arms and like very dramatic PCI and on like as we can all of us imagine. So just the first stent, just the pot, and initially we gained some stability with the patient, but still like it wasn't very stable in then. So we acknowledged the suspicious circumflex ostium, which also gave us some extra information why the patient is still not very stable and so on. Of course, in this overall pattern, it's very hard to understand what gains stability and what doesn't. But this circumflex ostium was, of course, considered to be doable and not to be left or some kind of a. So at that moment, for me at least, I didn't thought that it was like for me reasonable to go with a T or TAP. So I initially went for a culotte. So more or less status was okay. So we were considering imaging, but still very unstable. So maybe it would be reasonable to go with imaging. We can discuss, but at that moment we were just, trying to save the patient and just be fast as possible to gain flow to the whole left ventricle. So the second stent, and initially for the kissing, the fastest possible balloons, which we overall had on the shelf, at 3.5 to the LED and the 3.5 to the 6. And initially, only then we noticed this like borderline lesion in the mid-LED, which of course wasn't treated at that moment. And initially, the final angio was quite okay, and the patient was provided to the ICU. Of course, not stable, but with this result, I was happy at that moment. So, of course, continue. The patient was stayed in our ICU for like more or less a week. Then she fully recovers, and the ejection fraction was more or less 50% with a slight left ventricle insufficiency. So, of course, later the patient went to the cardiac rehabilitation, and she came back after more or less 3 or 4 months to me as her like providing cardiologist. So, of course, she remembered the whole thing. So she didn't have any chest pain. Her ejection fraction was more or less 55, 60. So, of course, we discussed with her about the possibility of like, we still have that lesion in the middle ED. And of course, she's relatively young, and the whole procedure was done very fastly. So we needed to recheck, but in a funny way, of course, we scheduled the whole procedure in the cath lab. But of course, after this experience, she didn't want to hear anything about any extra checks or any kind of visitations in the cath lab. So of course, some take-home messages, and like overall, from my point of view, so always be aware and conscious, especially with young female patients. Sometimes we hesitate, and sometimes we take as, let's say, a very fast and borderline patients, let's say that it would be just a diagnostic and nothing will happen because everything should be okay, but as it was the last case and so on and so on. So we really should be conscious, even in those patients, or like in the previous case, when we really have teratosis, when we see the problem and we're really ready for all the possible things could happen, then we're like on point. But in those patients who look healthy, more or less, when we see the first angio, still a lot of things can happen. Of course, never hesitate to ask for help. In the middle of the procedure, my senior colleague came, so it's always too good to have someone from a senior, like more advanced operators to help you, to be like stand by yourself. Of course, you need to talk about these cases and what happened to your stuff afterwards, because we just noticed after a few weeks that some of our nurses like didn't even understood what happened in the like why it happened. So and of course, like I just want to finish that, like you need to hope for the best and expect the worst in our scenarios and like in our work, and hope I have a good discussion with you now. Thank you.
Thank you for the excellent case, and I thought it was a great save there. I think for me there was 2 learning points to this case, and the first one is if you're going to develop chest pain, make sure it's early in the morning and not the last case of the day. And then secondly, this can happen very quickly and it can happen to everyone, so you need to be able to solve the problem that you've created very quickly, like you showed us. I just want to ask you something. What do you think was the cause in the first place? Do you think this could have been avoided?
You know, now retrospectively, I think like everything could be avoided, but as I guess everyone who delivers some kind of a complications in these cases, in this overall in our work, so we you really check those angios, what maybe you have missed, and so on and so on. And I'm not sure do you see it very well, but we consider that there was a plaque in the left main. It's not a big one, but there is some kind of a narrowness. It's maybe 20 to 30% or even less. As I was doing the whole procedure, I think that, you know, I didn't intubate it quite deeply, or it didn't happen that, you know, sometimes the guy jumps into the left main when you take out the wire or something like that. It wasn't that case. So I definitely think that it's a iatrogenic complication from the guide. Maybe as we didn't had any IVUS imaging, and we I speculate that this plaque was already there and you touch it with the guide, or maybe, you know, sometimes you don't need to be quite aggressive. Sometimes you just need to touch the lumen of the vessel of the Medina, and just sometimes it happens, especially from my perspective. Especially in young women with rheumatic diseases or smokers. It could be also a risk factor just to have in your mind that, you know, when you go to these patients, you should be really conscious.
Right. Any questions from the audience?
So again, a wonderful save, and I'm just going to ask the audience here, if anyone has never seen this or done this, please raise your hand. Okay, so we've got about 40 or so people in the room here, and 2 people who have said they haven't seen this. So it's, I think, just something to acknowledge. It happens to all of us. And but it's interesting. You pointed out the left main, that you thought there was maybe a plaque there. I wonder, did you ever get a chance to inject the right coronary artery?
Yeah. So as I mentioned, I just don't have the angio of the right. Somehow it missed, because now I'm working in the other hospital. But the right one was totally fine, crystal clear. Dominant right and without any lesions.
Okay. I mean, from where I'm sitting, the images are quite small, and I kept looking to see if there was any sign of SCAD, lower down, that might have explained why she presented with acute chest pain.
We also talked with her about that. So the symptoms were really quite mixed, and she really had a really, for her point of view, a really huge stress. A day before, her husband was in a car crash, something like that. So he was alive, everything was okay, but she was really, really stressed about the whole thing. And of course, SCAD could be an option, and we were discussing it about how we should treat it and so on. But in this case, as more or less the first angio was okay, and she pressed immediately on the table, and we already were putting glucose on her, but she with no pressure dropped very, very fast saturation of everything. So yeah, who knows?
Okay, yeah, because there's a few cases where someone actually did present with SCAD, although you said that her enzymes were only minimally elevated. So. Probably unusual here, but from time to time, SCAD is there, it's not recognized, and maybe after the second injection, the left main is dissected. I mean, there's something abnormal here. It'd be interesting, perhaps, maybe just out of academic curiosity, if you did a CT scan, would you see any coronary calcium here? She was a young woman, and maybe that she was truly going to have normal coronary arteries. But any other comments or questions? Well, thank you so much for your presentation and for being with us this afternoon. And again, excellent job. You're a young interventional cardiologist and you've already experienced this. So next time if this happens to a colleague, you'll be the senior person to come and help them.
Hope so. Maybe. Hope so.
Right. Thank you. Excellent case. So we move on now to Manuel from Germany.
My name is Emanuel Hurdakis. I am interventional cardiologist in Germany, in Trier. Thank you very much for the invitation. I will present interesting and complicated cases. Case entitled "Stay Calm No Matter What." Our patient, a 61 years old female, presented with angina and dyspnea on exertion. The transthoracic echocardiography showed mild reduced left ventricular function with apical akinesia and ejection fractions about 45% and mild to moderate MR. The patient was in sinus rhythm. The ECG showed negative T waves in the lateral leads. Her past medical history included three-vessel coronary artery disease and previous GABETs with Lima to LAD-1, RIMA as T-graft to CX and graft to RCA, combined with mitral valve reconstruction, left atrial appendage resection, and left ventricular aneurysmatectomy. Peripheral arterial disease was also known, and the cardiovascular risk factors were smoking and hyperlipidemia. And let's see the angio views. In the left video, we see the totally occluded LAD and CX at the proximal medial portion. In the middle video, we see the left ventriculogram with the apical akinesia and this interesting formation after aneurysmatectomy. And in the right video, we see the right coronary artery is significant disease, ostial and proximal and medial portion. After catheter engagement and contrast injection, engine injection, the patient was bradycardiac, and we documented a pressure damping in our monitor. At these points, I would like to mention that the bypass to RCA was at the proximal anastomosis complete occluded. Then we tried to cannulate the Lima, the left internal mammary artery, and we realizing the following complication. We faced an EMA, catheter-induced dissection of the left subclavian artery at the origin of the left internal mammary artery. That was a disaster. I must underline that the whole left coronary artery system was from this bypass supplied. And I would like now to ask the first question: how would you manage this iatrogenic dissection of left subclavian artery at the origin of the Lima? First option: emergent GABETs with graft to LAD-1 6. Standing of the subclavian artery to seal the dissection entry, or watchful waiting?
Can I just ask, what was the condition of the patient at this stage?
Yes, that's a good question. The patient remained completely asymptomatic. We have no ECG changes.
So this is a case when the operator has the chest pain and the patient doesn't. could you just tell us what catheter was used to engage the mammary artery?
That's a normal IMA catheter. Okay.
Shall we take a vote? Who wants to call the surgeon? Who's going to stent the left subclavian artery?
Maybe I will try not more than 10 minutes to wire Lima and to put stent ostially. Maybe I will try to do that.
Yeah, the problem is directly at the origin of the subclavia to the lima. If you put a stent in the rima at origin, we have the problem to injure the subclavian artery. It's not it's a difficult decision.
I have a stupid question, but would it be useful to ask a radiologist to come and give us some advice? Because I can tell you, I had a patient, I was probably your age, I was doing PCI through a Lima, and you know we have to pen the table all the time, and at a certain moment of time, I dissected the Lima, I lost the patient. Gone within 10-15 seconds. I have always remembered this case. So, well, here there is some myocardium that is, and other vessels are working, but I don't know, Annari, Malcolm, what do you think?
Yeah, so I had the same thought because it's a long time since I've been involved with this type of dissection. We had a run of them many years ago. I think over a period of 2 weeks, I think we had 3 or 4 of these for some reason. And I was very junior at that time, and I remember that David Holmes, who's renowned interventional cardiologist and really helped develop interventional cardiology at Mayo, made a point to our fellows never to use a right Judkins to engage the mammary. That's why I asked you about that. And be very, very careful because the IMA catheter is usually more coaxial. But Erica, in answer to your question, certainly at Mayo Clinic, the first people we would call would be the vascular radiologist, interventional vascular radiologist, because this is their territory. This is where they deal with all the time. But you wouldn't have a vascular radiologist to call, perhaps. So I think it depends where you're at. But certainly not the surgeons, not the cardiac surgeons. And then the other question is, so would you think about getting left arm access as well, to help secure things? But certainly we would be calling a vascular radiologist, interventional.
The point also, and I think everybody in the room agrees, getting into a memory is always an issue. And I don't know how you're doing. I'm most the lazy kind, so even I'm not selective, I don't mind, and I just pen along because the memory is always open. So I rarely go for selective memory injection, but I'm open for the floor what people do. Well, let's ask Tito.
I agree. I never use a JR4. Quite often, colleagues, fellows immediately try and go up with a JR4, but I just shy away from that. And I use an IMA catheter dedicated, or quite often we go from the left radial now for these cases, and use still an IMA catheter. But I would have a very low threshold for doing a non-selective image, possibly with a cuff around the upper arm.
So Eric, this is a great question. This is one of my favorite things to discuss in terms of being a little bit of an outsider in our lab with this. So first of all, to go left radial, we like to think, well, that's simpler. But if you're using the IMA catheter, very often the angle is not very good. The IMA catheter is made to come from the groin. So I think we've learned over the years that it's not so easy to do that. But I can tell you that in our lab, the vast majority of people go up with a Judkins right. They occasionally they'll try to engage the mammary, but then they'll use a long exchange wire and put a mammary catheter up there. I stopped doing that a long time ago when an interventional radiologist came to help me get up an innominate artery, and I was struggling. And I think I'd been on staff for 1 year. And I asked him to come and help me. And he said, well, do you have a catheter with a little hook on it or something? And he turns around and said, oh, I'll take that. And that's the mammary catheter. And 5 seconds later, he's up in the innominate. So at that point, and then going to someone else's lab, I've forgotten where, somewhere in Asia, I think, I saw that they would just always routinely just go straight up with the mammary to get into the subclavian, but not to try to push it up there, just go up with the wire, no exchange. And then, if you're struggling to get into the mammary, and look, we've all been there, tortuosity, and we're getting frustrated. I find that the blood pressure cuff, I think, is not terribly helpful. And again, what I learned from the vascular radiologist is I would then, and this is the few times that I'll use an exchange wire, I would exchange for like a 5 French pigtail, or even a 4 French pigtail. Make sure that the pig is really not straightened out. You just place that across the mammary. It's non-selective. You use 20 cc's at 10 cc's a second. You get images almost as good as selective injection, and it saves a lot of contrast, a lot of frustration, and saves the need to go to the left arm. And that's something that, again, I learned from the vascular radiologist. And the other thing about the vascular radiologist here is, unless you are an expert in the anatomy up here, you need to know, is this a left vertebral dominant, right vertebral dominant? I mean, there are some other things there that we don't think about as well, I certainly don't, as an interventional cardiologist. So as I said, this is their territory, and I think this is, if you've got them available, they're the ones to come and help you.
We didn't perform the coronary angiogram from the left radial. The left radial was used as graft for the right coronary artery. We have a vascular radiologist in our department. I asked for help. I called my chief, and we decided for a conservative approach. Also wasteful when waiting, also the patient remained asymptomatic, hemodynamic stable without need of catecholamines or mechanical support. The ECG was normal. We decided against ad hoc PCI, and we're planning the intervention of the diseased RCA and controlling the Lima bypass in a second procedure. We repeated the coronary angiogram 3 months later. The angio was performed from another colleague. He has difficulties in the right femoral coronary artery. The artery was severe narrowed. He implanted 2 stents, and after he reassessed the Lima bypass. There was no absence of dissection angiographic, and then he decided to perform the intervention of the right coronary artery. We're facing with another complication. One complication brought the next one. We dissected the ostial right coronary artery. We cannulate the right coronary artery with 6 French Jacques right 4. And we see not only the coronary dissection, but also the aortocoronary dissection extended up to ascending aorta more than 4 centimeters. And I would like to ask the second question, how you do approach this catheter-induced right aortocoronary dissection. Emergent ascending aortic replacement and aortocoronary bypass of right coronary artery, standing the RCA and watchful waiting of aortic dissection, or watchful waiting and RCA standing in a 3rd stage. Those are our 3 options.
So let's vote. And how's the patient feeling here?
The patient remained also asymptomatic.
So definitely you're conservative. So who would vote for emergency bypass surgery and aortic repair? PCI, the right. conservative. Of course, like an interventional cardiology audience.
We decided to solve the problem with stenting. We implanted 3 stents from medial to ostial. We achieved a good angiographic result with TIMI-FLOS 3, and we see also the aortic dissection membrane in the angio. We decided against operation. The syntax score was high with previous sternotomy. We transferred the patient to ICU, and after consultation with the cardiac surgeon, the patient remained in conservative approach. In the echo, we have no signs of pericardial effusion or aortic regurgitation. And 4 years later, the patient presented with angina. We repeated the angio. Unfortunately, we see angiographic that the RCA, the stents in the RCA were patent without progress of the RCA disease. The left coronary system was unchanged, and we reassessed the Lima bypass without dissection signs angiographic. My take-home message: use passive catheter in ostial lesions is crucial. Avoid repeat contrast agent injection in case of dissection that can propagate further the extension of the dissection. Conservative approach of catheter-induced coronary dissection may be feasible in asymptomatic patients without signs of ischemia. Aortocoronary dissection done in class 3 can be managed conservative without performing surgery in good selected patients. ICU transfer and monitoring should be part of the management of these complicated PCI cases. Thank you very much.
Yeah, thank you very much. And I think you got a really nice summary of the take-home messages. I don't think we have to go over that. I think so obviously courageous people in your lab to come back and shoot the mammary with a selective injection. I think I might have just gone up with a pigtail catheter, but I was actually thinking, why not to do CT scan? You know, so the early follow-up, I think, today you'll be able to see the subclavian. I mean, they probably do need to see the subclavian, and you should be able to tell whether the mammary is patent. So CT would be very, very helpful here. And I think that, you've, again, outlined very nicely what to do with these osteal dissections. And usually the dissection does arise from the ostium rather than in the aorta. And I think, you just demonstrated you can treat that very effectively. And it's great to see the 4-year follow-up to see there. But again, it's obviously brave people going up again, but I'm glad things worked out well.
The question for the audience is, has anybody seen this kind of complication heal? I've never seen this. Somebody has seen? Yeah, you can give me the microphone to...
We had a similar case in our institution about 6 years ago. It was a very local aortic dissection next to the ostial right, and after stenting of the right, the patient was watched for a week in the intensive care unit. She had a little bit of chest pain, but she was perfectly stable, and upon repeated CT, the dissection just is more like a wall hematoma than a true dissection, and it regressed very quickly.
We agree on the dissection of the right, but for I mean about the Lima.
Oh no, that I have never seen. Sorry, misunderstood.
Yeah. Congratulations for the case.
Thank you.
Quite complicated, but I wanted to ask, in this situation when you have antegrade dissection that might lead to propagation, when you treat conservatorily, do you have a protocol for CT scan, like to monitorize if it heals or if it aggravates, or?
We have no any protocol for this for a CT scan protocol. We have not. After the second complication, after the aortocoronary dissection, we didn't perform a CT scan directly. We had inject a lot of amount of contrast agent for the femoral PCI, for the normal angio and the PCI. So we avoided to perform after this complicated case another examination with CT scan. We control the patient clinically. He had no neurological signs. The pulse were for the both arm palpable. We decided not to perform directly in ACT.
That was my question, actually. How do you monitorize this kind of patients until they heal? Thank you.
Quick question. This person had dissections at the ostia of 2 different coronaries. Either, I mean, it seems more, could it be more than just luck? Could this person have some other reason for the endothelium being fragile? Because, you know, it seems unlucky to have 2 dissections at 2 ostia, almost one after the other. Well, there's any clues? Does anybody else have any idea of whether there's something?
I think there was a small lady with multiple arterial disease and the coronaries, in the femoral arteries. As I think there was, it has variable plaques. Frail, is there a frail?
Right, thank you very much. So we move on to the last case for the session. That's Hing-She Kim from Japan.
Hello, good evening, everyone. First of all, I would like to thank the organizing committee to have me here. I'm Kim Heng-Shi, Malaysian, currently doing intervention fellowship training in Japan. I'm from Okamura Memorial Hospital, Japan. My supervisor is Dr. Fumitaka Hosaka. This is my team. All right, so I'll start. Allow me to introduce my case. By the way, sorry, a bit nervous. By the way, my topic is perfection is imperfection. All right. So my patient is Mr. G. He's an 80-year-old gentleman. He has hypertension for more than 20 years. He's diabetic for more than 10 years, and he's an ex-smoker. So he was diagnosed with ischemic heart disease since 2011. As you can see on the top right, the angiogram shows a left main 50% disease, LAD of 75% with a D1 75% disease. So he underwent a left main LAD PCI with a DS3512 over the left main and overlap with a Cypher 3018 stent. D1 was treated with another Cypher 2513 under Ivor's guidance, and you can see the final result on the top, in the lower right. So he has his first ISR of a proximal LAD stent 8 years later. He presented with a typical angina. He diagnosed as unstable angina and a newly diagnosed paroxysmal AFib. So he was underwent an angiogram. As you can see there is a Cypher distal stent edge stenosis with ostia D1 and 80 to 90% lesion. So IFR of LAD was 0.65. So he underwent a second PCI. So the LAD was treated with POBA and a DCB, and D1 was treated with a Science 3012 stent. Okay. So because of a recurrent ISR, I mean the first ISR, so he underwent a reload angiogram 6 months later. FFR was 0.84, and you can see there's a mild moderate disease at the stent edge again. Because of FFR 0.84, we decided to defer the PCI and go for optimal medical therapy. So a lot of time we hope that everything will be okay, you know. So after the first ISR, so hopefully it will be nice and lovely fairy tale, you know, well, healthy, and hopefully we won't see them again. But unfortunately, this is not the case. So he come back this year again of a typical chest pain after 2 years, and CT initially go for CTCA, show possible ISR, and because of previous stent, there's an artifact, so went for angiogram. You can see there's a distal left main, tight lesion, and ISR 90% of a Cypher stent. Ostial circumflex look like there's an 80% disease there. So what we have now, so our patient, 80 years old patient, functionally class 2, CCS2, he has diabetic hypertension, recurrent ISR with IHD. LDL was quite okay. eGFR, I think 57 is quite acceptable for 80 years old gentleman. And EF was 42% with apical septal hypokinesia. The lesion assessment, we are having a median 111 lesion here. Distal left main, osteo-LAD, osteo-circumflex, and heavily calcified lesion here. Syntax 1 was 28, and syntax 2 suggests either PCI or CABG. And we go for definition criteria by a Prof. Chen group. So he fulfilled one major criteria and one minor criteria. And as per Prof. Chen study, there is a non-complex bifurcation lesion and suggests may consider to go for single stent strategy. I'm sure you agree with me, this is a complex high-risk indicated procedure. It's a cheap. Our patient is diabetes, advanced age, complex lesion, maybe plus minus ineligible for cardiac surgery, multivessel disease, left main disease, bifurcation, and calcification. All right. So our first question will be, what will you do? Call your, call your friendly surgeon. Hopefully your surgeon is friendly for single versus CABG of LAD, or go for CABG. Or you consider cheap PCI with 2-stent strategy and calcium debulking, or C, single stent crossover, calcium debulking, or others.
Did you at any stage consider why you've got repeated in-stent restenosis? Did you do imaging to try and understand whether it's going to just happen again in this case?
Actually, in our center, or maybe in Japan, is 100% imaging-guided PCI. So our center is either go by OCT or IVUS. So we prefer IVUS more, so all these PCI will go for IVUS. So previous PCI will show that there is a neointimal proliferation, so then decided they probed it, and the result was quite okay, so they did DCB over the ISR, cipher stent ISR.
Actually, you made a very good point, and if you're not aware of this already, in Japan, I mean, they are the world leaders in intravascular imaging. And some of it's so complicated, for some of the OCT work in terms of working out which strut you're going to go across. I mean, it's unbelievable. So many of you already know this, but if you didn't know this, incredible credit to the Japanese, and some of the Koreans also do this. I do want to pick up the thing about the, you've emphasized this elderly gentleman. And I know in Japan that patients don't want to have a scar on their chest. And so whenever they can avoid surgery, they will. But I do think, though, that you've got to have a friendly surgeon. I mean, it's all about teamwork, isn't it? And so whatever you can do to foster good relations with the surgeons, and vice versa, is critical to the success of your program. You do not want to be enemies with the surgeons. And I think in this day and age, I think we all get that, and I think the surgeons understand that. But there are lots of surgeons that would still operate on an 80-year-old person here, and he's got good targets. I'm not saying that he should have surgery, but I don't think we should just easily dismiss that he won't have surgery. But just a general point, and also depends on your surgical colleagues. But I didn't see anything here that tell me that he couldn't be a surgical candidate.
Yes. Our center is, we have 3 in-house surgeons. So, as you understand, Japanese are their advanced age. We have doing CTO PCI at 90 years old, it's not uncommonly seen. So after discussion with a patient, patient preferred PCI. So what we did was, we go for cheap PCI. So this is an IVUS guided PCI. Our access is a left femoral artery egg French. Our guiding is Roadmaster egg French 3.5 short tip. This is by Goodman. Our debulking strategy, we wish to decide after IVUS. So our center is a center able to use a directional coronary atherectomy, DCA. So there's old tools, but it's coming back again, especially in Japan. So it's worked very well with heavily plaque burden lesions. So DCA can do it very well under IVUS guidance. So if our IVUS show that there's a heavily plaque burden, then we'll consider DCA. And if it is a calcium predominant, then we'll go for rotablation. Let me show you. Okay. So as always, all these complicated cases always start with some tortuous here and there. So we have a tortuous femoral artery to begin with. You can see here, all right? So what we did was we used a 4 French diagnostic catheter with a mother and child technique, able to deliver the 7 French guiding catheter here, as you can see, all right? So this is a mother and child technique to sometimes to go through this kind of tortuous femoral artery. This is the first shot, tight calcified left main LAD circumflex through bifurcation, ISR lesion. I'm sure you agree with me. Then we wired the LAD with a SO 03 wire, circumflex with a Sion black Asahi wire. First IVUS of a left main LAD. So we'll pull back from a distal LAD to the austere left main. So you will see that there's a heavy plug burden over the austere LAD with a distal left main ISR, and there's a napkin ring-like calcification at the distal left main. How about the left main circumflex? All right. So this is a pullback, and you will see that there's a moderate disease of circumflex artery with a distal left main ISR disease. And to show you, this is a bifurcation 111 lesion. So this is a screenshot of the IVUS. So you can see that on the top left, that show that a heavily plugged burden, and on bottom left, there is a ring-like, napkin-like calcification, and on the right side is a mild moderate disease of a circumflex lesion. So what we will do now? Any taker, you know, bifurcation PCI with 2 stent or bifurcation PCI 1 stent. Anyone consider a hybrid with a DCB, you know, LAD, go for stenting to the left main, or DCB the circumflex, or, you know, any others thought? Okay, so I'll continue. All right. So, okay, so we decided, because of a heavily plugged burden over the austere LAD, so we decided to go for DCA, directional atherectomy. So directional coronary atherectomy. This is a short cartoon showing you how DCA works. So we will, because actually we heavily, in DCA technology, you heavily depends on the IVUS image. So what you need to do is you need to know where exactly the plug. So you direct the cutter to the plug. So then after that, you use some sort like a rotator. So then you will actually cut across the plug. Okay, so this is how DCA works. It needs a lot of IVUS understanding. I mean, I have never seen this before in Japan. So Malaysia's not having this. Okay, anyway, this device is called arteriocut. You can see that there's a balloon. It's actually a very bulky balloon. 7 French. You need a 7 French at least to deliver this balloon. So yes, 3 sizes: S, M, and L size. L size is the commonest DCA that we use, because most of the time we want to cut austere LAD or distal left main. So L size is 4.0 to 4.5. So you can see that the delivering of the arteriocut to the lesion that we wish to. All these are actually IVUS guided already. We will mark it, the position with our IVUS catheter. Then after that, we will not change our view. If you can see that, after this, all the view will be the same view. All right. So we will use the IVUS guided. That is how the IVUS guided PCI was done in Japan. So then we will actually do the cut. So patient underwent 39 cuts of using an arteriocut 9 mm L size. So the left side is a pre-DCA, the right side is a post-DCA. So probably here, you may agree with me, maybe there is some sort of luminal gain, but let me show you the spider view. So this is a spider view. I'm sure you agree with me, there is a good luminal gain of the austere LAD after the DCA. How about the IVUS? So IVUS of this is actually, I synchronized it already. So this is the same area of you are seeing. The left side is a pre-DCA and the right side is a post-DCA. So what's next? Actually, what happened now is actually we want to IVUS to the circumflex, but we cannot pass through our IVUS catheter into the circumflex across the stent strut. So we are thinking, should we do opening with an NC balloon or scoring, cutting, or rotablation? So I'll continue. So what we did is we actually rotated because of heavily calcification napkin ring. So we plan to rotate not into the circumflex, just at the point of the circumflex there. So we use a rota floppy wire to the circumflex, 6-round rotablation to the ostial circumflex with a 2.0 rotable at maximum speed, 240K. All right. So you wonder why is it 2.0 burr? This is an IVUS image. So the yellow color actually is the lumens, the vessel size. And you can see that the wire shadow is actually in the blue color circle. So we actually predict the 2.0 burr will rotate in such a way, then it's actually quite safe, and it's safe to use a 2.0 burr to burr the vessels to achieve a good luminal gain or debulking of calcium here. So the left side is before and the right side is after the rotablation. So there's a fracture of calcium ring with a reverberation sign indicating a good debulking here. So the normal PCI continue, pre-dilated circumflex with a Scoreflex trio. Scoreflex trio is a new Scoreflex balloon, also only in Japan. Apparently have two wire instead of one. So 15 up to 24 atmosphere. This is an angiogram after the preparation of with a Scoreflex trio. So after pre-dilatation, what we are thinking now is we are thinking to do a hybrid approach. Hybrid approach. So we are planning to stand across, as per definition criteria, we are planning to stand across the left main to LAD and DCB to the ostium circumflex. So before that, we decided to do a kissing balloon inflation to the left main LAD circumflex. Left main LAD with a Sapphire NC24 at 4.515 and a circumflex with a Scoreflex trio 4015. All right, it's the usual manner. Okay, so after the first KBI, okay, you can see that on the circumflex there's something there. All right, so we are thinking, should we do an IVUS there? So it's like, okay lah, maybe it's okay. So what we did is second KBI. So we did a second kissing balloon inflation at 18 atmosphere. The next thing, patient complained of severe chest pain. Again, I think we have seen enough coronary perforation. Yes, this is a coronary perforation. Okay, so maybe this is not so obvious. I have a multiple view for you to enjoy the coronary perforation. Okay, so multiple view. The reason of this multiple view is because we tried multiple balloon locations. So this is at the bifurcation there. So there is a good coronary, a contrast outflow there. You can see there is at least type 3 coronary perforation at the bifurcation left main circumflex. What we have now, worsening chest pain. Our patient hemodynamically unstable, BP dropped to 70/40, tachycardic from 60 double up to 110. Tachypneic of 24 to 28 beats per, breath per minute, and ABG stat was acidosis. Bedside echo was tamponade with the pericardial effusion. The worst, we unable to identify the bleeding point. We tried to balloon here, circumflex, LAD, left main, everything in the vein. So I'm sure we will do an emergency pericardial synthesis now, and I'll ask your opinion what we will do. Give a call to the surgeon, or you'll cover stand, or we'll consider reverse anticoagulation or prolonged balloon inflation, or all of the above.
Shall we take a vote? Who wants to call their friendly neighborhood surgeon? A covered stent. In which vessel?
I think no one like the surgeon. No people want to call surgeon.
Who wants to reverse anticoagulation? Prolonged balloon inflation? All of the above.
I'll try to block the vessel with the balloon to understand.
Yes.
I will try this 3 times with each vessel.
Actually, if you can see here, there's so many locations we have tried, so many. There's ostial circumflex, there is ostial distal left main to the ostial LAD, a bit further to the proximal LAD or left main. We have tried everywhere. So that's why you see this, I'm not sure is it wonderful, but I'm sure this is a very good diagram to show to our junior colleagues of coronary perforation type 3. Okay, I think the first thing to do now is take a deep breath, all right? I think if you are the operator, take a deep breath, okay? Take a deep breath first, and then need to have a very, very good team. In my center, if we are doing complex procedure, the whole team will be there. We have seven colleagues, seven coronary, intervention cardiologists or cardiologists in our center. So all will be there until the end of procedure, either CTO or either some sort of high-risk procedure. So the whole team is there. I think the teamwork is very important. And next thing is to have a lot of faith. Okay, so when you have a deep breath, when you calm your mind, the algorithm will come out, I'm sure. Okay, so this is, I'm sure you see this algorithm already. So we are having a type 3, Ellis type 3 coronary perforation here. Immediate balloon inflation, prepare for pericardial synthesis and hemodynamic stabilization. Sorry. Doctor, okay. So what we did is started IVI noradrenaline and fluid boluses. We checked the ACT was 300. Patient was electively intubated and sedated. Another team preparing for pericardial synthesis. We established a femoral vein 7 French puncture as a vascular access, and we changed the balloon, the NC balloon, to a Roussey perfusion balloon. So this is by balloon by Kaneka. So if you can see that, when we inject the contrast, there's a perfusion towards the distal LAD. So finally, we're able to stop the bleeding. This is actually using a 4.0 Roussey perfusion balloon here. So at this point of time, you can, sort of relax a bit, things are better, okay? So emergency pericardial synthesis was done. We have a PEC cell, a red blood cell filtering machine in our OT using by a cardiothoracic team. So we actually drain up all the blood and go through this red blood cell filtering machine and transfer back to patient. So heparin was partially reversed and SCT kept around 200. We prolonged inflation with a Roussey 4020 balloon. Left side is a 15 minutes. You can see that there's still a distal flow. And then 30 minutes, 45 minutes. And we are lucky. This is a 7 gods of Japanese lucky god, all right? 90 minutes of prolonged balloon inflation, this is a result, all right? So because of using a perfusion balloon, we're able to go for very, very, very long balloon inflation here. So, 10 minutes, 15 minutes of our time on the hemodynamic will be compromised. So with this perfusion balloon, we think that we can go up to 90 minutes. So you can see that there is a Dimitri flow to the distal. There's a dissection at the left main there, all right? We shall enjoy this, a lot of dissection here and there at the left main and things like that. So we did an IVUS. LAD left main, IVUS, pull back from LAD left main. You can see that what you will see later is there is discontinuity of the stent at the hinge point, all right? And there is a dissection and there's a perforation hematoma. So circumflex showing the same thing. There is circumflex coming now. So there is a crescent-like typical dissection hematoma. Okay, so later you will see that there is a discontinuity of a stent over the hinge point of the bifurcation. All right. So what we confirm that there is no extension of a dissection to the aorta, because if there is an aortic dissection, then the whole thing will be different. So this is a slower image. I slow it down so for you to enjoy the dissection, hematoma, perforation, and possible stent fracture. So because of, I'm sure you can agree with me, the left main are very big size. The minimal luminal area is actually more than 10 at this point of time. So I will need to later ask your opinion what we will do next. All right. So we are reaching the aorta. So now is out of it. All right. Okay. So patient hemodynamic more stable on single inotrope, pericardial drain in situ, ST elevation actually resolved. So this is angiogram after 90 minutes. I will ask your opinion. What we will do? We will consider to implant a DES over the LAD to the left main, implant a cover stent for cover up the dissection flap, or DCB, or we will do others. Shall we vote? This is the last question, actually. Anyone have any new idea? Great. I totally agree with you. All right. So what we did is we actually end the case. Okay. So because the reason of why we end the case is we think that the patient was hemodynamically quite stable, and then ST elevation resolved, and the MLA is actually very good, more than 10, and there's no aortic dissection. So for this point, we think that it's okay to stop, and we think that probably is the time to not to do anything, probably is the best decision. So whole procedure take up 5 hours, contrast of 160 ml, radiation of 3 gray, admitted to ICU, post-procedure extubated on day 3, the drain off on day 7. Although his stay have some fever and treated for aspiration pneumonia, repeated echo on day 9 show no new effusion, EF remained the same, discharge well ambulating on day 10. This case was done in March. We just see him 1 week back. He was asymptomatic. Initially, 1 week after discharge, we see him the first round. He was well, so we see him. This is the 3rd round we're seeing him in 3 months' time. So he was okay. We think that we will relook angiogram probably in 6 months' time, or maybe CT scan, maybe. Okay, if you invite us again next year, so I will show you the result of angiogram. Okay, so I have a few learning points. All right, complexity of chip cases actually is there. You know, management of coronary perforation is need to be well aware. Usefulness of certain tools, special tools, you know, like perfusion balloon and things like that. I think it's very, very helpful. So special attention towards the left main ISI and calcified lesion. ELIS 3, I mean, this is a ELIS classification, and this is a management algorithm. And we have a grade 3 coronary perforation, active jet, extravasation, active jet more than 1 mm. If you don't do anything for your patient having a type 3 coronary perforation, their life is in vain. All right, so what we did is accordingly, all right, we just continue to balloon compression and things like that, so there's no more contrast acceleration. Study have shown that there's a few predictors of coronary perforation: female, calcified, type C lesion, previous CABG, the use of ultraablative devices, older patient, hypertension, and you can see that all the yellow is what is in my patient. In summary, prediction of complication and preventing a complication is of utmost important when performing a CHIP PCI. And familiarization of management pathway with a helpful team is crucial when dealing with complication, especially when dealing with one of the worst nightmares for interventionalists, the coronary perforation. And last but not least, perfection is always the biggest enemy. Were it not sinful then, striving to man, to mar the subject that before was well, William Shakespeare's. This is my team here. All right, thank you very much.
Really exciting case. Just going to your summary there, talking about the prediction of complications. So you did extensive imaging before you started. Did you predict this? And secondly, if the balloon inflation, the prolonged balloon inflation, I don't think we've even got a perfusion balloon in our lab anymore, but this takes me back to the days before we were stenting. And it was always the last case of the day, 5 o'clock, and we'd sit there with perfusion balloons, sometimes for 90 minutes, you know, and we had no stents. But if your strategy had not worked and you still had the perforation, what was going to be your next step?
Prof,
fenestrated covered stent, or
for your first questions, I think the point that what we can change the whole thing is during the first kissing balloon inflation, there is some, you know, haziness. If we do an IVUS, instead of going for a second kissing balloon inflation, may have changed the outcome. I may have not perforated it. Maybe, you know, maybe there's some dissection ongoing, you know, we go for second KBI and all these things happen. So I think that we should not get, you know, it's okay. Well, I think this is a good lesson for me. We should just, you know, just take out the IVUS. It's probably an extra few minutes. I think maybe a change the outcome. So for your second questions, what we will do, our plan will be if it is not working. So what we will do is we will consider to DCB the circumflex. Then we'll stand across it. We'll stand across it first, and then we have a look. I mean, if there's only dissection, you mean, Prof, you mean? perforation. If perforation, then if no choice, then we will consider a fenestrated covered stent. So we are using a Biotronic covered stent. So we will do that, and then probably after a certain day, we'll come and do a long CTO again, and hopefully we have luck on that. Yes, doctor?
Can you tell us, please, about the total duration of this investigation? The total duration of procedure?
5 hours.
5 hours?
Yeah, 5 hours.
Respect.
Thank you. I think the perfusion balloons, there is something particular that people in the others may know or not know, is that in Japan there are many devices, excellent devices, that do not leave the Japanese market. With all my respect, because we love your cameras, we love your cars, we love your culture and the food, but please export also the devices that we need.
I hope that, because when I was in Japan, you know, I have never seen a Scoreflex trio. Scoreflex have trio is our Scoreflex is 1 wire, right? So their Scoreflex trio is 2 wire plus a coronary wire, so it's a 3 wire kind of cutting balloon. You know, scoring balloon. So it's a new balloon only in Japan. Well, in Malaysia, I never see that. I mean, arterial cut DCA is only in Japan. That's like everything is only in Japan. I don't know how to live when I back to
Don't take it personally, and don't take it personally. Tito, we have a short comment because then we need to go on.
I was going to ask about the perfusion balloon, because I think that could be is a game changer for a lot of the cases that we've seen today. I keep hearing that these perfusion balloons used to exist like many years ago, but they've not been around in the time.
We used them to treat dissections before stents. And then we put the perfusion balloon, and then we brought in some chairs in the cath lab, and we sat down and we waited.
I mean, is there any scope to bring them back, or if Japan, with respect, won't sell them us, can we make them in Switzerland?
Currently, it's carried by Kaneka in Japan, called Rusei perfusion balloon.
On the other hand, I think it's also culture. I'm not sure if we have the same cultural patience to wait. You will not be able to wait. Don't give it to Nikolai. It's worthless. You agree?
Okay, thank you very much. Thank you.
Thank you to all of the speakers. I thought there was an excellent session, and I think we're moving on now to the second last session of the EC.
Hi everyone, it's my pleasure to introduce Iulian Theodor Matei, who is a consultant interventional cardiologist in Iași, Romania.
Hello everyone. Eric, thank you for the invitation. It's great to be here. Fantastic. So I'm from Iași, Romania. I work in the St. Spiridon Hospital. And today I'd like to share with you more simpler complications case. It's a returning to the basics, and it's quite hard to come and share this case after what you've just seen from Japan. But I think there's a strong message to be sent, so let's go with the case. The case is the case of a 78-year-old patient with recurrent chest pain for 3 days prior to the presentation. Actually, his symptoms started 6 months before. He was hypertensive. At the presentation, the clinical examination was quite normal. The troponin was at about 140 nanograms per liter. The ECG and the echography showed ischemia in the inferior territory. So he went to the cath lab, and now we see a quite normal coronary artery, right coronary artery, with a retrograde injection of the distal circumflex and another diagonal branch, small diagonal branch. And let's go to the left coronary. You can see there's an ostial stenosis of the LAD, also another stenosis in the mid part of the LAD, at the bifurcation with the second diagonal, which is a little bit hazy maybe, and a chronic total occlusion of the circumflex artery in the mid part, a JCTO0 score. So I don't know if you consider that's a PCI versus cabbage situation. Needless to say, the patient preferred PCI, but of course syntax was calculated, a syntax score of 44, syntax 2 showing that cabbage or PCI might be both an option. And what I wanted to stress is that when I started the PCI, I wanted I advised to have a complete revascularization. So I decided to start with the circumflex. Luckily enough, that supposedly chronic total occlusion maybe was not that chronic, but I had the chance with a little bit of work, to pass the lesion with a PT graphics guide wire. I predilated with a 1.5 and a 2.5 balloon. And then I implanted a 2.530 drug-eluting stent in the circumflex with the result here on the right. So keeping in mind that the contrast dose was not that high and was quite small actually, and the radiation dose also, I went on for the LAD. I put a workhorse guide wire in the distal LAD, another one in the diagonal, of course a simple lesion, so I said I will go with the direct stenting. I implanted a 2.75 over 26 millimeter drug-eluting stent. You can see the result. And then because I was thinking also about the ostial LAD, I said, okay, I'll speed up a little bit of things. And I went with the guide wire switching, and so I rewired the diagonal. I went with a small balloon, 1.5 balloon, and then I dilated the ostial diagonal with a 2.5 over 15 millimeters balloon. Afterwards, I went on with the kissing, so 2 balloons of 2.5 over 15 millimeters non-compliant balloons. This is the kissing, and then this happened. And of course, it's obvious that the guide wires were pulled out with the balloons. This is not a complication that I wanted to show you, is this one. So I had an instant acute thrombosis. So what's to do? Of course, I rewired, I aspirated the thrombus, I started eptifibatide, and then I obtained TIMI-free in the both branches. But as you can see, there is still a big thrombus left in the stent at the level of the bifurcation. So what's the next step? What happened? Well, as Alex, my colleague, said earlier, we didn't have ACT at the time. The case was done a few months after our service was started. The cath lab was really, really young, as are us. And then, so I didn't know, but actually the procedure was not in a such farther away since the heparin was administered and the dose was all right. So I was pretty confident it's not, that's not a problem. The antiaggregants were administered. The patient was on ticagrelor and aspirin. Thought maybe there's something about that plaque. Maybe it's a thrombotic plaque that caused it. I couldn't do no intracoronary imaging. I don't know if anybody would have done anything in this idea with that big thrombus over there. So actually, now I was in the position to choose between risking to embolize that thrombus and to try to understand what I did and to treat that thing, or to opt for a deferred stenting strategy. And I have to say that I did my fellowship in Annecy. It's just across the border, very close to here, another beautiful town of the Alps. And I was guided by Dr. Bell, who is one of the main investigators of the MIMI study. They were trying to investigate if deferred stenting in STEMI has a good effect or not. As we all know, the study was negative. But quickly afterwards came the SuperMIMI study, which showed that actually when you have a high thrombotic burden patient, the first strategy is safe, absolutely safe, if you have GP inhibitors. So this is what I did. I left him on eptifibatide, I left him on heparin, and after 5 days, this is the image that I got, so no intrastent thrombus left, and the ostial LAD to treat. So what finally happened? I tried to understand that. I did a stem boost. I don't have the image, but you can see here on this 25 frames per second image. I hope it's easy to see. Actually, we're talking about a longitudinal crush. And I think it's because when I got a little bit in a hurry and a little bit enthusiastic about the procedure and trying to get to the left main, I didn't do the pot. So when I pushed the 2 balloons, I think this is what happened. So what to do now? I post-dilated the LAD stent with a non-compliant 3.014 millimeters balloon to get a good expansion. And then I proceeded with a long stenting from the left main to the LAD, not so long, but 3.5 over 26 millimeter drug-eluting stent. I did the distal pot with the same balloon, so before the bifurcation, before the carina. And then I finished with a pot at the level of the left main with this aspect, and this was the final result. So, my messages are that intraprocedural stent thromboses are quite rare now in the drug-eluting stent era, but we have to pay attention especially to the bifurcation treatment. And if you think about mechanical complications during PCI, we have to know that longitudinal stent deformation is one of the most encountered complications. So at the end, the take-home message is do all the steps that you have to do, hurry but a little bit slowly, pay attention to what you do, and don't be afraid to leave the patient on anti-GP2B3A and anticoagulants, because everything is going to be fine. In my fellowship, during my fellowship, and now I never had problems. I know some people are a little bit afraid of doing it, for not getting called during the night to come and do the angioplasty, but I think everything's fine. Thank you.
Thank you very much, Iulian, for this great case. Any question from the audience?
No, maybe just a comment. This is the hometown of both of you, so Iași is a very nice city in Romania. That's my only comment.
Thank you very much.
I have 2 questions. Maybe you said it and I just didn't get it. How long after the beginning of the procedure did this thrombus happen?
We were like in 20 to 40 minutes, I think, since the procedure started, because actually the CTO was not a real CTO. You know, I think it was a recent thrombosis, so.
Okay, and as you say, you don't have ACT. Do you do repeated heparin bolus? How do you manage?
Yes, actually, after 40 minutes, we do the first dose of 100 units per kilogram of heparin, and then every 40 minutes, we do another 2,500 units of heparin, and we try to be quick, and we try to not take such a long time, you know, to finish the intervention. Usually it's fine. We have to pay attention, but.
Okay, thank you.
Thank you.
So you're going to swap chairs, and Natalie is going to present.
Good afternoon. So today I'm presenting to you my complication. It is about a 73-year-old man. He had as past medical history a STEMI in 2002 and a stent on the LAD. And the actual history is that he's consulting for a persistent angina. Here is the electrocardiogram, so no doubt, it's a ventricular tachycardia. This was in the ambulance, so he was treated with amiodarone, which was non-efficient, and he underwent an external electric cardioversion. And here is the electrocardiogram in sinus rhythm. So we can see that there is a scar in the interior leads. And when he woke up, he didn't experience any more chest pain. He was stable hemodynamically. So he was surveyed in the ICU in order to make troponin tests and echo, and he didn't have an emergent coronary angiogram. In the ICU, the troponin were very high. He had a left ventricle ejection fraction at 45%, and little hypokinesia in the interior wall. And I received him in the cath lab. It was a Friday afternoon for the coronary angiogram. We can see it's a left dominance, so nothing special on the right. There was non-significant stenosis on the circ, and what's happening, what we are interested in is an instant restenosis of the mid-LAD. So I thought, okay, it's fine. It was the last case of the day. It's quite simple. It's going to be quick. I would like that you take a deep look on the angiogram, because what I saw at that moment is that the lesion is, so in a stent, there is a first little diagonal branch, which is really a little and tiny, then a big diagonal branch, and then little stenosis afterwards, which is quite distal. So at this stage, I thought, okay, a balloon, a stent, and it's fine. So for the stenting of the LAD, I pre-dilated with a 3.0 semi-compliant balloon, inserted in a Gaussian stent, and this is my result. So I see a little dissection at the edge of the stent, so I thought, fine, no worries, another stent, and then it's perfect. And here is what happened after the second stent. It was a 2.5 millimeter stent. So I inflated the stent, and you can see here that it's underexpanded at the distal part, and unfortunately, the underexpansion remained after the deflation. And what happens also at this time is that I couldn't retrieve the balloon of the stent. So I was here with an underexpanded stent and with a balloon trapped in the stent. So at this stage, what can I do? First, insert a parallel wire and try to inflate a small balloon in the same way as when rotablation burr is entrapped. Second, make a high inflation of the balloon in order to burst it. Third, try to perforate the balloon with a CTO wire or any other solution, call the surgeon, or maybe someone has another idea. What would you do? Who would do one? Okay, two. Okay. Oh yeah, so what I didn't say is that I thought, okay, maybe there is too much contrast. So I retrieved all the contrast. I tried to inflate it with only water, but it remained still stuck in the stent.
Now it occurred to me. A 5 French guide extension carefully placed inside the stent just at that region of cramping, maybe to have some pulling force with the guide extension.
This is an interesting idea, but it means you have to cut the shaft of the balloon. And so once it's cut, it's over.
Yeah, he can do that.
Okay. Okay. So here was what I did. So I tried to pass a parallel wire with a small balloon, but it didn't cross, in fact, next to the balloon. So then I called my colleague in chief for some help. He told me, okay, let's try to enhance the support with a microcatheter. But what happened at this time is that, so there was another wire in parallel. We advanced the microcatheter, and while we were advancing the microcatheter, the wire went into the first little diagonal branch, so it kept moving forward. So he told me, no worries, you'll see it's gonna be fine. And but unfortunately, after many attempts, we couldn't pass just after the balloon that was trapped. So we did an angio because the wire had a really strange way. And here what we saw, so what you see here is not another branch, it's a perforation of the distal part of the little diagonal. And at this time we asked, okay, how is the patient? Does he has any pain? No, he was asymptomatic, hemodynamically stable, there was no pericardial infusion. So we had to act fast. So what happened at this time? We think that the wire perforated the diagonal, and the perforation drained into a vein. That's what made that the patient remain stable. So we had a little time just to act. And at this time, we still have the balloon trapped in the stent. So, and the mechanism of this perforation was that we were in 6 French. The balloon is still here, and so the wire and the microcatheter didn't have that much place to advance. So every time that we were advancing the microcatheter, the wire was moving with, because there was not enough place to move the whole thing. So at this time, we inflated the balloon very high in order to burst it. At first, I didn't want to do this because I was afraid that the size of the artery was not enough. And then we treated the perforation. How should we treat it? What do you propose? So first, prolonged balloon inflation, a cover stent, distal embolization, other option. Who votes for 1? Okay, 2. Oof. And 3. Okay. Other option?
Is it necessary to treat it?
Yeah. I mean, we didn't feel that comfortable with it. Okay, so we did a distal embolization with a microvascular plug. Do everyone know this device? It's mostly used by vascular surgeons or vascular interventional doctors. So it can be used in small artery between 1.5 to 3 millimeters, and it's the same principle as the coils. The advantage is that it's retrievable, so you can really replace it if you think it's not in the good position, and you just have to unscrew it in order to release it. And you have also to use a bigger microcatheter because it must be large enough to deliver the device. So we used the ProGrade, which did not cross, in fact, into the diagonal because of the stent that was already there. So we dilated the ostium of the diag. And here is the release of the plug. So we controlled that it was in the good place. Can you just play the video to the left, please? It's just the control that we're in the good position. No, the other one? Yes. Not working, no worries. So then we retrieve the microcatheter when it's in the good place, and we just unscrew the plug. It's very easy, simple, and safe. And so Eric always said it's not expensive, but in fact, it is.
I thought it was not expensive. I told it to everybody, but it's not true.
So then, after all this drama, we thought, okay, maybe we can assess better the artery, because at first, visually, didn't seem that calcified, and we had many troubles. So we did some IVUS. And what we saw, in fact, is that the stent in the proximal LAD was underexpanded, and the right side of the artery was rather 3.5. So our colleague is not here. We did something dangerous for the one who were here yesterday. So we did shockwave in the under-expanded stent, 2.5, then OPN in all the balloon portion, proximal optimization with a 3.5. We did an IVUS to control that we had a better expansion of the stent. And here is the final result. So the perforation is sealed, the stent is well opposed. There is still this little stenosis, but after all the procedure that lasted 2 hours, we thought it could be fine to stop here. So the take-home message is that it's an expected complication in an apparently simple in-central stenosis. This learned me not to underestimate calcifications. So there is the utility of the stent boost, but also of the guidance with the IVUS or OCT. And what I do now more frequently is that when I have a in-central stenosis is to use a cutting balloon, because it helps not to, that the balloon doesn't slip, and it's helpful for the balloon dilatation. And in the end, a coronary wire can become a weapon. Thank you.
Thank you, Nathalie, for the wonderful case. If there are any questions, if not, I'd like to.
The only thing I can say is that the mistake is totally on my account. I have to pay for this one, because I just came in with Nathalie, and I used to just gently advance microcatheters over regular wires. But this in the setting of a freely 0.14 wire in a guiding catheter, because there is place. And I said to Nathalie said, can you do this? Of course, I do this all the time. She didn't want me to do it, but said, oh, let's do it, it's no problem. So when we were advancing the microcatheter, we saw the wire going more and more deep. Nathalie said, you're not scared? I said, don't worry, it will stop. But it didn't stop. It went all the way up to a moment I said to Nathalie, I think now we are too far. So when we pulled out, we had the perforation. And of course, you can say, do we have to treat it? Because it's probably going to a vein. But on the other hand, if you have complication, if you can solve it, the device costs $1,500. Sorry, it's a bit expensive, but try to solve it. Yeah. Maybe wait for the microphone. Nikolai, who has a
I would suggest a slightly other way on, instead of using a coil or some fat embolization, I would suggest you can consider to use a absorbable suture. We have tried to use a Vicryl 3.0, cut it into a few pieces, then you just stuck across the microcatheter. And the good thing about it is it's absorbable. After 6 months, it will disappear. So the result is quite okay and very, very cheap. It will cost less than maybe.
Yeah, it's very popular with the Hong Kong colleagues. They promote that this come from this is a Hong Kong style.
Yes.
But indeed, it's a good trick also. Yeah.
Yes, you can consider that. Just cut.
Yeah, you're totally right, but it must be well performed. You must have a balloon that occludes the artery and which is OTW and is inflated, because if it's not the case, it can go distal and into the LAD.
Actually, you just you can use a microcatheter. You just, if you're able to wire down, then microcatheter, and then just use cut the small pieces of suture, and then just stuck it across, just like you're doing.
Sure, but
embolization. You can try it next time.
What I meant is that it's like a septal embolization. The artery must be totally occluded. Otherwise, if it goes back, it can go in your main artery, and then it's the drama.
I agree with Nathalie. This looked like a big, it could potentially embolize into the vein. So then maybe it would end up somewhere, I don't know where.
Sure, but it's a suture, so nothing will happen.
I agree.
Nathalie, can I ask you another question, please?
Yes, sure.
Can you describe a little bit more how you check the position of this small plug, and if it's difficult to deploy, and does it have like some vicious position possibilities that you don't get to occlude the vessel, or It always works, and it's really, really simple. And
You mean about the plug?
about the plug, yeah.
Oh, so we just did a distal injection. That's it. And if we can go back. But it didn't work. It's the video that did not work, in fact. Here, can you just try one more time, please? The left one. The one to the left. No. So anyway, there is the microcatheter. We just inject some contrast. We see if it's distal enough or not, and then we just move the microcatheter, and it's just how it works.
Thank you.
It's very easy. I use it also for coronary fistulae to the pulmonary circulation, because it even goes in sizes up to 7-8 millimeter. Then it's of course much more rigid, but it can go, because coils are not made for this coils, they don't deploy well in the very distal situation. But there are now detachable, and there are now coils that are also like the wires that are resorbable. There are very small coils, but I have never used them until now, but maybe I'll use that next time when we have a distal perforation. But still, this is a nice tool to have.
Are they cheaper?
The smallest you can put up to 1 millimeter. 1.5 is no problem.
Okay, thank you very much. Once more. And we invite Dr. Harbaoui to share a case with us.
So hello everybody. Thank you for the invitation. Thank you, Eric, for the organization of this wonderful meeting. I'm very happy to be here in Lausanne, back to Lausanne. So today I'm gonna present and share with you a complication of a TAVI case, a sinuous TAVI. So it's an old man, 93 years old, but in a good shape. He's gardening and drive his car. He has peripheral vascular disease and chronic obstructive pulmonary disease. He has a severe symptomatic aortic stenosis with a good LVEF and a mean aortic gradient more than 15 millimeter. And he suffers from shortness of breath and anirakasha at 3. So I told him, okay, for TAVI, if the transfemoral approach was feasible. So here is the MDCT, and as you can see, it's not so easy. Are you still okay for a transfemoral TAVI when you see this? What do you think? For example, Marion, will you perform a TAVI from a transfemoral approach? So we see that it's very, very tortuous, and there is a lot of thrombus. We call it shaggy aorta. This is a very high-risk patient. This was our job 10 years ago. All patients had very shaggy aorta and high risk, and were with a high risk procedural complication. So aortic tortuosity and shaggy aorta are at high risk of procedural complication. So this is an illustration. It was my case also a couple of years ago, not this patient. You can experience stroke, embolization, aortic damage, dissection, valve failure. So the next step was to discuss again with the patient and his family. And the patient aim was to improve his quality of life. And he said that he wants to live only if he can garden and he can walk, but he doesn't want to stay at home and do nothing. So even though it's a very high procedural risk TAVI, they wanted this TAVI, okay? So no general anesthesia, no surgical conversion if there is any complication, So everybody was okay for transfemoral Edwards S3 TAVI. What's the next step? It's the pre-flight plan. Okay, it's mandatory for TAVI, especially in high-risk TAVI. So we discussed local anesthesia, right transfemoral Edwards S3 TAVI, sheath introduction on an extra SIF wire, left radial secondary access, cerebral protection device with a third radial right access, double wire technique, body balloon, rapid pacing on left ventricle wire, and predilatation to avoid forcing. So let's go for the cerebral device protection at the left-hand side. So the first time I use this device, so there is a beautiful tuto in YouTube, but not so difficult to insert it. At the right, you can see that it's very, very tortuous aorta, and the sheet was inserted in an extra stiff wire. We were confident. So here you can see the coplanar view with a very horizontal aorta. And it was very difficult to cross the valve, but 25 minutes later, we managed to cross the valve, make an exchange with the pigtail, and then to put the Safari Small in the left ventricle. So we performed the predilatation and progress with our valve with the double wire technique to cross the aorta. We had the backup Meyer wire in the left radial in the descending aorta. So it takes a little bit of time. Then a couple of minutes later, after chapel wire technique with the backup Meyer and the Lander Quist, we were here very close to the goal, and the atmosphere was quite good because we thought the more difficult thing was behind us.
Can I ask you a question, Brahim?
Yes.
I just wonder, where is the balloon markers of the valve?
So as you can see, there is the central marker is here. Okay, you have a marker here, okay, and the other one is here. So sometimes we have this situation, but it doesn't matter. So yeah.
Very tortuous aorta, so I'm a little bit afraid if it's enough long, the sheet and the valve introducer, because it's sometimes we in this kind of situation you are near to the skin and we have no more place to push your.
Yes, I agree, but here you can see that we are very close to the goal. So
I was afraid just before.
Just before, yes, I agree. So here we were happy. Okay, we decided to implant the valve, and this is what happens. So at this time there was silence in the cath lab. We were very close to the goal, and we don't understand everything like this goal. Okay, it was me, exactly the same. So just for the fun. So after valve towing with a semi-inflated balloon in the descending aorta, I implanted this balloon so in the descending aorta, and we had to implant the valve at the right place. So again, a couple of minutes later, we were very close to the goal. But this time was the good one, and we implanted in a quite good position with an acceptable result. You also did the control of the second valve, just to be sure that we are not in front of a main digestive artery. And unfortunately, during the follow-up, despite a good anatomic results, the patient developed a coma with a Glasgow 3, and the cerebral scanner showed multiple ischemic strokes despite the cerebral embolic protection device. So the take-home messages of this case is that sometimes it's more difficult not to do than to do something. It's very easy to put a stent or to put a valve, but sometimes it's very difficult to say to the patient, no, we are not going to do this intervention because it's too dangerous for you. And this is what we should have done, I think. And when the aorta is severely tortuous, the pre-flight plan is very mandatory. You have to use a double, triple wire technique. You have to predilate. Sometimes you need a very long sheet. And you have to think about an alternative access, carotid or axillary. Thank you for attention.
Thank you, Brahim, for this amazing case. Someone has questions? Yes, Christian?
This kind of situation, maybe if you don't retrieve enough the pusher under the 3 markers. So at this situation, this is first one, and the second one, I think the problem that Eric said that it was because you push very strong, so it's a little bit the balloon is a little bit forward, and this is one of the situation. The second one, sometimes if it's the pressure it's not sufficient low, and it's sometimes it's you need just one extra beat, and
yes,
the valve.
As you can see, it's not an extra beat because the balloon is in the right place. When you have an extra beat, you also have the balloon that do a pop-up in the aorta, and the pusher is, I think, in a good place. You can see. So we were a little bit surprised.
Okay, excellent case, really nice. But I have a question about the sentinel. Did you find anything in the sentinel, in the protection, embolic protection device?
We found some debris. Okay,
nothing special.
There was a lot of debris also in the brain.
Yeah, that's the problem, because the conception sounds good, but we don't have any strong evidence, and we are waiting for a really big randomized trial. This will be presented at TCT probably, and we are waiting for the results.
An excellent case with, I think, lots of teaching and learning points. Do you think it would have made a difference if you had used a different device, maybe something like the Pro Plus or the Portico, but being more flexible, possibly?
For the second valve implantation, it's possible. But for the stroke issue, I think whatever was the device used, I will have a stroke because the thrombotic load of the aorta was very, very high.
Okay, maybe one last question, please, Ibrahim. The patient was 93 years old?
Yes.
Am I right? Have you considered only dilating, doing a balloon dilatation and maybe not going on with the TAVI? Or do you think it's not worth it at all?
So when you do a balloon dilatation, you take the risk of the femoral approach, of crossing the aorta with the thrombus. Even though it's smaller than TAVI, it also carries risk. So when I have this case, I put a valve.
If you risk it, go to the end, right?
That's quite conceivable today. Yeah. One last, and I think we have to conclude.
In the recent guidelines, it's recommended to have valve next door, just in case if you have a huge aortic regurgitation. But if you decide to perform only BAV, you can do it with 2 balloons through both radials. It's a nice technique that you can use.
Okay, thank you so much, Brahim. I think we needed. I think we needed a great case to end. I think, Malcolm, time to call you up front. We are going to close the meeting. Can we have the closing slides, please? So we just, I forgot we had to stand here. Can we I just give you a few slides through the internet for this closing. Yeah. So, of course I have to move forward myself. So, usually, but unusually, but not, I would like to thank first the sponsors who made this event possible. You can see them listed according to the support. I think this is logical. I think without the industry, it would not have been possible to have this meeting organized. As mentioned 2 days ago, we are living in difficult times. We had one major event that struck the planet, and we have a second one now ongoing, and we still have tried to pretend that we are happy and everything is going well, which is of course not the case. We were able to set up the meeting. We were able to have 150 people physically present, and I was amazed to see people from almost all continents. In the very previous days, we had up to 40 to 54 countries here in Lausanne in the golden days before everything went wrong. But I think we'll have to look forward and be positive. I think if you are not positive, life doesn't make any sense. We learned that from many lectures during the previous days. So first of all, real thanks to the sponsors. This meeting always, and like all meetings where we show complications, is characterized by awards. We recognize 3 cases that we thought were different, and since ever, Malcolm has been chairing. We just put up a committee with Tito and Annari and we just discussed a little bit the cases of the day. Now it's extremely difficult to decide, because I must say that after all these years, I think I will have you comment a little bit, Malcolm. But I think I have no souvenir of having so incredible cases, and also the CHUV guys over here who have been around for a while. Exceptional year from Friday afternoon until there is no. Of course, we must be honest. Some cases are more boring than others, but globally we have seen exceptional cases. So in times of winemaker, I would say it was an exceptional crew this year. So Malcolm, ask you just to make some comments. So what we offer to the winners is basically we take care of the logistics for these people who will be part of the faculty for the next edition of ECC. That's the deal.
So when will that be?
Oh, that was my last slide, the future.
Okay, all right.
But I'll come back to that.
So keep you in suspense. Just before I announce the awards here, I'd also just like to echo what Eric has said, but also just to thank, I mean, you're the last remaining attendees here, so give yourself a good shout out for that. But you can't have a meeting like this to be successful without people attending. And under these difficult circumstances, I just want to thank you for all making the effort to come here. And it certainly made it worth my coming. I mean, as I said yesterday, this is the first time I've been to Europe in 3 years. I've missed it. I've missed seeing my friends and colleagues and people I've now learned so many things from over so many years. So I'm looking forward to the next big in-person meeting, and as I said, we're going to keep you in suspense there. When it comes to making the decision about the awards, it's always very, very difficult. The presentations have been fantastic. We look for all sorts of things, maybe the uniqueness or singularity of the complications, and I mean, that's what we're presenting. It's complications. We had a few fatalities here. We've ended with a fatality. And so I think that it always takes courage to present these cases. Sometimes it can be really awkward, and we've never really discussed the medical legal aspects of it. That may be something for us to think about in the future. Certainly in certainly in the United States, I mean, there's some sensitivity about this, and particularly in terms of, again, Twitter. I brought this up yesterday, and again, I was on Twitter for about 6 weeks and then got off Twitter. It was going to just destroy my life. But I understand that many of these complications actually appear on Twitter, and I think we have to be careful because they can easily be triangulated in terms of where that complication occurred, and just like the United States, I'm sure that there are ambulance chasing lawyers around. So there's something for us to we've never really discussed that in great detail, as I recall.
It has always been the objective of a session here at ECC, but we didn't make it. We had one with the South African friends quite some years ago, where we had a pathologist, a lawyer, talking about, but we haven't done it here, but it has been done.
Yeah. So anyway, as I said, looking for the uniqueness of the cases, the way it was presented, the preparation that obviously went into those. I think it's the recognition of the complication, and then the thinking behind the strategy for now solving the problem, and then how it was executed. And at the end of the day, it's those learning points that we have, and when you put it all together, really, what was the value of the case? And as always, the value is really high amongst all. So it's really difficult to pick out the so-called winners. But I'll not keep you in suspense any longer, but with the help of a handful of us here to review these, and this is in no particular order. Everyone's getting the same prize. So the first I'm going to announce is Paola Mota from the UK. The only sad thing about that is I didn't see the case. I was still flying in to Geneva, but I understand it was quite a case. And I don't know if you want to say anything more about that.
And she's flying out at the moment. So no, I think indeed she was standing here. I think there was a lot of pressure on her shoulders. She was one of the last cases of Wednesday, his lady, and we had, I would say, quite some aggressive comments from the participants, where we had at a certain moment to intervene. But she did very well, and I think nothing else to say about the case.
Our second winner actually was online, Zimasa Jama from South Africa. You'll remember this case of the older lady. I think she'd had 2, maybe 3 surgical procedures, and there was the attempt to put the mechanical valve across the mitral valve. But there were issues about what was going on with the hemodynamic collapse, the limitations of the immediate echocardiography, and then some of the other imaging that they used. But it was really a dramatic case, and they solved it really well. And again, just brilliantly presented. And I think it's really hard doing it when it's online. It's something that we're not used to doing, and obviously over the last 2 or 3 years, people have become really skilled at doing this. But it was a really dramatic case, and again, very well presented. And then the final winner here is Jacques Auslender from Belgium. And that was the case we heard this morning about the PFO that found its way into the distal aorta. But it was, again, a very neatly put together case. But I think one of the things which I've actually found really very good, the way it was put together, was the way that he described, the strategy, and actually having some time to think about it and not rush in to do something, and really, worked out that strategy with the double snare technique. Took us through that very nicely, and again, simple procedures can suddenly become really complicated, and hopefully. No one will have to try to remember how he did that in the future. But again, just a very neat case. And I'm not sure we've had too many PFOs that have been sort of winners in this category. But no, so it's good. Anyways, I just want to congratulate all 3 winners, and looking forward to when they're going to come with all of your support. And that's going to be on the next slide.
Yeah, I'm going to say 2, 3 words, Mark, and I would be really happy if you would say the final words. Prepare yourself mentally, if you agree. So I think as mentioned before, I would like to thank you for being here. Yesterday we had a social event, and I felt, I'm not a politician, don't worry, but I was walking around talking to people, and talking to many of you, and hearing where you're coming from, what is your background. It's amazing to see people from really the most amazing places coming here. So a lot of people have left, but as this is a event that will potentially stay, they can always watch it streaming and see how we thank them while they're back at home. So I think that's, this is basically the meeting made by the people. I said to people yesterday, this is not our meeting. We provide the environment, we provide the logistics, and then it's your turn to go ahead. Of course, if some things go wrong, we have to pay we have to be a referee. We have to say, this guys, this is the way it's going, and not others. Faculty and case presenters, that was great. The faculty, the challenge also, as told people yesterday, when you organize this kind of meeting, you feel like a musician that he's making a new record or a new album is coming out. And every time you try to make it a good album, a good edition again, this is what we try to do. And we always try to keep the p-values away, but we want to hear philosophy. I think if we apply everything that was said over the last 3 days, medicine, from a human perspective, would be a better world. We would get along much better, I think, and we would live much happier. So thank you to all of you, to the people here, to the faculty and the case presenters, and the faculty, of course, and the industry, of course. What will come next? So this is a biannual meeting, basically. So the project at this moment for 23 is to probably do something trans world. That means that, I'm sorry, not physically, but I think we need to take some breath, and there will be, we project a big event, hoping that 2024 there will be less inflation. It will be still conceivable and not considered as a crime to fly from an ecological perspective, and we'll hope that there will be a better place and that we can have a meeting. So something, probably pure virtual, and then in 2024 a real meeting. So I would like to give the final word to you, Malcolm, to conclude this meeting.
So this is classic, Eric. It gives me about 2 minutes warning here. I just want to thank you all, and as Dr. Kern said yesterday, and I feel the same. This is my favorite meeting to come to, and as Eric was saying, to meet and talk with you about where you've come from, what you're doing, what the challenges are that you feel, just to learn something about not just what your practice is about, but the culture and the challenges of your countries. And I was just reflecting there that I don't think there's another meeting that I go to that I'm approached by so many people to talk about their cases, or just the way that they're practicing, their colleagues, and all the challenges that they have. So again, I want to thank you. And as Eric said, this is your meeting. But the person we haven't really thanked, of course, is Eric. And Eric, I'm going to share something that I didn't know about him until a few years ago. So he brought this, again, this is just all coming off the top of my head. The door's locked, you can't get out. And that is that when Eric was much younger, you were an underground music DJ and broadcasting in the middle of the night, all sorts of music. I mean, you brought up the music analogy there. So if you didn't know that about him, it's really fascinating. So let's just stay on that theme as we finish here. This meeting, as I said yesterday, is the premier complication meeting for interventional cardiology. There's no question. That was Eric's vision. And as we think about that musical analogy, let's just think about this. Eric is the producer, he's the director, he's the composer, he's the conductor, he's everything. And I just want everyone to put their hands together and thank Eric, because without Eric, this would never have happened. And it's been going on for 20-odd years, and I hope for many more years. So Eric, thank you so much, sincerely.
Free to go.